Thank you, ma'am, for your presence. Now I may call upon Professor Dr. Ajay Jana, sir, President of IADBL Odisha. Sir, please come upon the stage and join us. Dr. Gaurav Das, sir, Secretary of IADBL Odisha. Sir, please join our dignitaries. May I request Dr. Manas Ranjan Puhan, sir, Chairperson of the Workshop Committee, and Dr. Debjit Kar, sir. Please come upon the stage. Dr. Gaurav Das, sir, Secretary of IADBL Odisha. Sir, please join our Dr. Subhanshu Sekhar Patnaik, sir, Joint Organizing Secretary. Sir, please join us. Thank you, sir. Now I may request Dr. Reshma to present bouquet to all the dignitaries present. Now it is the time to start the proceeding of our program by lighting the lamp. I may request all the dignitaries present aboard on the dais for this auspicious beginning. তারপরে না Thank you, sir, for such an auspicious beginning for our academic. Thank you, sir, for such an auspicious beginning for our academic endeavor. Now I may request our esteemed Chief Guest, Principal and Dean, Professor. Now I may request our esteemed Chief Guest, Dean. Hello. That was an auspicious beginning for our academic endeavor. Thank you, sir. Now I request our esteemed Chief Guest, Dean and Principal, Professor Datteshwar Hota sir, to share a few words of enlightenment.
Good morning to all. Professor Mahanti, my friend, Dr. Manju, our colleague, the dignitary from the dais and of the dais. In fact, it is a privilege to me that I am standing before you and becoming part of the workshop of the QTCon. I have been told about it quite long back. Gradually it took a shape and today we are here for the workshop. I can see the very advanced gadget displayed in the front of the dais. So I am very conscious about this gadget because I have been using this gadget for a pretty long time. You know, as you know, urology, the fraternity to which I belong, is one of the most advanced specialty, or you can say super specialty, in medical science, where we have been using laser, I think more than 2.5 decades. 25 years down the line, we have been using laser. And you know the evolution of laser. I am conscious about the fact also that dermatological use laser is not the laser that we use most of the time. And our laser has gone real ramifications, modifications Now we are using thulium as well as we are also using the green lighter, the PVP. And as all you know, it is wavelength that matters. And since you belong to a specialty which deals with the biggest organ of the body, I did not say about the dimension of the organ, but your department is visible on everybody's. This is the department which everybody can see. Nobody can see kidney. Nobody can see ureter. Nobody can see bladder. And keep aside what they can see, everybody likes to hide it. The other area that I deal with, genitalia. Nobody would like to display it. Barring that genitalia, rest skin are very obvious and visible. So your visibility is there everywhere. And dermatologists per se, there's a beautiful saying also. A person like, friend like Dr. Prasenjit Mahanti, he joined in dermatology when we all decided to go for medicines and surgery. I asked him, why you want to go to dermatology? Because there are a lot of disadvantages in dermatology. No, the answer was, I want to start from scratch. This, the word is so familiar with dermatology. People come to you, I am having scratching. So he wants to start from scratch. And he is one of the most handsome persons in our batch. And I have complimented all along. He said, I want to become a dermatologist because I will go for skinny genes, which others may not get. So these are the few things really lured him if I go to dermatology. And many a time I joke about him, saying the fact that, you are going to a specialty. At that time, it was not that developed as it is today. So at that time, when I asked him, this is the best part. Patient will be remaining much away from you. You will not be coming in touch with you, contact with you. You don't have to examine. A diagnosis at that time. You do from a distance, you treat from a distance and keep the patient at a lot of distance as far as possible. I'm Odiare Koutulu. Kon hochi na kunde hochi. Acha, e molam ta ne loga ebong logouta. So this is the lighter vein we are discussing. But what it was then and what it is now. We entered into our post-graduation in 83. And now you see what the transformation has taken place in every field of medical science, looking to dermatology. We say dermatology. Now, if you look to the NMC or MCI terminology, dermatology, venereology, and leprology was the earlier one. So now it has been combined together. Now, DVL they used to say at that time. Now, this is a specialty. Everybody is lured. When we are appearing our entrance in 83, the best of the students were going for either medicine or the surgery. They were thinking these are the royal subjects that we have to take. But now, the demand for dermatology is the highest. Nobody think of surgery and medicine. The transition. Now people say dermatology, radiology are the number one and number two for a budding person, budding student who wants to do his post-graduation. So this is the magnitude. This is the magnitude of the dermatology department providing the care. There has been transformation over the last 2 decades, particularly. And to add to it, a dermatologist, as per se, he looks after the whole skin of an individual. And the skin is the biggest organ, as I mentioned. Anything at any point of time of any part of the skin can go disarray. And at that time, people realize the value of the skin. As the individual grows from childhood to the elderly to the old age, the most neglected part is the skin. The culture do not tell them, the tradition do not tell them how to maintain the skin hygiene. Now, when a person is ill, then only he realizes the value of the skin. So, obviously, with the modernization, with the advancement, with the gadgets that is coming up, as quickly as we are trying to develop cosmetology and some reconstruction also.
there are many overlapping areas where you work with the plastic surgeon as well. Now, simple thing that since my this butterfinger converted to a surgeon's finger, I have realized this scar is a big challenge to a surgeon. Scar, keloid, all those things are a big challenge to the surgeon. And we had no answer excepting just injecting some Kenacot. Beyond that, we had no knowledge. Now there are a lot of surgeries coming up to tackle the scar, the keloids, and more so when we are talking about cosmetology. The cosmetology has really progressed like anything, and few reconstructive surgery. Those things has made a lot of differences. Now dermatologists who were thinking of distant diagnosis and distant treatment now have started touching the patient for the benefit of his contour, for the benefit of his look, and for the benefit of his personality. So it has added a lot of dimensions to a dermatologist practice, and I'm pretty sure the dermatologist of the day will make the best use of the technological advancement, which we are going to have a display today. And I'm sure this workshop is definitely inspiring for the students. And these students who are in dermatology, as I have always been telling since I have taken over, dermatology has to come up more than what we have in our institution. I know there are deficiencies, but our effort has to be more. The dermatologist should come to a pinnacle in SCB. Everything is coming to a pinnacle. Why not dermatology? It is you and the budding dermatologist who can make the difference. With these few words, I expect this workshop to be really contributory and really beneficial, enlightening to one and all. And I wish the workshop a grand success. Thank you all.
Thank you, sir, for such inspiring and enthralling words. Now I may request our HOD, Sir Professor Dr. Prasanjit Mohanty, sir, to share a few words. Thanks.
Thank you, Dean and Principal Professor Dr. Hota, for those enlightening words and such words from the past. I think I remember them also now very clearly. 30 years back, he had told me that. So, first of all, good morning to all of you. I extend a hearty welcome to all of you for this dermatological and dermatosurgery and laser workshop today. And I'm extremely pleased to have this workshop at SCB Medical College by the grace of our Dean and Professor Dr. Hota for his encouragement to have such workshops here. He has always been a supporter and motivator of having scientific sessions, workshops, and academic meets in this institution. Thank you, sir. And I hope all of you see, learn, and implement what you learn here in the future. Thank you.
Thank you, sir, for your kind words. Now I may request Organizing Secretary Dr. Manjulata Das ma'am to share a few words.
Thank you, sir. Thank you for your encouragement words. We feel proud for that. Now it is my turn to welcome all. A very good morning to one and all on the glorious day on behalf of organizing committee of the annual state conference of dermatologists of Odisha. It gives me great honor and immense pleasure to welcome you all to the inaugural ceremony of the workshop of 40th IIDVL Odisha Cuticon being held at our SCB Medical College Auditorium, the premier institute of our state. The workshop is based on basics of dermatosurgery, medical cosmetology, and lasers. Has been organized by IIDVL Odisha and Association of Cutaneous Surgeons of India. I take this opportunity to welcome our esteemed dignitaries on the dais. I welcome our vibrant and most dynamic Dean and Principal Professor Dr. Doteshwar Hota, our chief guest of this function. I extend my heartiest welcome to our energetic and charismatic organizing chairperson, Professor Dr. Prasanajit Mahanti, on this occasion. I would like to welcome our state IDBL President, Professor Dr. Ajay Kumar Jena, and Secretary Dr. Gaurav Das. I warmly welcome our efficient and dedicated workshop organizing chairperson and secretary Dr. Manas Ranjan Puhan and Dr. Devjit Kaur and co-organizing secretary of Cuticon Dr. Subhranshu Shekhar Patnaik. Last but not the least, I welcome all our esteemed delegates of the DAS whose presence is indispensable for the success of the workshop. This pre-conference workshop is materialized from the idea of providing hands-on training of our postgraduate students in the rapidly evolving field of lasers and dermatosurgery under the able guidance of renowned dermatologists of our state, many of whom are proud alumni of our institute. We have also organized digital interactive video sessions with dermatosurgeons from across the country whose experience in their respective fields can improve our knowledge and understanding. Man has always aspired for healthy and youthful skin, and the advent of modern technological advancements have taken us significantly closer to it. Hence, today, along with a solid grasp of clinical dermatology, sound knowledge and skills in the fields of laser, medical cosmetology, and dermatosurgery is inevitable for the budding dermatologist. With this workshop, we hope to open the vista into these evolving fields to enhance our knowledge and guide us further. We hope these sessions will enlighten our students, bolster their skills, and spark their interest and confidence to guide them further to greater achievements and it to their armory of dermatological practice. I must express my heartfelt gratitude to all our delegates whose invaluable presence is necessary for the success of this workshop, and to my organizing committee members whose untiring and dedicated efforts in spite of time restraints has brought us this day. Once again, on behalf of organizing committee, I welcome you all to this function. I wish all the success of the workshop. Long live IIDBL. Thank you.
Thank you, ma'am, for your kind and affectionate words. Now I may request Professor Dr. Ajay Jena, sir, President of IITVL Odisha, to come and share few words.
Good morning to you all. Respected dignitaries on the dais, my teachers, seniors, colleagues, friends, and students. At the outset, I would like to welcome you all for this workshop of dermatosurgery, mainly lasers. Sir, Dean sir has already told about the evaluation of our subject. I fully agree with him. Now the subject has changed to this new gadgets and then, but for learning of the students specifically, what you learn is one should learn that academic excellence. What is that? Whatever you learn, you have to apply to the patients. And these kind of workshops, they give you a hands-on experience to apply that. Unless you do whatever you learn to the patient or benefit the patient, your learning is not that much valuable. Second is, nowadays, you have to learn the basic dermatology. The new focus of the system, new generation, they have been shifting from the basic dermatology or core dermatology or clinical dermatology to gadget based or cosmetic dermatology. But we see many now complications of these gadgets. So these workshops will enlighten you or make you aware about the dangers of the gadget which you are going to use on your patients. So I hope this kind of workshop will help one and all to learn the finer aspects of these gadgets. So I sincerely thank the organizing committee for conducting this kind of workshop and hands-on training for the postgraduates. And I wish that this workshop should be a great success. Thank you all.
Thank you, sir. Now I request Dr. Prasanjit Mahanti sir to felicitate our chief guest of honor, Professor Dr. Datteshwar Hota sir.
I just came in to say that I cannot have the honor more than what I have today because I am honored by one of my dearest friends. Thank you all.
Thank you all the Thank you all the dignitaries for joining us in this incredible learning opportunity, and I hope all the delegates across the state will rejoice this academic feast. Thank you. Now I request our organizing secretary, Dr. Subhanshu Sekhar Patnaik sir, to give a vote of thanks.
Very good morning, everyone. Very good morning, everyone. I've been entrusted with the responsibility to acknowledge all our dignitaries over here. So at the outset, I would like to thank our chief guest of the morning, our Dean and Principal, Professor Dr. Datteshwar Hota sir, for his constant support and cooperation in hosting this event. I extend my heartfelt gratitude to our organizing chairperson, Professor Dr. Prasanjit Mohanty sir, for his vision and persistent guidance in making this workshop possible. I'm deeply grateful for our organizing workshop committee members, Dr. Manas Ranjan Puhan and Dr. Debjit Kaur and other members whose untiring, enthusiastic and proactive efforts have given life and form to this event. I would also like to acknowledge and appreciate all the academicians over here who have joined here to share their knowledge and to learn from each other. And also I'd like to thank our IDVIL president and secretary who have been here and made this function possible. And at last, I would like to thank all the delegates who are participating over here for learning in the workshop. So with this, we come to the end of the program and we are going to start our workshop now. So thank you. Thank you very much.
Hello, hello. How's it?
Hello, hello.
Hello. Hello. Hello.
So good morning to all of you. So after this encouraging words by our guests and dignitaries on the dais, now we will start the demonstration of the laser procedures. To start with, I request Professor Dr. Vikas Ranjan Kar to start with live demonstration of IPL. So I request her to come to the stage. Hello. 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 Okay. Okay. Should we start? Mana, should we start? Okay. So good morning, all of you. So we'll start with IPL. The message is clear. because it's a non-laser and we must try a non-laser device before we land up or go and settle exercising with a laser device. Why this is a non-laser? Because as far as the definition goes, a laser machine should emit some rays which are coherent, but it is not coherent here. So you have a wide spectrum of lights coming. This is from the infrared end, means the lower end of the visible spectrum, the UV ray, up to the far infrared rays. So you have a wide spectrum of coverage, unlike the other machines. Say, for example, you have diode laser, where you have a specific wavelength of 810 nanometer, or you have Q-switch ND-YAG, where you have a specific wavelength of 1064 or 532 nanometer, or for that matter, you have simple CO2 laser, where you have a specific wavelength of light being emitted, that is above 10,000 nanometer. So here we have an amalgamation of all the wavelengths, and the only purpose is to put the machine in such a platform that probably this will be something like a jack of all trade but master of none. You have lot many indications. So for a beginner, if you want to start your practice, maybe immediately postgraduate, after post-graduation, so this is probably the ideal device, because you can cater, this machine can cater to a lot of target audiences or target patients, in the sense that you have multiple indications which is incomparable to other indications. Say, for example, you have the machine is a diode laser. You can do only one indication with that, only hair reduction. But with this machine, you have 4 filters which come as a part of this machine. There the wavelengths are specific, though it is not a very narrow spectrum wavelength, but you have wavelengths targeting pigment, you have wavelengths targeting hemoglobin, you have wavelengths targeting hair, and you have another wavelength which targets propionibacterium acnes. So 4 indications are very clear cut. You can start with to begin with this machine. So you can treat acne or acne related indications. You can do hair removal. You can do a lot of pigment related indications, asthma, or maybe topical steroid damage face, where you have a combination of both. You have pigmentary changes as well as telangiectasias. So lot of indications with this. So probably this is the ideal machine if you are on the way to start your practice, where you cannot probably invest in very high-end or niche setups like a simple dedicated diode or simple dedicated Q-switch ND-YAG or fractional CO2 laser. So in that case, this is the ideal machine. There are few parameters. Before you learn any laser device, there are 5 parameters we must make it by heart. One is the wavelength. So wavelength means the light that comes has to reach a target to show the effect. So that is the wavelength we are dealing with. Suppose, for example, it all depends on the chromophore where it hits, whether it's the melanin or whether it's the hemoglobin in the vascular channel, or it's the collagen, or maybe for that matter it's the, in ablative cases you have water as the molecule. So 4 major target elements has to be hit to have a clinical effect which is visible. So wavelength is very important. Second thing that we should know, or that is a must, is the spot size and the power. Combination wise they are called as spot power density. So you should have the idea about the spot size. The smaller the spot size, the lesser is the tissue scatter and lateral damage becomes less. So the more focused you are. So you must have a rough idea what is the area of my treatment, what should be my spot size, what should be the power I should deliver to the target tissue. The major aim is hit the target, spare the surrounding tissue. So that means the lateral tissue damage should be minimal with your device. Otherwise, what you will do is, instead of removing one hair, you may remove one hair, but the surrounding skin will be charred. So in that case, probably the complication outweighs. The next thing that matters in a laser device is, first one is the wavelength,
Second one is the power density. Third one is the pulse width. Pulse width means the tissue is exposed to the energy eliminated or released from the device for a particular moment. The moment you put press or hand press the switch, the tissue is hit with sudden energy. So that amount of time for which the energy, the tissue is exposed to that energy is called as pulse width. So pulse width is also related to what we call as thermal relaxation time. So the moment you are giving energy to your target tissue, the surrounding tissue is also exposed to some energy. So the time taken for the target tissue to come down with the radiation of the heat to the surrounding tissue, which the time taken to release 50% of the heat to the surrounding tissue is what is defined as thermal relaxation time. So we must be very sure what is TRT for our indication, because that is very important. We want to save the surrounding tissue, which is of paramount importance in case we are dealing with some cosmetic indications. Otherwise, probably there will be complications. The last one is cooling. So any energy device we are dealing with, one of the most important thing is to save the surrounding tissue from getting damaged. Suppose you are targeting the underlying collagen. Our purpose is to do a photo rejuvenation or say tightening or something. In that case, our main focus is on the collagen and we do not want to injure the epidermis. So in that case, the epidermis has to be cooled to sufficient extent so that whatever energy the device releases, that reaches the collagen layer or the deep dermis, sparing the epidermis. So that means the epidermis has to be spared. Otherwise, what you will end up is a burn. So instead of getting the optimal effect by deep hitting the collagen, will also land up in the epidermal burn, which is frequently seen once you start doing the things as a novice or maybe as a amateur. So you should be very clear. So that is how overcome all this. We must practice things, set parameters, because all these machines are probably built as per the Western standard. We all read that lasers are suitable for type 1, type 2, type 3 skin. So we are nowhere near those type of skins. So for us, the most important thing is we are rich in melanin. So that is one of the advantages as well as disadvantages, because the indications are cosmetic and we are dealing with a darker type of skin where melanin is plenty. So probably all the melanin related adverse effects are also plenty if we are dealing with this kind of machines. So we must be very much well versed with the indications. So one thing is, another point where we come across in routine life is our skin tends to tan frequently. So if we tan frequently, suppose in the morning the patient has taken appointment for the evening clinic saying that, doctor, I want to come for a photo rejuvenation or maybe acne reduction with IPL. So you have given a time. The patient went to play cricket throughout the day and maybe evening he comes. By the time he is tanned, you remember giving the parameters last visit and you start to use the same parameters. Suddenly the same patient burns. So that means tanning has got a detrimental effect on the skin type. So we must be very sure about the type of patients we are dealing with. And in our first or counseling session, we must counsel the patient regarding that as well. So coming to this, as I told you that we have 4 major indications, we have 4 filters in this. So the wavelength emitted by this spreads from 400 to 1200. It's a very large wavelength and probably it will deal with all except part which is taken care by beyond 1200. So we have Erbiomag and we have CO2 laser, which are in the ablative range because the chromophore or the target is water there. Whereas here we have a broad spectrum wavelength 400 to 1200 and our main targets being the porphyrin released by Propionibacterium acnes. We have got a filter for that and you have 4 filters. They are numbered here 530, 480. There are 2 more filters. One is there inbuilt. This is 640 and one more 610. 590. So some machines provide 610, some machines provide 590. They are all near to certain wavelengths. So if you see 530 probably is nearer to hemoglobin wavelength. 480 is very close to porphyrin by propionacnis, and the other ones like 640, 590, they are more close towards melanin. So in that case, even 590 is also close to probably hemoglobin. So you can overlap that. And 610, 640, they are more close to the diode range or 800 range, where you can use that as for hair reduction methods. So these are filters. That means once, yes.
Sir, how it works, sir? Actually, this is a filter, or this is filters that beyond this, there
That's
will be
what.
no further.
Once you put this, you have the machine releasing entire wavelength, but the other lights are filtered, so only this wavelength comes out. So that means this 480 or say 530 will only hit the target. So that is a specific wavelength. But unlike others where you have a group of coherent energy releasing system, here that is not coherent because you have entire range, right? So there the light source itself is monochromatic and coherent. Here that is not. So the indications, ask for the indication, you need to place the filter in this. You have a handpiece here. You have a handpiece. You have to use as per your indication. There are this socket where you can fit it. You have 4 filters. So suppose your indication is here, and nowadays the machines come with a very user-friendly software. So if anybody is interested, you can come here and can use it yourself. The machine is such that once you switch on, it will ask for what type of skin you are dealing with. You have to feed in that type 5, type 3, darker skin, brown skin, white skin, like that. So you can check that yourself here in the machine and feed whatever is your patient fits to. Next is, what is the indication the software asks? Suppose you are dealing with acne, or you are dealing with melasma, or you are dealing with hair reduction or telangiectasia, then you have to key in that parameter. So once you put that, then the machine gives you option that what kind of filter you want to use. So there the machine suggests few filters, and you have to put the nearest filter for that, right? So in that case, if you are beginning for the first time, or as I told, suppose you are doing a photo rejuvenation and you feel that the skin is little bit darker than what the machine opts, then probably you can give a lower energy to prevent a burn. So always better to give a lower side of energy than doing a burn in the first visit. So that is the ideal situation, because we do not know how the skin will react. So in that case, it's always go. But the long term, if you're, there is something called as paradoxical regrowth of hair with IPL. So in that case, suppose each visit you tend to do a low energy setting because you are afraid of inducing a burn, then in that case it is seen that it can induce hair regrowth itself. So you have to make sure that probably first visit you tried your hand, second visit you know how the skin is behaving. So you try to reach to the nearest energy level that should be effective, not that I'll just fire few shots with low energy, because low energy itself is a trigger for hair regrowth. So this term is there in the literature.
Do you go for a test patching first?
Yeah. That's what the machine gives you option. Suppose you key in all your parameters, it comes as 13, 14, 15, some parameters. What you do on the first visit, you usually come below that and give, because there are still, suppose I am wearing a half sleeve, I want to do it here, then probably this area will require less energy than this area because that is sun exposed, right? So if you are planning for this area and machine suggests 14, you can go to 12 and give a shot. Yeah, yes. So the optimum feel that the patient gets is something like a snap of a rubber band, which is expected from the patient. You can ask the patient how it feels, because if you are giving, suppose in place of 14, you are giving something like 20, it will burn, and the patient will say that the entire process was painful, and what you get is maybe within half an hour you will get a large blister over the area where you have shot. Okay, so first is the importance of a test patch. For any laser, that is true, whether this is a non-laser device like this or any single wavelength laser you are using. You always use a test patch. Do a test patch in the patient and follow that for 2 to 3 weeks. See the response. Immediately you see, look for the side effects. If there are none, then probably at least you are sure that I have not done any burn to the patient. That is very important. That is the only major disadvantage with any kind of laser.
And sir, cooling is also very important in this.
I told you there are 5 parameters. I was just coming to that. Cooling is very important. If you touch this, this is now very cold. Here there are gradation of cooling as well in the machine. You can set it like 1 to 5 range. You can set it to the highest parameter depending on the area. Cooling is very important to minimize the burn, and you must make sure that the tip is chilled. So there are 2 types of coolings available in various devices. One is a sapphire based cooling like this. Another is a water system, water cooling, which runs inside the handpiece. The moment you press it, the water runs and you get around 4 degrees centigrade. That is something like the door of the fridge. But sapphire cooling is something, there is another type where
So this machine is a combination, water plus.
This is a combination. This is a combination. There is another method where you have to spray something like Freon. You have to like histofreeze. You have to freeze it, then fire. So it depends which you are more well versed. Nowadays, most of the machines come with inbuilt. So the moment you switch it on, the tip here, it starts to cool. So you just check it. What is the temperature like? Once you are sure that this is chilled to the optimum level, you can start to fire. So this is very important. Okay. Anything else?
I think ice is also very important. Post procedure, you can put ice.
One more thing is you must protect yourself as well as your staff's eyes during the procedure. They must use a protective eyewear throughout the procedure. The patient's eye has to be blocked because these rays are going to induce various damages to the cornea as well as retina. So those areas should be thoroughly blocked.
Because this is in a visible range, so all the lights actually go up to. So this is one device which can damage the retina also.
So that has to be blocked. Never be very heroic to do without any ocular protection. And the next step is you have to explain the patient what you expect out of the procedure. So say for example, acne. If you are doing it for acne, it is effective only for very active grade of acne, say 2 or 3. And if you have papulopustular lesions, then that is the stage where it should be ideally used, if at all. Though you have other modalities and you want to try this, then papulopustular acne is the best because there you have the maximum concentration of Propionibacter acnes, which tends to release the molecule of in the wavelength of porphyrin. So that is what is the target for this. So that is one. If you want to do melasma, then never overpromise the patient that I will cure your melasma. Try to undertreat and try to combine with other modalities as well, because melasma is a very challenging stuff. Third, if you are doing it for hair, then you have to have all your sessions spread over entire 1 to 2 years. On your first visit itself, you counsel the patient accordingly that I'll space my individual sessions say monthly or once in 6 weeks, and probably will start. What the patient notices initially is not a drastic reduction of hair, but suppose the patient used to do some home-based removal of hair on his or her own, then the gap between 2 sessions of those home-based removal will increase. So that is how the patient comes to know that every 7 days I used to pluck or remove my hair, but now I am doing it once in 3 weeks. So that is the first feedback you receive from the patient. Like that, you have to say that it will take a long time. At least 1 hair cycle has to be covered, which varies from something around 4 months to 1 year. So you tell the patient, depending on the body area, at least 1 year time is required for that. After that also, what you get is a hair reduction. It's not a permanent hair removal, and that has to be maintained. So once in 3 months or once in 4 months, that has to be maintained. You are not promising a cure for that. So that is very important.
Sir, other indications like stria and facial rejuvenation?
Facial rejuvenation is in fact the indication for which this started doing business. So this is in fact for type 1, type 2 and type 3 skin. This does wonder for facial rejuvenation, and that too in a non-ablative way, which is very patient friendly. So instead of going to classic tested modalities like fractional CO2 or erbium mag, you can do this. This is, I told you, this causes collagen heating. So that is something like it. As if you are changing the filter to the pigment mode, then this also has a effect on pigment dilution. So if you combine both, then probably you can achieve optimum results. But facial rejuvenation for type 4 and type 5 skin with this machine is a bit challenging. So you have to be very sure before you do that.
So what is the maintenance of the machine? Like
what is the
maintenance, consumables of the machine?
Consumables hardly any, except probably you have to check the water level frequently. And
almost every month you have to check the water level.
Not every month, you can check that. What is the water level? You just, I don't think it's every month. Once in 6 months is also fine.
Depends on the use only.
Depends on the use. So the more it hits, the water will flow more and it will be evaporated more. So depending on the usage, you replace the water, whatever you use.
So what is the difference between this tabletop model and the tower model?
The power output is definitely more here. You can, suppose you are a professional user, you want to use it, tweak it like a DSLR and a mobile camera. The difference is like that. So you are using a DSLR, you know what is the focal length, what is the camera, telephoto, zoom, or it's a portrait mode, whatever. Various modes are there. So you can do that kind of a tweaking with the professional mode. But there it's something like a mobile camera. You have settings preset, you just click it and that's all. You cannot go beyond something. The software is such that you cannot go beyond that. Here you can tweak all the parameters. So that is the major advantage.
And sir, finally the cost of the machines ranges from.
They can tell you, I brought this some long back, but that time it was around 3.5 lakhs. I do not know what is the cost now. Maybe it has gone down.
So it's always a range. So it is somehow starts from 3 to lakhs to around 20-25 lakhs.
Of a good brand should, yes,
around
it can
60
go up to
lakhs
30-40 lakhs. So it all depends what you want to invest in.
So as it is confusing because if some machine starting with 3 lakhs and goes up to 60 lakhs.
I brought this from long back.
Duplication.
Sir, I wanted to ask what are the common causes of burn? I mean, you told burn, you may burn the patients. Sir, when you are using this IPL, sir, what are the common causes of burn?
Common causes.
Yes, sir.
Common causes. You should be well versed with the machine. Like I told, suppose the machine you have done in 4 or 5 patients, you know that probably 12 to 15 is the safe range. And all of a sudden you want to try that, no, I'll go with 18 and I'll probably tend to do hair reduction faster. So in that case, that is over enthusiastic approach, that will burn more. Second, the one I gave example is from my own experience. The patient went to play cricket, in the evening he came, I fired 2 shots and he landed up in burn. So you must be very sure that the patient is not grossly tanned. Okay, so beforehand you prescribe him adequate sunscreen, sun protection behavior, and then say that you come in the evening, I'll do it. Right.
And also room temperature also and post procedure cooling is very important.
Cooling during the procedure as well as post procedure is important. Next is probably if you are doing something, suppose you are doing hair reduction in the lateral side of base and you have long hairs. Long hairs means the energy will flow along. So there are reports that along the hair there are burns. So you try to trim it before you fire.
Even if burn occurs, sir, how do you treat that complication?
Like any other burn, because like it's superficial burn. You are not firing a very high energy, like it won't go full depth. It's like the policy is wait and watch, counsel, make it cool, as well as make the patient cool. So it will take some time. PIH will be there because that is more common in our type of skin. So you have to use some hydroquinone based creams later on, along with adequate sun protection.
Thank you, sir.
And sir, once PIH, we should not go for the second session. That is also very important.
That is true.
Otherwise, you will have
you can go something like, suppose patient develops methotrexate induced toxicity, that doesn't debar the patient from further methotrexate exposure. He has overdosed himself. So that is the problem. But if you are spacing the doses rightly, it's unlikely that he cannot tolerate it.
Sir, for the hair reduction, what are the other devices available? We have
apart from IPL. We have diode, we have long pulse NDI, so many other devices are available. For Indian skin, what is the most tested nowadays is diode. There are loopholes in all. It's not that one machine is perfect. So we cannot say that diode is the best or long pulse is the best. We cannot say that which one is the best. We'll learn it out of your experience that, but yes, the rapidity of hair reduction is probably the best with diode. With all the machines, we have 3 major machines available today, but there is a study which clearly delineates that at the end of 1 year, probably the amount of hair reduction is almost equal with whatever devices we have. So to counsel the patient, you can say that probably after 1 year, whatever machine you use, you can have almost similar kind of experience. But if you want to get rid of the hair first, then yes, you go for diode laser, and maybe at the end of 4 to 6 months, you have significant hair reduction.
So we are having another demonstration of diode. So we'll go for the Q switch first, then we'll go for the diode.
Yeah.
So can you put one short works so that everyone?
This is without eyewear.
Sir, the filters again, sir. 4 filters are there, sir.
Yeah.
Sir,
We have 640, 480.
There are other filters are also available.
Between also your filters. Suppose you want to very come down to the nearest possible parameter, you have filters available. Suppose you are treating a port wine stain and you want something around 570, 580. Those filters are also available, but optional. They do not come with the machine. You can get them separately.
sir, that inflammatory acne, which inflammatory?
The lowest one, the 480. That is. So you have 2 methods to fire this. Okay, this is a hand switch here inbuilt. So once you put that, the area is chilled. Then you fire this. Once you press this, on karo. So once you press this, the fire comes. Or what you can do is you can put it on the skin and fire from the foot. Foot device is not linked. So, okay, some problem may be, but you have 2 options. You can use either.
And regarding the protection eyeglasses, there are different type of glasses. For IPL, we are having different type of glasses because
Yes.
you want to protect from the natural light. For Q-switch and different type of glasses. So for every lasers, we are having different types of eye protection glasses that you have to procure with the machine.
What parameters we have to enter to find that energy here?
Actually, that parameters depend on the machine. No 2 machines is same.
Yes, that is
in
not
lasers.
standardized.
So once you buy, then you know the what parameters is useful for
So
your
in fact,
patient.
nowadays those parameters are missing from almost all the machines because that will ask you type of skin. So you say 1, 2, 3. So type 3 you have put. Then automatically that will come to a nearest parameter. So you have to tweak in that.
Madam is asking about the endpoint of the laser.
Endpoint is little bit erythema. You do not expect aggressive erythema, but for the patient this is something like a rubber strap hitting the skin. But what you see is mild erythema. So if you have a gross erythema, probably that will be blistering in coming days. So do not expect a very gross erythema. Mild erythema, and the patient feels that as if some rubber band has snapped on the skin. So that is the endpoint. It is more effective for terminal dark hairs. So this is true for all the hair reduction device, not necessarily IPL. So terminal dark hairs are the most responsive. If you have lanugo hair or if you have very thin hairs, they are not very good candidates. So the darker, the more the amount of the chromophore, that is melanin present, the higher the chance of. In fact, it is seen that you keep on doing this procedure repeatedly, at the end that there is hair thinning, the melanin amount goes down over a period of time. After that, there will be resistance. So that is why it is told that it is never 100%.
Some say chin hair, that is more resistant. This,
So that is distribution wise.
Because of the hormonal effect.
Yes.
But type of hairs, white hairs doesn't improve.
White
Vellus hair
hairs will
somehow
never
it will
respond.
improve.
White hairs will never respond.
that can go with carbon peel, but again it is a short-term procedure, like a for few days, then it comes back. Thank you, sir, for enlightening all about IPL. Now we'll go with the next device. I request Dr. Devjit Kaur to go for QC India.
Good afternoon, everyone. A warm welcome to all of you. So, we were thinking that how should we finish it off, but sir has made it easier and he has almost discussed everything about lasers also, because the basic funda remains same as sir said. I always compare the parameters that sir said of now as sir said, laser.
So we have to use 532 and we have reached 1064.
Where to use?
We have to 532
for epidermal lesions 532, and for mixed or dermal we can go for 1064, but for Indian skin 1064 can be used for almost all. Practically you can use it for almost all the indications.
For the tattoo we are using 1064.
Yeah, for tattoo 1064 you need. Now the marketing that these tattoo and all, that is how lasers were promoted, but they are not very common. What you get clinical cases, you get more. So nevus and freckles and lentigens, or even you can do for melasma also. So once you are clear with what the patient has, what is the indications, and you are ready with your machine, now adjusting the fluence. As sir said, you can go for a test patch, but after a certain time you know that what category of patient is coming, what is his or her skin type, and what is the energy. So normally after using for some time, you don't need a test patch, but it is mandatory. If you do, it is always better. So you know that at my machine at 17 joules, or I can start. So there you can start. So there is no question of burning. If you give these things to your assistant, then the chances of burning increases. Another thing is, we always try to fiddle with the machine and we try to increase the energy with every sitting. That is also a common mistake we do. So normally in high-end machines, or even in whatever machines you have, So within a very small range, you can treat, because normal skin type we get is from 3 to 5 in our Indian setting. So you can treat most of the things. Now, how does this work? So it works by photoacoustic mechanical destruction of melanin. So again, as sir said, melanin is the chromophore here. So melanin destruction is there. So photoacoustic and vibrational. So when you hit, as we will while demonstrating, we will see as you hit the target, there is a thermal damage to the melanin which is present in the melanosome, which is present in the melanocyte. So and that energy goes to the surrounding skin also. So as sir said that your pulse width should be less than the thermal relaxation time, so that there is less damage to the surrounding tissue. These things are now mostly automated, so you don't have to bang your head much that what is to be done, but although knowing the basics as sir said is always better. So that is the funda how it works. Now the new thing which has come is laser toning. So what is laser toning? Laser toning is subcellular damage you are doing. So here you are doing cellular damage in normal mode, but in laser toning you are doing subcellular damage. So here you are not destroying the keratin or the melanocyte, rather you are destroying only the stage 4 melanosomes. So very less damage to the surrounding skin. Laser toning has come as an indication for mostly melasma and facial rejuvenation, because if we use the normal laser mode in that, then there is chance of burning. So you can do the laser toning. You have to go for a bit lower fluence in that. As for example, maybe if you are using 20 joule, you go for a lesser fluence, maybe 15 joules, that you can use in laser toning, because nowadays lot of people are promoting these things for melasma, but as sir said that for melasma laser is always a third line indication. So creams followed by peeling and maybe after that laser. So if a patient is very inclined and you are ready to do, you can do with the laser toning method, not with the normal ones. Now how to know the you are doing it right in a right or wrong way? As sir said, the best person to tell you is the patient, that after a few shots the patient will tell you how he or she is feeling. So practically I don't use EMLA before any procedure, because this is not a such very painful condition where you need a EMLA. So you can do very well without that also. So how it is to be done? You have two kind of machines, active and passive. So as sir said that higher energy ones are these kind of things where you have to be more careful. The small tabletop models deliver less energy, so maybe a few more sittings are required there, but again the chances of burning will be less. Now Manas bhai rightly pointed out that the concept of cooling. So there is three kind of cooling: pre-procedure, during procedure, after procedure. So to reduce the tissue damage, surrounding tissue damage, cooling is very important. So as sir said, in diode laser, Dr. Lakshman will demonstrate, you have a cooling kind of thing in the handpiece itself, but a simple ice can also be used. So before doing any laser procedure, cool the skin, then hit with the laser, and then after doing also you cool the skin before applying any anti-inflammatory creams or that thing. So this is all about
difference between long pulse NDIAG and Q-switched NDIAG. What do you mean by Q-switched NDIAG?
Yeah, Q-switched NDIAG is basically how these lasers came up is that Q-switched NDIAG, the pulse widths are in nanoseconds. So that is how Q-switched, the meaning qualitative switched NDIAG laser.
Quality switching, actually long pulse NDIAG we use for the hair removal. So again it is thermal relaxation time. This is the energy is given only for the few fractions of second. So this is the difference between a nanosecond. Now we are having pico lasers. Pico laser is the laser light is given in the picosecond.
Even lesser, less than nanoseconds. So again less chance, more safety wise it is better. Safety wise it is better, and efficacy wise it is as good. So nowadays, as sir said,
this machine actually is a pico one.
Yeah.
But again, actually, even if the company people say it is a pico machine, actually doesn't give in the pico range. Always it is in the nano range. Only the high-end machines give in the pico range. But conventionally, they say it is pico range. Definitely better than the conventional Q-switched NDIAG.
So gradually, we are expecting in days to come, picosecond lasers will be what we will be getting in future. So normal will be out of vogue.
No, never try your hand for the first time on a melasma patient. the results are very disappointing. You'll be disappointed to the core. So never try your hand on melasma patient with Q-switch, because sometimes we become over enthusiastic and try whatever machines we have on our patients, and invariably we have landed in PIH. So that is not the indication.
I have never done for any melasma.
So that is not the indication at all. So what you can do is, if the patient is fed up and you have tried all the modalities, you can give an option that yes, we will try and see with this.
After the
but
consent.
I cannot predict.
After a consent.
I cannot predict the outcome. So if your outcome is fine with a test patch, then probably we can do the entire area. So that is how it should progress. Otherwise, you should be very happy if you get a case of affiliates of freckles or lentigens. That is the best indication, in fact, to get rid of those things.
This is what you get out of experience, that with experience you know how, where to say no. That is very important. And these patients who pester you for melasma, they will be the patients who will pestering you after there is some side effect. So you should know where to do, and if you are doing, how to do that. Take a consent and again do a test patch, see after 4 weeks. If the result is there, then go ahead, no problem.
And in the machine, actually the 532 and 1064 are the same machine, same energy. Energy output is same because it is comes from the same medium. Only thing is the tip, the filter is there. This is called double tip is the for 532, and single tip, the longer one is 1064. The wavelength is more wavelength penetrates deeper. So for the tattoo you need a 1064. For freckles and superficial lesion you need 532.
Bigger spot size, deeper, more energy, deeper. Again, it goes with more damage also. So you have to play with the parameters.
And in the active QC, you can adjust in the machine. In a passive QC, you have to adjust by giving the length, like distance from.
Another difference is when you are using an active laser, then you can do at a fixed depth. That is, you can directly touch the handpiece and do on the skin. But in a passive thing, you So when we used to do initially, we used to think that more the sound, more the effect. But it is actually practically it is you have to identify the medium sound which actually comes at 2 to 3 finger distance is the sound. So in this case, this should be perfect.
And here
Not
the
this,
chromophore is
not
melanin.
this, not this.
So the chromophore is melanin and our eye contains lots of melanin. So it is very damaging to the eye. So using a protective eyeglass is very important for yourself, patient and all the staffs also. Actually, that comes with experience. Normally we sit for like tattoo, you have to go for higher parameter. For the freckles, you go for the lower fluence. Then once the machine goes, like you are using the same machine for 3 years. So whatever result you are getting with 600 joules, now you have to go to 900 joules to get that result. So with aging of the machine also the power reduces. So all these things you will learn when you are having one machine. Because no two machines are the same. So all machine will have different. This is the difference between a high-end machine and low-end machine. All the high-end machine, the parameters will remain same throughout its life. But low-end machines, the parameter gradually goes up. So you after certain, like in QC India, after 1.5 lakhs or 2 lakhs, you have to work more than 1 lakh, you have to change the filter. That is the important.
And also, if when we used to do initially, suppose a large lesion is there. So what we will do is we do frequency of 6. So there is a drawback with that also, because you can finish it faster. Suppose this much big black patch is there, you are finishing it faster. But the drawback is your shots are also getting exhausted and the energy is also going down. So there is no alternative to patience. So you have to stick at the normal frequency only, like in this kind of machine 2, 3, not 5 and 6. So 5 and 6 will make it faster, but your more wear out of the machine, and in addition your energy also goes down.
Again, coming to the cost, each shot counts you the money. So in a private, if you are in an institution, it is different thing. But in private practice, how we count? Because each lamp is a specific lifetime. Suppose one lamp, one handpiece is giving 1.5 lakhs shots, and the cost is 1.5 lakhs. So then per shot is 1 rupees to you. If you are doing a tattoo of large area, you are putting 5,000 shots, then it is costing to you only 5,000 for that particular session. So you have to charge accordingly. So accordingly, you have to decide the financial part. And again, cost of the machine, running the clinic, all these things are there. So you have to decide the cost as per the machine you are using.
So for postgraduates, there is one frequent short question that comes in the exam. What is the R20 mechanism of tattoo removal? Right. So anyone who is aware of that? Yes. So that means instead of a unipass or single pass session at each visit, and you have to space between 2 sessions around 4 to 6 weeks, you can do multi-pass session in a single visit. So instead of doing that, so that this is called accelerated tattoo removal. So same session patient comes, maybe in 1 hour, you do 3 sessions, and the amount of endpoint that you want to achieve is definitely much faster with R20 mechanism. So within 20 minutes, that lateral tissue damage, whatever is there, it gets cooled off and you are ready to fire again.
Same thing you can do, madam, with moving the handpiece to and fro. So both the way you can do.
ये भी तो है.
So now we'll go for the what we have learned till now. We have finished IPL and Q-switched India laser. Now we'll go for rejuvenation part or the management of scars. For that, I welcome Dr. Monali Patnaik to demonstrate fractional CO2 laser.
So today, of all the lasers which are being demonstrated here, I want to say that fractional laser or CO2 is the one whose results are permanent. Rest all you need to do more settings to maintain the results. But whatever result you get with a CO2 or a fractional laser, that is a permanent one. So fractional photothermolysis is a revolutionary change in the field of laser resurfacing processes. The fractional techniques can be of ablative or non-ablative variety. The CO2 which we are seeing here is the ablative variety. So what is fractional? Fractional basically means it is fractionated. So instead of sending a direct high energy beam, we are fractionating it or we are pixelating it and breaking it into multiple equal sized, equal spaced, equal depth energy beams. So what these energy beams will do?
And ablative means we are directly burning the skin, and non-ablative means we are not burning the skin. Skin is not damaged or the epidermis is not damaged, only there will be heat. So this is the difference between ablative and non-ablative machine.
So ablative machines will damage the epidermis as well, then go deep into the dermis, but non-ablative ones you will not see any change on the skin surface, but the dermis is affected. So what basically we are doing here is we are all targeting neocollagenosis, either with fractionated CO2 erbium or with this tip which is a micro needling RF machine. So what we are creating with a fractionated laser is we are giving equidistant energy beams of equal energy. So what they will cause is they will cause a column of necrosis of epidermis below its dermis. They don't go much below the dermis. They will go up to mid dermis level. But what they will do is after you release that energy, they will create a MTZ. So MTZ is a microthermal zone, and that zone in the matter of 3 to 4 days will get completely necrosed and a MEND is formed. That is a theory that MEND means the necrotic debris which get trans-epidermally eliminated out of the skin. Now the main role is of the surrounding skin. So the surrounding skin, the good skin which is still viable, they will start forming the new epidermis, the new dermis, and this collagen which is being built new is the good collagen. So what now this collagen is more the direction is such that it will go upwards and break the adhesions which are below, and therefore this collagen is a better collagen.
And coming to the machine, so CO2 laser, here the chromophore is water.
The wavelength is 10,600 for CO2 and 1550 or 1560 for erbium laser. So for both these, the target is water only.
Water. So basically here in the Q-switched India, we are targeting melanin. In IPL, we are targeting the other pigments. And in ablative lasers, we are targeting the water. That means we are evaporating or heating the water to a very high temperature so that there occurs tissue injury. It is a controlled tissue injury. Once there is an injury, body will try to form new collagen, and that collagen is a good collagen which will give us a shape. This is called rejuvenation or the scar rejuvenation.
It is a controlled damage, and after that new collagen which is formed, that is also like therapeutic wounding. We are knowingly causing a therapeutic wounding.
So we are having actually two probes, one for the CO2 cutting laser, and this is for the fractional one. In the CO2 cutting laser, there is only one light comes that is used for making cuts during surgical procedures. Or
any kind of where you need RF or where you need surgical things, use that. But the drawback of using a
CO2 laser for cutting is always, your patients will always come and ask you to do laser because they love the word laser and we also love it. But actually, for many surgical procedures, laser may not be good because the suture, the ends of the cuts, they are charred, they get necrosed. So the healing is not good, what you get in a normal cold steel surgery. So in those cases, many times I prefer doing normal surgery rather than CO2. So basically, I asked a few people, some seniors, and they told that whatever you do in RF, those are the common indications you do in that ablative part of the CO2 laser. For fractional, definitely scar. Sir, do you think the result we get in scar when we do fractional CO2, is it permanent? Because I have some reservations.
In a sense, scar is a continuous process. So you are doing one sitting now, the changes will be visible even after 6 months because collagenation is a long process. So it keeps on happening in the background if you are traumatizing the deeper dermis today. It's not that you are doing it today and whatever is the end result today will be valid for 6 months. So it's a continuous process. So that is why never be in a hurry to repeat the second sitting. So give a sufficient gap, see the improvement and then do the second sitting.
Actually, what happens is that when laser, these corporates have brought about this concept of sittings. So there is no kind of, there is nothing called sitting. What is sitting? Nothing. So you decide accordingly what is the condition and आपको कितना gap में second sitting करना है. It's what they do. You need 6 sittings in 6 months. You pay this much. From there, this sitting concept is there. Now, why I asked sir about permanent? The permanent thing is you have to remember the person who has a scar has got a scar because he has a tendency to develop scar. So he will again develop scar. His skin will again try to like contract once again. So for this also, I have found that you need repeat sessions. So you can space it like in, this is something I am telling out of the book. So like hair removal, if you are telling that after 8 sittings, you come once in a year, even in CO2, we should tell, because what happens is that after 2-3 years, even the patient gets aged. So again, his skin collagen damage is there, natural collagen damage. And
but that
patient
is a different indication, not the scar which we have remodeled.
That level of tightness you may need. So this I think it is required.
And now coming to the Combi Machines. So the advantage of this machine is a combination of erbium glass, fractional CO2 and microneedle RF. But the advantage of combination machine is the cost will be less and it will take a less space in your clinic. But the problem is, any problem, suppose there is a water cooling system, anything happens, there is a water leakage or something, then all the machines are short. So now you end up with nothing. So this is the problems with the combination machines or the platforms. But if you are buying a very high-end machine, that maybe platform is good enough. But otherwise, individual machines are always advisable. But if you are having backup machine, suppose you have purchased one low-end machine, now you want to upgrade, then you can go for this type of machines because you are having an old machine for a backup. Because once you are in practice, you cannot say no to the patient because these are all need multiple sessions. After first session, you cannot send the patient to another doctor. So this is the whole issue. So that's why you have to plan accordingly while you are investing, because this needs lots of money. And this machine will create problem, and again you have to spend money on repair and all these things. And AMC, annual maintenance, all these things are there. So for all these things, you have to make the budget first before buying a machine.
Okay, so I'll show you how this laser is fired.
First, let me show the parameters. Can you focus this one? So here we are having, one is power, one is duration, distance, repeat times, and aiming. So the power is, the more the power,
so the superficial injury will be more. So if you increase the power, so the ultimate, you can see the here it is 10 watt and 3 millisecond, and it is 30 millijoule. If you increase the power, you can increase the millijoules, but the superficial injury will be more. If you increase the duration, the power will be millijoule will be more, fluence will be more, but you can go deep rather than doing superficial injury. So accordingly, you have to decide what type of lesion you are doing and for what purpose. Accordingly, you will decide. Then there is called distance, like to distance from two spots, and another one is repeat, like how many times it will repeat. Suppose with one press, it can repeat 2 times, 3 times also. And time, this is the number of repeats, and the aiming is you can go on increasing and decreasing. This is the light which is coming so that you can see the exact lesion and do the procedure. So now you can see how it works. You can see the piece of paper. Actually, you can see individually after this session. Each machine you can see individually.
Can you focus here? Somebody come here. So I'll show you on paper. So
Yes,
if you can see here, there is a square shaped.
Again, the shape can be changed in the machine. It can be made square, round, all these things.
And this is the maximum shape, I think.
Now see, it has become round, then it becomes a triangle, so again square. So some shapes are there only for jumlabazi, there is no use, and some shapes are actually needed. I am yet to get a use of triangle. Now, but how you can use that, I will tell.
You can focus on the paper.
Can you more focus on the paper? Close.
Yes. Ready.
So see, I'm going to fire this shot. So if you can see here, there is a grid pattern which is formed. There is a grid pattern here, where there are multiple, you can see these black dots. These are equidistant from each other.
I'll show in the camera.
So these are the MTZs, microthermal zones, and this is the area where we are causing the necrosis to happen or the therapeutic wounding. What will happen is in these zones, after 3 to 4 days, they will get necrosed. But the surrounding skin, or you can see the surrounding paper, which is white in color, this is having the reservoir of the tissue which will grow back to fill these empty spaces.
They
And
help
there
in
is where
healing. That
the
normal skin
therapeutic-
part will help in healing.
So it is a calculated damage and a predictable wound healing that will give
Now,
you the results.
see how when Monali did that paper, see how the shots are stacked very close to each other.
Very equal.
Now
equidistant.
again, this also you have to manipulate. So
You
what
have
we
to
can
adjust
do
according to the
is
start
if we
size.
increase the distance, then suppose we are making it 2. Now Monali, you do one shot again. Yeah. Now you see it is even more spaced. So again, depending upon the type of lesion you are dealing with, the type of skin you have to decide. The more closely they are stacked, the more damage. The longer the time it will take to like get back to normal. So again, this has to be also manipulated. So why I was telling you regarding DSLR is, so you have to play between these 3 parameters. So when the power, suppose a dark complexion person is coming to you and you need a deeper depth, so you increase the fluence, so it will cause more burning. So what you can rather do is you don't increase the fluence beyond this, you increase the depth. So in that way it will show you the total energy here. So in that way you have to play between the parameters. So there is no fixed thumb rule that this much 30 joule for this person, 40 joule for this person. You have to play between these 2 parameters. And distance, you can use it for normal rejuvenation also, increase the distance. So give few shots. So what it will happen? So in chemical peeling, laser, what we are doing? We are damaging the tissue. So do a lesser control damage at a much lower setting. Maybe we go for around 20, and we don't need more of depth. So we will make it around 1.5, and distance we can make it like 2.5. So this should be good enough for a rejuvenation. So you have to understand the parameters, and you have to know how to play with that use your laser to optimum requirement.
Yes, either. Gauge pad. Actually. By chance you open. चश्मा पिंधिले रहिबनी काढी दियो पुरा I'm holding
Hold it. This actually needs little bit of topical anesthesia.
your patient should ideally be sleeping position with goggles put on, protective
goggles. This is how we put it. It will make little bit of vapor. The skin will vaporize, but in between skin is normal, so the epithelialization will be very fast, but the deeper injury will lead to new collagenesis or the collagen formation. So this is how the rejuvenation happens in fractional source. But coming to the other machine, so again we will go back to this one.
So this is another machine is the erbium glass. Here the wavelength is 1550, and again the same thing. Here again the power, duration, all these things are there. So it has been preset. I'll be increasing little bit of power. Almost same mechanism, but here what happens? There will not be burning of the skin. So there will be only heating of the skin. The mechanism remains same. You can see it.
Ready?
Now, after PG, 5 years after PG Q switch, 10 years after PG fractional, and now 15 years after PG erbium glass.
So what is the advantage of erbium glass?
So the same mechanism, but if you closely see, there is no damage to the skin. Only the deeper layer is heated. It's like you can say the induction cooker mechanism. Both the surface are intact, but the inner content of the what is heated. So the same mechanism here, we are hitting the dermis without hitting the epidermis or without damaging the epidermis. So again, the mechanism is a controlled injury. So which way we are using that depends. So the downtime, and in the microneedle RF, again this is microneedle RF. There are certain needles, and the energy is radio frequency. The needles go deep into the skin, releases the energy, then comes up. So there is injury to the skin, but we are not damaging or burning the skin, but only insertion of the pins, which leaves no scar or nothing. So the downtime with CO2, fractional CO2 is high. Like patient has to take at least 7 days, 3 to 4 days of rest. For the microneedle RF, it is further less, and for the erbium glass, it is very less. The next day, patient go to his work. So accordingly, we choose. Like the patient doesn't want to go for 3 days rest. Like persons like us, we cannot take a rest for 7 days for a procedure. Then you have to go for erbium glass. So you should have all these gadgets, but for the freshers, you need only one, master that one, then go for the next energy device. I think we'll finish this patient after the procedure. After
I have
the
a question for
demonstration of
Monali. How is erbium glass better, or how do you compare with fractional CO2? Like I'm confused which one to buy. So what will be your take on this?
So as like Dr. Manas told, that erbium glass, the downtime is less. So like in 2 to 3 days, like 3 to 4 days, it is for CO2. It is very early for erbium that they cannot know. It comes like a lunchtime procedure. Patient can go back to work. Second important thing for Indian patient is with erbium glass, the degree of the risk of PIH and all that is less with the erbium glass than with the CO2.
So I think it's like diode and long pulse NDAC for hair.
Right.
So more chances of burning
Yes,
in
sir.
long pulse NDAC. So diode is considered safer at the cost of efficacy a bit. Likewise, in fractional CO2, the chance of damage is more and the chance of damage is less. But the result is better also in erbium glass. I think that's the message.
And one more thing is there in the mechanism which I practice often is that I don't fire the same shots everywhere. I will give 3 passes in a CO2 laser. First, I will target each of the like box scar, U scar, whatever scar is there. Then I'll give a lesser energy on the surrounding skin. And at the end, I'll give a third pass, which is a very mild juice, so that there is no pigmentary alteration after.
Way of doing things, as Dr. Monali is saying, what she does is she first targets the individual scars, then goes for a lower energy, again the surrounding tissue, and still lower and again. So that is what she does. What I do is I go for a single pass, because if you look at the mechanism, so with a single pass, your chromophore is already gone. So what you are hitting is basically now you are damaging the tissue. There is chance. But like you said, you can play with that. But the problem with repeat hitting of this CO2 is that with a single hit, all the chromophore is over. So there is nothing.
Too many passes should
There are so many tips and tricks.
But of same energy, we should avoid different passes overlapping.
There are so many tips and tricks, but for the starters, first you have to understand the basic lasers. Then only you can know the tips and tricks like individual lasers, how we are handling or how we are manipulating the thing to get the best result. So thank you, Dr. Manali, for demonstrating very nicely. Now I welcome Dr. Lakshman Besra to give a demonstration of diode lasers, because for the hair removal, as Vikas sir has told, we are having 3 major mechanisms: IPL, diode, and long pulse NDI. So best one is diode. So we'll have a demonstration for that.
So in between, I will fill in. Nowadays, you hardly see any single any person with a tattoo which is only black. Do you see that? They're usually multicolored, right? So there probably QC will fail. So what you will end up with is only removing the black color. So if a person has a multicolored tattoo, you will end up with leaving the non-black color and clearing only the black color. So it is again another cosmetic deformity for the patient. So you are not doing justice to the patient. So in that case, probably the rest of the pigment can be taken care by a still higher frequency laser, which is the picosecond. So that is what is there with us. In that Q switch, we have picosecond as well. So picosecond still fires much faster, so that whatever color pigment is left in the macrophages, they break. The melanophages, they break, and the macrophages pick that color. Okay, so that should be very clear.
One thing, like once you use, then you know where you are facing problem, then you will find your own way. But before that, you should have a hands-on knowledge, like what are the devices available and which is suitable for your practice. So now we'll go for diode. So before you start, there are different types of diode. Most commonly we are using 808 diode, but now we are having triple wavelength and quadruple wavelength diode, which is more superior, which can target even the finer hairs.
Good afternoon, everyone. So now we'll be discussing regarding the hair removal lasers. And in Indian skin type, we will be most commonly using diode laser because it suits the Indian skin type. And this machine we are having here, it is based on all the skin types, and based on the skin type itself, it is having the different settings inbuilt. But before that, for skin type 1 and 2 and 3, most commonly we will be using ruby laser and alexandrite laser. Ruby laser being having wavelength of around 694 nanometer, and alexandrite being 755. And as Manas sir already told, nowadays we are having multiple lasers which are coming with triple wavelength and quadruple wavelength also, because there are different types of hair over the skin, some in the different levels we are having. Mostly it can be situated from 2 millimeter to 7 millimeter depth also. So depending on the depth of the hair also, we need to target the hair. So
in that, in multiple wavelength laser, actually we are having all the wavelength are single shot. In the single shot, we are having different wavelength, or we can use different machines. But because it is nowadays available, so we are going for the triple wavelength and quadruple wavelength diode machines.
So as previously already been discussed, the lasers already this is the like energy which is being used for the fluence. The more the fluence, the more the depth will be. And for different type of hairs, if thick hair is there, more fluence will be needed because it takes a longer time to get heated. And for thinner hair and all, we need lower fluence initially. Even the pulse duration should be optimum around 40 to 50 milliseconds for optimum penetration.
In diode, actually, there are different modes. Like you can adjust the energy, you can adjust the frequency, and you can adjust the pulse duration. Like for how many time there will be the laser light will be passed from. So accordingly, because as we know, overheating will lead to scarring and damage to the skin, pH, and all these things. So we try to prevent overheating. So for that, you can have like multiple types of modes. One like in one mode, you can when you press, there will be 2 times or 3 times the light will come. In another mode, it is a continuous mode. Right. You have to move the handpiece from here and there, but there will be continuous blasting. So according to what you are comfortable with, you can decide.
So hair removal can be used for multiple indications. Hypertrichosis can be there, or hirsutism is there. Then other clinical indications like pylonodal sinus is there, pseudofolliculitis barbae, and other indications like
distance so you can see the burning here. So the same thing, but if you put the same thing in the white area, there will be nothing, there will be no burning. So it is the dark black color which is burning. You have to see actually the lens should not be damaged. And in the diode, we'll have any patients for the diode? No, actually machines are here. After the demonstration, you can see each machine, which is whatever you want. You can see the machine and live demonstration of the machine on your own hand. So I think we'll shift to No, in diode there is no photoacoustic effect. So you have to see the pinpoint erythema, like the hair follicles are placed at a particular distance. So at the end point is when you see the pinpoint erythema, equally spaced erythema. So that means you have burned the hair roots. So for that, either you ask the patient to trim the hairs or shave the hairs at least 4 or 5 days prior to the session, or you can use a trimmer to trim the hair. There should be only fine small hairs, so that the energy can go through that hair up to the root of the hair and damage the hair root. Here the basic mechanism is damage of the hair roots, and it needs more than 10 sessions, because in each session we are damaging few hairs, not all the hairs. If you try to overdo, then there will be there will be ulceration and scar formation, which is again a very big complication over the face.
Target will be melanin over here. Melanin of the hair.
Here the chromophore is melanin. So what we are doing, our skin also contains some amount of melanin. but the hair contains big amount of melanin. So that's why you have to be, it is in a calculated way. So you are putting some energy. So it depends upon the skin type. If the skin type is fair like 1, 2, 3, you can go for very high energy. If the skin type is 4, 5, then you have to go for lower energy and number of sittings. And you also see the patient's condition. If the patient doesn't want any complication, always go for the lower sitting. But if the patient is little bit ready that even if there will be some burn will be there, it is okay for me, then only you can go for higher concentration. But for the safer side, always for the dark skin, go for the lower fluence, and for the white skin, go for the higher energy. This is actually the spot size is there, different types of spot size there. This type of like 8 millimeter, 6 millimeter, 12 millimeter like that. So you can choose. For the body, you need a bigger spot size. For the face, you need a smaller spot size. So in one spot, you are targeting all the hairs in a particular area, but you are targeting only the hairs here because the energy is concentrated more in the hair roots than in the skin. This is the mechanism difference. Why the Q-Cyst one? That's why the Q-Cyst one only targeting the melanin on the skin, but here it is targeting on the hair only. So the white hairs, fine hairs cannot be done with diode. Basically, the dark hairs in a fair person is more suitable for diode hair removal. Triple wavelength actually, as Dr. Lokma has said, so the alendronate and the ruby one, the 630 and the 755 targets different, even the fine hairs and the vellus hairs. So in one shot, you can target the darker hairs and finer hairs. The fine hairs are very difficult to remove with diode laser, which that disadvantage can be taken care of by using a triple wavelength laser. But again, the cost is high, so that has to be considered also. Long pulse NDIAG is better suitable for the dark skin type rather than diode. But long pulse NDIAG, somehow the machines are not very highly used by everyone. So the number of machines is less and the cost of maintenance is high with long pulse NDIAG. This is the main disadvantage with long pulse. So cooling is again, here we are having water cooling system or dual mode of cooling system. I think it is dual mode of cooling system na? In diode. Dual mode of cooling. So we are having an inbuilt cooling. Actually now almost all machines is having inbuilt cooling. No need to go for a, because 10, 20 years back when the new, there were old machines, there we need to put extra cooling. All these machines are having inbuilt cooling. It is conductor based and water based. The same mechanism. You have to put ice before the procedure, just after the procedure, and I advise at least 5 minutes ice application just after the procedure.
There is a school of thought also by which says that when you are doing it intra procedure, while doing the procedure, that may reduce your efficacy a bit. So what some machines have is they don't have the chill tip, right? This one, like, it will chill here only, but some machines have a chill tip here. So for doing, you touch that area, you move it, and then you move, and as you move, it keeps in the
other area.
next area.
The next area is cooled so that you are using the first area. Again, the third one. So like
the
like
funda
that.
of those machines is we will do pre and post cooling, but we won't do intra. While you are firing the shots, we won't give you cooling, so that the just the target better. See, there is what I have understood that every manufacturer sells it like their US. So there is not, as I said, there is not much difference. No, it doesn't do anything with increasing the penetration. It only
It only what we are concerned about the tissue damage. We don't want any complication. Actually, just before the workshop, as Vikas sir has told, now it is the time not to learn the lasers. Now it is the time to learn how to avoid complication and how to take care of the complication of lasers. Because now you all will be exposed to, you will have a laser wherever you work. But only thing is who knows the what are the expected complication and how to handle the complication. Then only you can go ahead. So now. So I will be demonstrating another two machines, which is also very useful nowadays. One is HIFU, which is high intensity focused ultrasound. So whatever mechanism we have discussed, one is radio frequency, then laser or IPL, which is a light source. This is the radio ultrasound machine. So the ultrasound energy is used to damage the fat. So the mechanism is the ultrasound energy passes through the skin. Again, the pressure, the induction cooker mechanism without damaging the skin. But wherever there are two waves, wherever they are touching or at a particular point, there occurs maximum energy. And that here again the tissue is there occurs the heat generation, and that heat goes up to 60 to 70 degrees Celsius, around 65 degrees Celsius. So at that particular level, there occurs damage to the fat cells and also damage to the collagen and other subcutaneous tissue. So this is again a focused one, controlled injury on the subcutaneous tissue. So high focus ultrasound is a very safe machine. As we know, we are using ultrasound left and right everywhere, gynecologist and other in radiology departments. So it is a very safe machine, and the use is same as rejuvenation or facial rejuvenation. You can use for the reduction of the fat, but don't expect you lose fat in kg. It is only losses in grams. So don't expect it is this is a machine for weight reduction, but definitely it can reshape your double chin, like double chin, then eye bags, anywhere wherever cellulite, all these wherever extra fat is there, or someone has lost weight, now there is loose tissue, sagging tissue. For rejuvenation and skin tightening, you can use HIFU, which is very safe machine to use, and the parameters are also, it needs around 1 hour for the whole face. And the mechanism is there is the ultrasound probe, and once you have to put the jelly just like other ultrasound machine, and the energy goes beyond. Once you set the parameter, there are different on the areas of face. Can you focus this? Yeah, you can see the number of lesions are written there, number of shots for each area. So this is basically done by your staffs, not by you, because it needs more than 1 hour for the whole face. And you have to select the area, select the number of shots, then start the, and you have to select the energy. There is an energy level and the length is there. So for how much time the energy will be there. Because if you go for a very high energy, like this machine is goes up to 0.2 joules, I think, from 0 to up to 2 joules. So normally I used to do 1 to 1.5 joules, and for the whole face, there is specification, like once you put that number, suppose after 40 shots, that area will be stopped. So you have to mark with a pencil of that particular area, then start the procedure. So how it helps, how it occurs. This is basically, show your hand. You can see the energy, there will be little bit of acoustic effect type of thing, little bit of sound, but basically you will feel the trickling sound. One. Okay. So that type of then you first you go for a test patch. You see how much energy non-topical anesthesia is required. Then you see how much energy is tolerated by the patient, and accordingly you put the energy. And the whole session goes around 1 hour, and the effect comes only after 2 to 3 months. Because what we have done is an injury. We are not doing anything because we are giving the body to rejuvenate it, like produce new collagen and remove the fat whatever has been damaged. So effect comes after 2 to 3 months, and one session the result will remain for about 1 year. Again you have to do. So this is basically in comparison with Botox and fillers. So HIFU is same, where you want to go for Botox and filler, you can do HIFU. But basic difference is there we are injecting something which very patients they would fear for injection, they don't want a thread inside their face, then you can go for HIFU. HIFU is a machine for facial rejuvenation, reduction of cellulite, reduction of eye bags, and also body shaping. Same thing we are doing with microneedle RF, fractional CO2 laser. So as I have said, fractional CO2 laser, then microneedle RF, then erbium glass, and the most safest one is the HIFU for the facial rejuvenation and tightening. So then another one is excimer. Already, so we are going beyond time. So excimer, I think almost now everyone is using. So basically it is particular wavelength 308 nanometer. It is in the ultraviolet B range, and it is not exactly a laser. As IPL, it is again a light. So it is a non-coherent light. But the thing is, the efficacy is same with excimer laser. The first or the initial excimer lasers uses we are using a gas. So to keep that xenon gas is very difficult. Procuring the xenon gas and putting it inside in a pressure chamber was difficult. That's why it was abandoned. But because the smaller machines have come, so now we can use it, and the cost is also very less. And again, what we are doing here, we are giving a particular wavelength, the 308 nanometer wavelength, so which damages the cytotoxic T cells and activates the melanocytes. So it can be used in vitiligo, in psoriasis, in lichen planus. So in variety of conditions, you can use this excimer laser. So the basic mechanism is same as laser. The light is when the atom goes up higher energy state, then once it releases the light in a particular wavelength, and that light is not monochromatic. It's a monochromatic light, but not like laser. So the power is less. Very safe machine, but it is very damaging to the eye. So always take a eye protection, because it is damaging to the lens also. Not like other laser, this also damages the lens. So always keep a eye protection. And you can do in atopic dermatitis, in psoriasis, wherever there is inflammatory conditions, you can use it. And the use is very simple because it is a small machine. It's a very handy machine. So actually 30 millijoule per second, 30 millijoule per second is the energy in this device. You may have different type of in your device. So accordingly we decide how much is required. Suppose for vitiligo on the face, I need around 150 millijoules. So that means I'll go for 5 seconds. But normally I have to start with 10 seconds. That means around 300 millijoules is required to start pigmentation. And there is no endpoint here. Immediately you will see nothing. So the patient doesn't feel any pain. But after 1 day there will be erythema. So just like other types of PUVA therapy or dermal UVB therapy, you just go for alternate day treatment, or once in a week or once in every 15 days you can do. And you see, you go on increasing the energy till the time you are getting erythema but without any blistering. So then at this point you can continue for around 5 to 10 sessions. This gives good result in vitiligo, but again the rules are same. Wherever the medicine works, the laser will work. Wherever the medicine doesn't work, like tip of the fingers and all, laser will also not work. So this is not a substitute of medical treatment, but definitely it can hasten your treatment. And for others like psoriasis and all, this gives good result. For the localized lesions, you can try it. This is one of the best laser for localized lesions. Which one? Pregnancy. So I think this is safe because this doesn't enter anyway. All the lasers are safe in pregnancy. We don't have any contraindication. Even so, because we are not going beyond the skin and there is no systemic effect, we can use in pregnancy also. Mask for the fat, not for this one. Okay. So there is another machine for in the HIFU, but she is asking about Coolsculpting and hot sculpting. So there are different machines for the removal of the fat. We are having excess fat like cellulite and all. So I am having a cryolipo machine in my clinic. So that what it does, there is a machine, a cup-like thing, and the suction is there. Once you put the machine, you have to put a gel sheet, put the handpiece. So there will be suction and it will suck the skin. Then once it is fit into the machine, then there will be heating initially. then gradually the temperature will go down. So by this process, your fat cell will burst or will be damaged. This is called Coolsculpting, and there are different machines for this, different mechanisms, like few uses different temperature variations. So all these are for body shaping machines. I use only one machine, that is a cryolipo machine, which is the like heat flow mechanism. You have to heat the tissue, then gradually cool the tissue. Each session will cost you. So this is the machine actually how it looks I am having. So this one will heat the tissue, then gradually cool it down, so that in that process, so you have to put that probe handpiece for about 45 minutes. So all these things needs extra space in your clinic, because one patient will kill whole time. So you have to have different number of beds. You have to increase the number of beds if you go for all these, like HIFU, cryolipo, all these are time-taking procedures. So you need different beds for each patient. Actually, ma'am, as I have told, there is a misconception that laser will do wonders. Laser does never do wonders. Only it helps you in certain indications. Like suppose in a suppose in a child you are doing, patients are they are not willing to go for sun exposure and all. So then you can try excimer. And as I have said, the golden rule is wherever medicine works, the laser will also work. Where medicine doesn't work, laser will not work. You have to go for surgery followed by excimer. So what I am doing for stable vitiligo, rather than theoretically trying lasers, I go to surgery first, then post surgery. Normally what happens, if you go for Puvasol, it will take another 6 months to 8 months to get the result. But with excimer, you can get within 1.5 months or 2 months. This is the advantage. But don't expect the laser as a substitute of medical therapy for vitiligo specifically. But for certain conditions like skin rejuvenation, where you don't have a medicinal option, or definitely for tattoo removal, for freckles removal, lasers are the only option. But for the excimer, the rule is little different, because the medicines will work. This is something where patient don't want to take medicine, or there are certain contraindication, patient cannot take medicine, you can go for laser. So suppose patients are taking medicine. Now you want to give extra result. Suppose patient wants to marry after 3 months. If you go for oral therapy, it will take long. There you can add excimer. And so now almost we have discussed except few. One more is microneedle RF. I think almost same as fractional CO2. That's why we are not going to demonstrate, but anyone can see during lunch hour how the machine works. And now we'll go for the facial rejuvenation part by giving injections, either Botox, fillers, or the threads. So as I have said, that for every problem there are multiple ways of solution. Now you have to choose which you are more confident with and what patient will afford. Like HIFU is a very costly machine, and each session in all metros charge not less than 20 to 25,000. So then you have to decide whether you will get that type of patient or patient can afford it. Then only you can pick up. And again, Botox lasers are also in that range. So all must be dead tired by now, but असली picture अभी बाकी है मेरे दोस्त, so you cannot miss this one. So Botox and fillers. I don't think we have Botox, but we have fillers. So this is another thing for I won't say it is for rejuvenation. It is actually anti-aging.
Now, what is anti-aging? For anti-aging, we have three things. One is anti-aging creams, which are not anti-aging. As simple as that. They don't remove your wrinkles. They may just iron it out a bit and they won't reverse the aging. So if you use cream, a 50-year-old lady or a male will not look like 45. They may look a better of 50, or maybe the further aging will go down, but they won't look like 40 or 45. Then coming to energy based systems. Energy based systems, those who have heard my session in the last QTCon, I was discussing the same thing. So those who, if you have energy based, as Manas bhai told, HIFU and all, number of sitting is more, and the patient has to come to you for multiple times, and it is again a global treatment like I do for face and neck, but I may not remove this wrinkle which the patient wants. So there comes Botox and fillers, or maybe threads. So what are they and how to use? So each of them has their own indication, but if you classically categorize them, then you divide your face into three halves: upper third, middle third, and lower third. So classically, upper third is an indication of Botox. Upper third. Middle third is an indication for threads and fillers, and lower third is for again Botox and threads. So this is a classification. If you go face wise, zones of the face. Now age wise and anatomically where they are working, because what I will be talking today will not be on a particular technology, rather how to overall use it. So now if you did this, then age wise, so 20 to 30 may be the age where your skin ages. 30 to 40 is where there will be in the fats and muscles. So 30 to 40 can be a right age to start these things. Again, the requirement, the technique of treating a 30-year-old lady will vary from what a 60-year-old lady will need. The requirement of the chemicals and whatever fillers, hyaluronic acid and all will be more. But it's not like you cannot do. Now the thing is, when we in Odisha, it's really difficult. In Odisha, it's like it's really difficult to do Botox and fillers. It's a practical problem. Even if you learn, you can't do. Some patients tell, "आप Botox लीजिए," they will tell, "Sir, क्या मैं बुढ़ी दिखती हूँ?" Then I tell, "नहीं, आप बहुत जवान दिख रहे हैं." A 60-year-old lady in Rourkela who looks quite aged, she asked me, कि क्या मैं बुढ़ी दिखती हूँ? So you don't have any answer for that. So basically, as Manas sir said, the reluctance for getting injected, the reluctance to get needled, and there is reluctance on the part of physician also. How confident are we in advising Botox to our patients? We are not, and we don't give that much time, and it's very difficult. These patients will take half an hour to 1 hour in just in a sitting of counseling. So how can you do that? But once done, once converted, they give amazing result, which cannot be given by any technology, any device. It cannot be given. So that is the advantage of using Botox fillers and threads. Then another advantage is the result is visible. Like you do chemical peeling, the patient tells, "I don't get benefit." But once you do these things, the patient cannot tell you that I didn't get benefit. The patient has to get benefit within 1 to 2 weeks, and it is definitely visible. Fillers, more costlier of the lot, very costly. So fillers, like your charges, what you charge to your patient is in multiple of 20,000. I am telling just an average. Like you charge the patient 20, 40, 60, 80, 1 lakh, 1.5 lakhs, like that, if you do fillers. And you will be surprised, those who have attended conference, cosmetic conference, we thankfully stay in a relatively poorer state. They advise to give 10 injections, 5 injections of fillers. the MRP to you will be 1 lakh, and I don't know how much they charge to the patient. So they must be charging 2 lakhs to 3 lakhs for a patient for a single sitting. For a single sitting, and has to be repeated after 1 year. So this is the reason this part it is difficult to do. It is difficult. Number 2, then how I am doing, maybe I am very passionate, so I am able to do a bit. Then number 2, why it is difficult is procuring these things is very difficult. Now maybe many companies are giving, but initially only single company monopoly was there. So you cannot procure. Difficulty 2. Number 3, it is as much as an art as a science. Because maybe for madam, if I will do, you will have a different approach, I will have a different approach, and we can't prove that he is correct or I am correct or she is correct, who is correct. She may give 2 units here, I may give 1 unit here, I may give her result. Like for clinical dermatology, you have a certain guideline. Here there is practically no guideline. So I can fill you with 1 ml, I can fill you with 3 ml, I can fill you with 4 ml. So there the problem is it's very difficult to tell who is right and who is wrong. And as a medico, we have trained our mind about right and wrong. Now here this zone is a gray zone. So there is no right or wrong. If madam pays me 2 lakhs, I will love to inject her 5 syringes, no problem. If she is paying me 30,000, I will try to do the job with 1 syringe only. And associated headache, so better not to talk about them. Now, where do we place thread? Botox filler done. So what is Botox? Botox is for the muscle, for dynamic wrinkles. So when you do a facial expression, your wrinkles are coming, dynamic wrinkles, indication for Botox. What is filler? Filler is hyaluronic acid. So you are filling. So with age, what happens? Your pad of fat, malar pad of fat goes down. Your lower part of the face becomes heavier. You just imagine Sunny Deol, how he was looking when he was very young, and now how he is looking. So your face becomes squarish, and the lower part becomes more heavier and broader. So by filler, what you are doing is you are again recalibrating the things. So you are making the upper or middle third a bit broader, and you are trying to give back that pear-shaped look of the face, pear-shaped look with the S curve or OG curve. So another example, because first you need to understand what happens. Another example is you see models and all these celebrities, they lose a lot of weight for their waistline to get narrower, but you will be surprised that it doesn't show on their face. Fillers. They lose a weight, they go to a dermat, they put fillers, and their face becomes like a balloon, but waist becomes like a stick. And in the newspaper, they tell that we got this result by doing pranayam and by drinking 2 liters of water. So actually they are telling the truth. The water is hyaluronic acid, not Bisleri. So that is how the patients, these things are done discreetly. But I feel if 10 celebrities tell tomorrow morning that we did fillers, so the awareness will increase, more patients will come, and we can do. Third thing is education. Why there is less education in this? We are not trained, so we cannot train our juniors. Simple. The training, entire training lies with one company only. They will not train you till you buy something from them. And if you buy, you have to consume. So it becomes like a vicious cycle. So they will send you for cadaveric dissection training, but you should buy minimum 2 lakhs worth of goods from them. If you ask them study material, they will send to your mail. That mail will disappear from your mail within 7 days. Yes. So that is why the learning is also very difficult. And as I said, it is more about artistry. If I tell you that you inject 1 unit here, what the hell will you understand? So you have to see the face, you have to read the face, and gradually you can master it over years. So if is interested, we will straight away go for a live demo. Threads and fillers we have. We don't have Botox, so threads and fillers. So your patient will be inclined to do only if you are inclined to do. Till the physician has reluctance, your patient will never do these things. Never. So if anyone, or we can do on Sahaj ji. अगर कोई सैंपल नहीं है तो सहाय जी is the sponsor for this session, so we can do it on him. मैडम करिए. I wish I could be the subject and injector both, because I would love to get a treatment worth lakhs free of cost. So I don't understand the reluctance. 1 lakh I will be giving you now, not in cash, in the form of hyaluronic acid, but Asanu madam. Apa? Asanu. So Dipti madam will help us. We'll try to make her more beautiful. Lai saman apna. I'll tell while doing. So you take the, while taking the history, you talk, when you talk to the patient, you try to see that the expression lines first there. Then you tell to make a pout or something, but first you see the where is the need of the patient. So I realized over time that this CK2, CK1 is just another method of giving. It's not like so. Yeah, that is the thing. So what Monali is asking is that are there any specific points? So what they basically do is to enhance the mid face. So on the zygomatic arc and zygomatic eminence, prominence, they inject. This is CK1 and this is CK2. Like once you come to CK3, there is no anatomical landmark. So it's anteromedial part of cheek. Now that big, so it's difficult to define where is that. CK4 is parotid area, and I think CK5 is submalar area. So submalar area. So it's difficult really to tell that how much where. So that is a code which was given by Dr. D. Mayo from Brazil, who is a plastic surgeon. So I think that is what she is telling. But now in most of the standard textbook, they have mentioned these points. So, but you will see that there are other things also how to give. So, Madam Asanu. Once someone comes, I think others will be, even young people can come. There is nothing, like I told you that if I use maybe a higher molecular weight hyaluronic acid for ma'am, I will be using a lower molecular weight for you people. So PGSRs, anyone can come. Dipti can also come. Huh? Madam, madam, please. So I have to now tell like this, 2 lakh, 2 lakh, 2 lakh, 2 lakh, 1 lakh. So I think then people will come. Madam Basan. Apan Basan. Yeah. डर के आगे जीत है. So if we see, madam, now I'll tell, yeah, Sahaj, आप pre photo ले लीजिए. So what, without disclosing her age, so middle-aged woman will be the right word. So what, when madam is smiling, you can see these lines, right, in the nose. You can see bunny lines. So very much there. You can see lines on the forehead. Madam has very good this pad of fat here. So normally this becomes like this. But what can be done for madam is, as you age, your chin from this becomes this and it goes up. So chin enhancement can be done. This is an advanced indication, but it can be done. what we can do is nasolabials can be done, right? Marionette much is not there, and a bit of jowl is there. But the interesting thing is when you correct the mid face, everything gets taken care of, because once you correct the mid face, this becomes like this. So jowl goes, nasolabial goes, and you also get support, give support to the tear trough. So mid face is the best place for beginners, for starters, and for Odisha. That is very important, because if I inject in Hyderabad, then how much budget I can make? 20, 20, 20. I will be charging around 20 more. So if I am in Hyderabad, I will be charging not less than 80,000 to her. And assuming that she lives in Banjara Hills. Now coming to our state, 20 में सब मिलेगा. So what I will do is, I will do what will work actually good for ma'am is thread lift, because she has a very good mid face. So enhancing it may get over enhanced, she may not like. So we will do thread lift for her. Very nice and very gratifying result. Like thread. Madam, bosandu. Ebe hobo. Yeah. And whenever you are doing these things, it's very important that your patient should lose weight also, because you can't modulate everything with these things. कॉग ना तो 18 गेज नीडल वो सब दीजिए. So we have two kinds of threads. One is mono threads and one is cog threads. So cog threads basically have barbs. So there is more anchoring and it is believed to be giving more tightening. These are relative things. Maybe if I inject 4 of this and 10 of this, the result may come same. So mono threads are give you less support basically. That is how you have various other types of threads also made up of polydioxane. So very safe. It's get dissolved in your body. How does it work? It works by anchorage initially, then neocollagenesis. सबका target एक ही है, collagen. So neocollagenesis and anchorage. Also a bit of fat reduction can also be there by giving threads. Yes. Gloves. छोड़ दीजिए आप, है ना, काम है तो क्या काम है? मानस भाई आपन को रेडी मोर 5 मिनट से सर जीव. आपका बॉस बोलेगा फोटो लिए कि नहीं, ले लीजिए फोटो. दिए तो मैं जब बोल रहा था. हाँ सर, निडल है ना हमारा, ये है ब्लेड है, वो ट्रे में ब्लेड है. है जी स्वाब. हाँ ये ब्लेड है ना. अच्छा सुनिए, स्वाब स्वाब नहीं, ये तो गॉज गॉज है. अल्कोहल मतलब स्पिरिट है नहीं, स्पिरिट नहीं. स्वाब वो जो आप लास्ट टाइम लाए थे गीला वाला नहीं है. सैनिटाइजर ओनली. सैनिटाइजर किसी भी नहीं. So when we are doing cog threads, so in mono threads you don't need to do give anesthesia initially, but in cog threads you need to give anesthesia. So we'll numb the area. So we'll be injecting somewhere around this zone. So the entire zone will anesthetize with the normally available 2% xylocaine. Yes. Hospital जाकर. Madam is asking tomorrow she can go to hospital or not. I would say that she can go hospital without mask also. That will look better. Yeah, this will give immediate result. Botox and filler thread both give immediate result, but fillers and thread give immediate result. Botox takes some time. Botox around 48 hours you get the result starts to come, but proper result comes after 1 to 2 weeks. So because here we are having a cannula kind of thing, so it will not penetrate. So who is the agla shikar after madam? After this hunting is over. Okay, साया जी ये यहाँ रख देते हैं, यहाँ रखते हैं. अब मैं ग्लव्स पहनूंगा. It engage. It engage. It engage. अच्छा ये तो चाहिए होगा ना पकड़ने के लिए. आपको खाली ब्लेड देना है बस. So now what we will do is we'll make a small burrow hole. मैं एक खोल के रखा था कॉग. So you locate the area which will give the maximum lift. जी xylocaine दीजिए और थोड़ा xylocaine दीजिए. So focus. Sorry. So we'll make a small hole here. So we made a small hole here, right? Sahaj ji, दीजिए thread दीजिए. So we made a small hole here, so that will enter. दीजिए मैं निकाल दूं. And we are ready to go. You see how this will give a cheek lift. Depth, where are we going? We are in the mid dermis actually, right? So after putting it, take it back. ये चाहिए scissor. Lift it. Blade चलेगा. And you have to also respect the bilateral symmetry of the face, like right and left face may not be same. Maybe I'll need 5 threads on this side and 2 threads on this side. So that also you have to see. So in between the procedure also you need to see, look at the patient, how is the result. Madam, comfortable? Or if Madam has a very good cheekbone, so it is looking a bit swollen, but it's actually the bone, and because we have given anesthesia. ये चाहिए blood. So again I come back. Madam, सीधा सीधा देखो. I give a traction, I pull the thread. Actually, we don't have scissor, other things would have been easier, but fine. Now we will see. Yeah. If you can finally appreciate this nasolabial and this nasolabial. Focus kariye. Yes. You see, this nasolabial has improved. Madam, apan सीधा देखो. Apan घरे देखिए. Yes, you see. Are you able to appreciate? Okay. उस साइड करेंगे, उस साइड. हाँ, 18 गेज से होल बना देते हैं. इसको नीचे ही कहाँ फेंकेंगे इसको थोड़ा. इसमें रखिए. So again we will see the laxity in this part of the face. Madam has more or less symmetrical face, so I think I'll be needing 2 here, same. दीजिए सर. नहीं, कॉक थ्रेड. सर जी, रुके. Hit at 90, then go straight. ब्लेड दीजिए. No downtime, nothing. Patient comes and goes within half an hour. So I am giving this traction at the end so that the thread gets pulled inside. As a counter traction I am basically giving, right? Otherwise sometimes what happens is it juts out, and if you don't remove it, there's a blue foreign body granuloma kind of thing, and that stays for a very long time. After the, no, there is no knotting. I am just pulling and cutting. No knots. और एक दीजिए नहीं इसको, हाँ इसको उसी में रखिए, इसी में, हाँ और एक थ्रेड फिलर्स भी ले मैडम का कर देंगे. This I am going towards the lip, just like this I have gone. So madam has been really considerate to allow her. Done. Fillers le आइए. So again I give a counter traction. Focus. Yeah. So without any fillers, you get nasolabial has gone almost. Like when she is not making expression, when you make expression, nasolabial has to come. But when she is not making expression, I think around 50 to 70% reduction in the nasolabial. So I call thread as a poor man fillers. The person who cannot afford fillers, they can go for threads. Fillers. वॉल्यूम नहीं, प्लेन वॉल्यूम दीजिए. मैडम का अच्छा है गाल, और थोड़ा अच्छा कर देंगे. फिलर 80 के दे दो. हाँ 80 के दे दो. 80 के दे दो. So while giving fillers, supratrochlear artery, supraorbital, infraorbital, facial, these you have to remember the landmarks only, not very dangerous, as hot to be, and if you do it in the right way, hardly there is any chance that you will damage any blood vessel. And just like any injection, you need to withdraw before giving. That is the only thing you can do, and you can so this is not, yeah, Gaurav, this is a very time consuming procedure. It's not like you see, even I think half an hour is, it's not like patient comes, you give jabs, thak, 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 they give you money. It's not at all like that. It's a month long counseling, and then it's a long, it's not quick or easy money. तो ये रखिए, मैं यूज करूँगा. स्पिरिट थोड़ा और दीजिए. So we'll ask someone else also, but let me do what I can do best for madam. Thank you, madam. You can see this jowl. Now see, this is an advanced indication. Should not be doing in this workshop, but her cheeks are very good. So let me just see how we can make her look better. So the golden rule is, the thicker the filler, the deeper you place it. So just for precaution, wait for 5 to 10 seconds, withdraw and wait so that you are not on any blood vessel. Yeah. Heavy lagibo se jaga jani paribani gote din par. बेसी अटे नहीं मैडम विथड्रॉ करके दे मुंडा फुंडा बोलो जी मैडम I don't know whether all of you can appreciate or not, but what I am trying to do is to give her a more defined jawline. But what she needs is that she will be needing Botox and threads also. साहे जी नॉर्मल थ्रेड दीजिए मुझे नहीं कॉक भी चलेगा कॉक दीजिए और है ना कॉक नॉर्मल भी चलेगा You have to be very careful with the depth where you are, because as you are withdrawing the needle, you are coming superficial. So you can't leave fillers at the upper level. There will be Tyndall effect and there will be lumpiness. Now, if you are doing something at the upper level, then you have to reduce the molecular weight of the hyaluronic acid. So the more thinner and liquid ones will be on top and the heavier ones will be at the bottom. So I did something for this line a bit less prominent now, a bit less prominent, because I am not trying to overdo things. Jawline is a bit better. You see this jowl, you see now it's 50% reduced, 50%, because maybe other things will be needed, and most importantly you have to wait. So in such cases what you do is you tell your patients to come after 15 days, then you see what has worked where and then you give. Third there मोनो दे दीजिए yeah. पेन मैडम कहते हैं 1 2 3 4 5 स्केल रे 1 2 3 4 5 some heaviness but intra procedure pain tolerable mono na हाँ इसको दीजिए. So what I'll do is we have seen cog. Now what I'll do is we'll do mono threads for her jawline because she has a wonderful cheekbone. So I won't fiddle much in that area. So we'll play with mono. So in mono, you don't need any cannula or even anesthesia, you don't need. I don't use. You can use as per your suitability. So what I'll do is I'll try to redefine her cheeks. So I'll give one shot at the jawline. I'll give one more just below that. This is more superficial than cog. And I'll give one above that. तो कुछ भी हो जाए आज मैडम को जवान करके छोड़ेंगे, नहीं तो नहीं छोड़ेंगे. So see this side of the face, feel better. You have to also learn how to appreciate, because I cannot impose that there is improvement, but gradually, like you have to train your eye. Like I cannot really tell how, but patient. So today is a scapegoat, so she will appreciate after she goes home. ना फुली नहीं, फुली जी मैडम को फेस किसी ये दीजिए, स्पिरिट थोड़ा दीजिए. माने भलो फुली जी, माने भलो कहाँ दीजिए. और एक मोनो खोलिए. लगे मैडम नॉर्मल एकदम मैडम, डोंट वरी. मोनो मैडम खाली लड़को जहाँ लगे मोनो. अरे नथिंग मैडम, पेन है खाली एंटी इन्फ्लेमेटरी किसी खाइदेवे, पैरासिटामोल के सेमती किसी सेमती किसी हबनी मैडम. माने एते दिन हला तो को पेशेंट किसी कंप्लेन करि नाहंती मते. आ मु सब मैडम अंडर डू करी ही करछि, जो 2 दरकार 1 देछि. सो केमती किसी हवा कथा नहीं मैडम आइडियली. So for more anchorage, you can do cross hatching also, like this also you can do, right? So a bit of more correction might be required this side. This side is pretty good. What normally happens is when your patient goes to her house, problem starts there. First person whom she will meet, she will tell, I have done something. They will point out 10 problems to her. So the satisfied patient becomes dissatisfied. So whoever does, tell them not to tell anyone. But what normally happens, we want advertisement, na? So we tell sabko bolo. Never. Never. They will never come to you for the second time. Let them feel the result, they will come. Done. हाँ more sorry वाला हो गया, छोड़ दीजिए. मैडम देख लो सीधा, मैडम देख लो. मोनाली ठीक ଅଛି କୋଉ ଜାଗାରେ ତ abnormal irregularity yeah ସେଟା ଆଗରୁ ଥିଲା ନା ନା you can see lip रे एटू here like this नहीं कुछ नहीं चाहिए और कुछ नहीं करना है मुंह लगाए नहीं 5 years कमिଯିବ 5 years कमिଯିବ anyone wants to do fillers start କରନ୍ତୁ ଏଟା ଲାଇଭ କରିବା ଦରକାର ନାହିଁ start କରି ଦିଅନ୍ତୁ ଆମର ଅଛି ସାର୍ ଦବା ମ୍ୟାଡାମ ଡନ୍ so tell her yeah so for any patient and our patient is madam today not to see the mirror multiple times क्या हो गया so anxiety so we are always trying to underdoing things so there won't be any complication if you underdo if you overdo then only there is a problem so you need not see your face you need not tell to people that I have done if the patient is happy they will come back to you once again nothing kichi nahi nothing nahi madam kichi nahi हाँ এটা অফ করে দেবে
Sound আসছে? ହଁ ମାଇକ ଅନ୍ ଅଛି ଏବେ। ହଁ ସାଉଣ୍ଡ ଗଲା ଦେଖିଲେ। ଦେବଜିତ so very good afternoon to all of you. So now we have come to an end of live demonstration of lasers. Now we'll go for the dermatosurgery workshop. The IID Well Dermatosurgery, IID Well in association with ACSI, we have come up with a video workshop. So all the faculties are online, but here we are in the hall, all the delegates are sitting. So we'll be going live now. So before that, we'll have the message from our president, Dr. Samant Barua of ACSI.
principles which one must remember is replace like with like, think of reconstruction in terms of units, always have a pattern and backup plan, steal from Peter to pay Paul, but only when Peter. Flaps for dermatologist. A skin flap consists of skin and subcutaneous tissue with a partially intact vascular supply that is transferred or repositioned from an adjacent or more distant donor site to a recipient site. It is the recipient site is called the primary defect in dermatologic surgery. Is usually the wound resulting from the removal of the subcutaneous tumor. The secondary defect is defined as the wound that is created by cutting, lifting, or sliding the flap to fill the primary defect. The base of the flap is the area that remains attached to the skin adjacent to the defect and is also known as the peduncle of the flap. It contains the vascular supply necessary for initial flap survival. The tip of the flap is the portion of the flap furthest from the flap's base. A few principles which one must remember is replace like with like, think of reconstruction in terms of units, always have a pattern and backup plan, steal from Peter to pay Paul, but only when Peter can afford, never forget the donor area. Be thoughtful, be knowledgeable, and be prepared for failure and backup. It is indicated in benign pre-malignant and malignant skin lesions. It is contraindicated in active infection, colloidal tendency, bleeding disorders, and uncontrolled blood sugar. Diagnostic therapeutic application, primary wound healing, functional restoration, and excellent cosmesis. It requires a operative skill and learning curve and heals with a longer scar. After having taken the history and detailed examination, one must investigate, combine it with dermoscopy and skin biopsy, and in locally advanced lesions or where there is a regional lymph node, one must second it with FNAC or PET scan. Stop anticoagulant therapy, start broad spectrum antibiotic, take an informed consent, pre-operative evaluation, do a proper planning and design the flap properly. After anesthesia, do a rigorous undermining. Always take the incisions along the RSTL, execute the flap, hemostasis with pressure or cautery, undermine, and 2-layered suturing. Histopath and dermoscopic images of the instruments required. You can combine it with your L-man or your bipolar radio frequency. The rhomboid flap, it is the basic flap which all dermatologists should learn and begin their flap surgery with. Always keep in mind the RSTL and line of maximum extensibility, and the primary defect is excised in the shape of a rhomboid, and the flap is then rotated towards the primary defect, and it is sutured up in 2 layers and heals with a linear scar. Another case, pyloneedle sinus over the superior intergluteal cleft. Again, the same flap was done. This we would be seeing in the video at the end of the lecture. It heals with a linear scar. A case of basosquamous cell carcinoma in an oculocutaneous albino, a bilobe flap was done. The primary defect is in the shape of a circle and 2 lobes are created, the first and second one, so as to rotate it towards the primary defect at 45 degrees each. After having excised, 2-layer suturing, heals with a linear scar. Another case of basosquamous cell carcinoma, again the same flap was done. It heals with a hypertrophic linear scar. An interesting case of nodulo-ulcerative BCCs. Now here the upper pole BCC was subjected to O to Z rotational flap, and in the same setting I subjected the lower pole BCC to fractional CO2 laser with 5-fluorouracil. This was the result which I achieved after the first sitting. In the second sitting, I excised it and it was followed by a split thickness skin grafting. This is a before and after. A multiple BCC, the upper pole was subjected to A to T plasty. A circular primary defect is excised and A and T are created along with Burroughs triangle, followed by excising, incising, and suturing it up in 2 layers, heals with a linear scar. A case of nevus sebaceous, H plasty was performed. Again, this case would be seen in the video at the end. Suture it up in 2 layers, heals with a linear scar, before and after. Case of varicose hemangioma of the shin, here I chose to do a VY island flap as the skin is quite tense, heals with a linear scar. Reading man's flap, especially over the BCC over the infraorbital area, so as to prevent ectropion or entropion. Excise the defect in a form of a circle, create 2 Z and rotate it over each other. Same flap over the contralateral side. In another case, heals with a linear scar. A jigsaw puzzle flap, excellent modality to be used, especially in morphiform or recurrent BCC along the nasolabial fold. Excise it in the circular manner, create a jigsaw puzzle, and glide the flap towards the primary defect. Heals with a linear scar. Aged 80-year-old patient with a pigmented BCC over the neck. Here you have a good amount of lax skin. So I did a rhombic flap with 2Z plasties, sutured it up in 2 layers to heal in a linear scar. An interesting case of multiple pigmented BCC. Here 76 BCCs were subjected to liquid nitrogen cryo and 2 were subjected to a rhombic flap with 2Z plasties and Burroughs wedge advancement flap. This is your right side BCC and the left side BCC respectively, healed with a linear scar. He is under our follow-up for the past 3 years. Post-operative care, occlusive dressing along with antibiotic cover. Monitor the flap, tissue color, warmth, turgor, assess blanching, capillary refill time. Alternate suture removal on day 10 to 12 and remaining on day 18 to 21 on phase 7 days provided a good dermal buried closure has been obtained. There can be intraoperative or late complications and causes of flap failure, deficient blood supply due to poor anatomical knowledge, too much tension on the flap, local sepsis, tight dressing around the pedicle. Some of the complications which my patient developed. A properly designed and executed flap may provide a good functional and cosmetic outcome. Follow Carpenter's motto, measure twice and cut once, and understand the anatomy. One should be prepared for failure as well. In other modalities in malignant lesions, once the dermatologist achieves this surgical skill, one can start doing flaps. However, a good long-term follow-up is required, minimum of 5 to 10 years, so as to access in same. Now we will be seeing 3 videos of rhombic flap, biload flap and H-plasty after this. A 29-year-old male having a pyloneedal sinus 3 to 4 centimeters superior to the intergluteal cleft. Start by palpating nicely so as to include all the sinus openings into the rhomboid, which would be your primary defect. The primary defect is in the shape of the rhomboid, sides being of equal length and opposite acute and obtuse angle being 60 and 120 each. The lowermost pole, that is the inferior pole of the rhomboid, should be 2 to 3 centimeter lateral to the intergluteal cleft so as to prevent wound dehiscence as well as maceration. Depending on the anatomical position and RSTL and movement, one can choose any of the 4 limbs so as to draw the flap. After having drawn the rhomboid, I label it as A, B, C and D. From the point C, I would be extending a line having length of the shortest diagonal of the rhomboid. From here, I would be drawing an angle of 60 degrees inferiorly, and to the point CD, I would be drawing a parallel line, labeling it as E and F, F being the pivot point of the flap. I'm starting with my local anesthesia infiltration. Here I have used 2 cc of 2% lignocaine, 1 cc of 0.5% bupivacaine and 7 cc of distilled water in dilution so as to form a tumescent. I would start with my excision of the primary defect. Here I have used Elman radio frequency needle point. One can use the cold steel scalpel or the CO2 laser. Excise the primary defect, which is in the shape of the rhomboid. Visualize, examine after having excised the primary defect so that you have excised the whole sinus along with the base. Now we excise the flap. Again, I have used the Elmen with needle point. Coagulate the bleeder wherever required. Do a rigorous undermining over all the corners and start with your buried sutures. Here I have used Vicryl 30. One can also combine your subcutaneous and subcuticular sutures. This is to support your flap so as to prevent wound dehiscence. A 2 or 3 layered suturing is important, especially at such areas where there is higher chance of wound dehiscence because of mobility as well as moisture. After having done your subcutaneous and subcuticular suturing, start with your simple interrupted sutures. I would be using Proline 30. After having gone all over the side, topical antibiotic mupirocin cream followed by your occlusive aseptic dressing, broad spectrum antibiotic for 14 days, suture removal at day 21. Biopsy confirmed case of basosquamous cell carcinoma in oculocutaneous albino over the back. I'll be demonstrating the bilobe flap. The primary defect is marked along with surrounding 5 mm of normal skin in the shape of a circle. Draw 3 lines and extend it in the direction of the RSTL, first from the center of the circle along the radius extending outside the circle, and 2 tangents at 12 o'clock and 6 o'clock position parallel to each other. Join the 2 points and tangentia in the center of the circle. Draw a perpendicular line to the 3 lines, extending it at an equidistance to the diameter of the circle along the x-axis. This point is the pivot point of the flap. With the help of a protractor, mark 2 points at 45 degrees each from the pivot point and draw 2 lines in the direction of the angle. Draw 3 circles, outer, middle and inner circle, by extending the first 3 parallel lines, that is the 2 tangents and the central radius line, in the direction of the 2 angles drawn, such that the outer circle is 3 times the radius of the primary defect, middle circle is 2 times the radius of the primary defect, and inner circle is equal to the radius of the primary defect. Draw a circle with radius equal to the primary defect with periphery of the circle encircling between the tangential points of the outer and inner circle. This is the first lobe of the flap. Draw a 4th outer circle parallel to the 3rd outer circle with its radius 4 times the primary defect. Draw a semicircle with its radius less than the radius of the primary defect, extending its tip at an acute angle tangential to the 4th outer circle. Prepare the part and start with your local infiltration anesthesia. Excise the primary defect, which is in the shape of the circle. Here I have used Elmen with a needle point. Go up to the subcutaneous fat. One can also use the bipolar to coagulate the bleeder. After having excised the primary defect, we now incise the 2 lobes so as to form the 2 lobes. Undermine aggressively all around the surrounding area and rotate the 2 lobes towards the primary defect. Start with your subcutaneous and subcuticular suturing so as to support your flaps. Here I have used Vicryl 30. After having done the 2-layer suturing, we start with our simple interrupted suturing, skin surface suturing using Proline 30. Put the patient on a broad spectrum antibiotic Suture removal will be alternate sutures at day 14 and rest of them at day 21, being the back as a thick skin. This will be followed by your topical antibiotic cream occlusive dressing. The next case is a nevus sebaceous over the midline of the forehead. I would be demonstrating a H-plasty. This is a bilateral advancement flap. The primary lesion to be excised is in a rectangular manner. From the four corners, draw 4 lines extending the length of the line equidistant at the side of the rectangle along the RSTL. We now have 3 parallel lines of equal length along the RSTL as X, Y and Z, thereby creating a bilateral advancement flap on both the sides of the primary defect, forming the H. Four burrowed triangles are created in the 4 corresponding corners of the tip of the H so as to facilitate easy advancement of the 2 opposite flaps towards each other and prevent dog ear formation. The length of the side of the triangle being half the length of the side of the rectangle of the primary defect. X is equal to Y is equal to Z. A is equal to half of X. Prepare the part and infiltrate local anesthesia below the lesion as well as along the surrounding skin. We start by excising the primary defect. Here I will be using 15 number Bart Parker blade attached to 3 number handle. After excising the primary defect, do a rigorous undermining. The face being a highly vascular area, wherever possible, coagulate the bleeder using Elman ballpoint. Undermine rigorously, and now create the 4 corner limbs. Along with the Burroughs triangle so as to glide the 2 edges towards each other. Start with your subcuticular suturing using Vicryl 30. Bilaterally advance the 2 flaps towards each other so as to close your primary defect. We have put the patient on a broad spectrum antibiotic which we would be continuing up to 2 weeks. After the supportive suturing, one can start with simple interrupted skin suturing. Here being the face, I will be using Proline 50. Suture removal will be alternate sutures at day 14, rest of them at day 21. This will be followed by topical antibiotic cream and occlusive dressing. The beauty is that the 2 lines get merged with the forehead lines.
We had a lot of type and the amount of surgeries you are doing. So pleasure to meet you online once again. Our next speaker is Dr. Madhura C, another renowned dermatosurgeon of India. Dr. Madhura will be speaking on scar revision surgeries. Dr. Madhura is a consultant dermatologist, dermatosurgeon and hair transplant surgeon at QTIS Academy of Cutaneous Sciences, Bangalore. She has contributed chapters in various textbooks and her areas of interest are hair transplantation and flap surgeries. So over to the live video demonstration.
Hello everyone. Today I'll be speaking on scar revision surgeries. I'll be presenting various scar revision surgeries. We all know like there are various kinds of scars and they are basically what are the indications are basically the stretch scars with hash marks and depressed or discolored scar and contracted scars and puckered scar. There are also acne scars and hypertrophic scars are amenable for scar revisions. Though there are various scar revision techniques, today what I'll be discussing basically on the excision and closure, W-plasty, M-plasty and Z-plasty. So the patient evaluation, always the scar assessment becomes very important, and always rule out all the comorbidities and do the proper investigations which are necessary, and mark the RSTL lines and look at the surrounding skin and know the patient's expectations. So we need to follow the rules of surgical excision. Always hide in the junction of aesthetic units, hide in the relaxed skin tension lines, and always the edges should be well approximated with minimal tension or no tension. Always the edges should be clean with fresh, healthy edges, and always handle the tissue very gently and select the proper suture material. Coming to the excision and closure. This is a video showing an excision and closure. Basically, it is indicated for all the linear scars which are along the RSTL lines, and there are various variation in the excision and closure. Always give a good anesthesia, 2% lignocaine with adrenaline. Include the areas, surrounding areas also where we need to undermine. The important excision is excision tray. Skin hook is very important, and tooth jewels, forceps and iris forceps are important. Always aseptic precaution becomes very important in scar division surgeries, because any kind of infections will sometimes lead to a bad result. So always paint with a betadine properly and then drape the patient. And the next step is the incision. The incision should always be with a 15 number blade, and it should be always in one stroke, a bold incision to be given. And it should not be a cross hashing type of incisions where we do multiple strokes also. So once the bold incision has been done, so what I do is usually I take 11 number blade and I help, which helps me in dissecting the apex. The advantage of using the 11 number blade is it will not cause this cross hashing, which can happen, which can either happen with a 15 number blade. So once the incision has been done, the next step is excision and undermining. The scar which is being marked is excised, and it is held with a tooth adsense forceps, and either with the 11 number blade or with the 15 number blade, we need to excise the scar tissue. The proper depth excision becomes very important, and undermining, as a rule of undermining, always undermine on either side. If the scar size is 0.5 centimeter, you need to undermine at least the half of it on either side. And the level of undermining, it depends upon the site. And this is a cheek, so like we are undermining at the subcutaneous level. Next is the layered closure, and it becomes very important to support the dermal tissue with the dermal stitches. And I'm taking in like a buried dermal stitch with the 50 vicryl, and equal bites to be taken on either side, so that like it gets approximated like this very, very nicely. You can make out here. And once we have closed with the vicryl, the next step is to close the wound transcutaneously with a 60 roll-in. So this is either we can use in simple stitches with a Prolin 60. So the rule is always use a one size smaller when we are closing the transcutaneous, and always see that like we don't strangulate the tissue. Make out like absolutely there is no dog here, and it is closed with a gentle pressure dressing, which is usually removed after 48 hours. The next is, and you can make out like this is a CP scar which has been removed, and then you can make out the scar is very, very faint. And this is again a crescentric excision which has been done. And this is an S-plasty which is done on the chin area, and it has healed very well. Basically, it's a pigmented scar. So a similar type of excision can be used in case of serial excision, where when the scar is very big and we cannot, which is not amenable for the closure primarily, then either planning flaps become an important, or like we can do a serial excisions, and it has got a very low complication rate, and it is reliable with minimal morbidity between the stages. So this is a serial excision where we have removed at one stage, and in the second stage we have removed it completely. So basically the gap between the two serial excision should always be 3 months. This was one serial excision which was done and the patient became happy, and then we did not do another serial excision. So coming to the next technique, that is a W plasty, which is recommended in specific areas where the scars are oriented perpendicular to the RSTL or along or at an angle of an RSTL. And when the scars, when the length of the scar is more than 2 centimeters in length, it produces a regularly irregular scar with removal of some amount of normal tissue. So always here the series of V's and W's are created, and this is how like the RSTLs are marked, and a series of W's are created with an angle not more than 45 degrees and at the apex not more than 30 degrees. And the limb of each W is not more than 6 millimeters. So, and once the W is excised, a good undermining is done, and then the flaps are approximated, which will get complement in either side, and that's closed with the tip sutures. And this is how it is healed at the time of suture removal. And this is how it has healed well. You can make out like it's very good healing. So this is a video which shows the W plastic. So it's a scar on the forehead, a crooked scar, and then what we are doing is like we are marking a W, and care is taken that the limb of the W it's not more than 5 millimeters, and angles are well maintained between the W, and a good anesthesia is given. I usually prefer to give an intradermal anesthesia, though it is a pain, though it is less, it's more painful, but like the hemostasis is well achieved here. And whenever I'm doing a W plasty, I usually use a 11 number blade because it's very easy to cut the V of the W, and there will be absolutely no cross hashing, which can either happen with a 15 number blade. And once the scar has been excised, the undermining is done, and it's a forehead, so I'm undermining at the subdermal level. So once the undermining has been done, so what we do is we close it with an dermal stitch, and then later on the apex of the W's are approximated with a half buried dermal stitches. So this is how we are doing half buried dermal stitches. First we take a transcutaneous stitch, and then next is the tip, the dermis is taken from the tip, and then again we come out transcutaneously. So this is a 60 prolin what we are using, and you can make out like the V of the W complements on either side, on the opposite side, and care should be taken that we don't strangulate the suture. So once the V has been approximated, so what we are doing here is like we are putting a simple stitch in between the limbs of the W, and so wherever it is needed, a simple stitch needs to be put. Nowadays, what I'm doing is once I fix with the tip sutures, I also put a cyanoacrylate glue, and it has given me a good results. So whenever we are suturing, care has to be taken that the suture doesn't strangulate the tissue. So this is the same patient where we have done a W plasty, and you can make out how nicely it has healed. So this is again another patient where W plasty has been done, and you can make out like how nicely it has healed. The patient was very happy with the result. And this is again another surgery, what we call it as a geometric broken line closure. Here, the main difference between this and geometric W plasty is like in the W plasty, we take a V's, the limbs of V's are there, where here either it could be an semicircular, or it could be an square, or it could be triangle. So this is how it happens, and then otherwise it is exactly similar to the W plasty. So this is again a video where we are done an geometric broken line closure, where most of them are V's, and then the circular shapes are created, and then it is excised in a similar way what I showed for W plasty. So always a good bold incision needs to be taken, and here like 15 number blade is used than 11 number blade, because basically these are like semicircular, the shape is semicircular. So, and once this has been excised, it is closed similarly as we do it in case of W plasty. So this is the results of scar reduction with the GBLs. You can make out it is healed well. And coming to the next technique, that what we call it as an Z-plasty. So basically, the 4 fundamental functions of the Z-plasties are to lengthen the scar, to break up the straight line, and to move the tissue from one area to other, and to obliterate or create a web or a flap. This techniques is basically, it's a transposition flap. So depending upon the angle size, there could be increase in the length of the scar. So most commonly, like what we do is a 60-degree Z-plasty. So whenever we do it, like there is increase in the length of the scar by 75%. So this we should be well aware of it. So this is Z-plasty technique which I'll be showing. So this is exactly a perpendicular to the RSTL line. So what we are doing is we have marked the Z along the RSTL, and the 2 flaps which have been created or transposed. I'll be playing a video of the same. And then 2 flaps are fixed with the tip sutures, and then later on the dog ear has been corrected, and then this is how it happens. And then you can make out like he has healed well. The scar is almost, it's oriented in the opposite direction. So this is a scar which is present on the chin area. The scar is marked, it's a pigmented scar, and 2 limbs of the Z are marked at 60-degree angle and then along the RSTL line. And a good anesthesia is given here. Always in the phase, the bleeding can be more. So always give the anesthesia and wait for at least 10 to 15 minutes for the adrenaline to act. And the scar is excised in a similar way. Once the scar is excised, in the next step, what we'll be doing is, so we will be creating the flaps, the 2 flaps, which are incised till this subcutaneous tissue, and the 2 flaps which have been now incised are now undermined, means they are raised, and the surrounding scar is also undermined. So this is how we are undermining. So once the flaps are raised and then the surrounding of the scar is also undermined, always these flaps should be gently held with a skin hook. So you can make out this is how we are transposing. So and these are transposed, and they're fixed with a intradermal stitch. And these 2 flaps are now fixed with a 6-0 Prolin. So the tip suture, you can make out the first bite is a transcutaneous bite, and the second bite is a half dermal bite, which is taken from the tip. And then the third bite is again the transcutaneous, which comes out on the same side. Care has to be taken not to strangulate the flap. Otherwise, what happens is there could be a tip necrosis here. So once the flaps have been approximated, what we are doing is we are closing these 2 limbs with a simple stitches, and also a simple stitch is put in between the 2 flaps. So this is how it looks once we have closed. A gentle pressure dressing is applied here. So this is the same patient like where we had done one Z-plasty here, and this was a scar revision surgery which I showed, and this is how it has healed. So she looks much better. So this is a serial Z-plasty is what we had done. So first Z-plasty was done to show him how he would look, and then later on the serial Z-plasties were done, and this is how he looks after the Z-plasty. So you can make out on the forehead, absolutely you can't make out the scar is so much well aligned. So this is again in the periorbital area. It's very well healed. And next, coming to a next technique, what I call it as an M-plasty. Basically, the major advantage of M-plasty is to decrease the length of the scar. So here I'm just showing, it's not a scar, it's a mole. But similarly, we can do it for the scar also, especially the round CP scars, or like the broad scars can be, instead of, if the whole ellipse is removed, we get a very long scar. So instead of it, like an M is created at the apex. So the advantage of creating a ME is not, it also corrects the dog ear, and also the length of the scar is reduced, and we have a very small scar, and the ends of the scars have got a fish tail like appearance, which will not be visible to the eye like when it heals. So the next step is once the scar has been excised, what we will do is like we put an intradermal stitch at the center. All the scars has to be closed in layers because it will be always prone for the scar stretching. So once we are closed, what I'm doing is I'm closing this the tip of the M. So what I'm doing is I'm taking a vertical matrix stitch, and in between that I'm also including this tip of the tip, so that we can make out like once it heals, only this part of the scar is seen. The other two parts, like even the dog ear, is automatically corrected with this. Simple stitches are put. So always in the scar revision surgery, the suturing techniques becomes more important. A proper suture material and suturing technique needs to be selected. Sometimes if you are finding that like the wound's edges are inverting, then we can put a vertical matrix stitch. So this is again the same patient where we have done, and we can make out like hardly the scar is visible here. So this is at the time of suture removal, and this I can't even make out like where the scar is. So this is again an enplasty of the CP scar. So what is the post-op follow-up? Like basically we call after 48 hours, and then we will open the dressing and leave it open. Suture removal is done basically on the face at the end of 6th or 7th day. And we advise scar massage in patients, and few patients we also ask them to do the 595 toning. And in some patients we also do the laser resurfacing if required. In most of the patients, what we are nowadays doing is we are doing a Botox. This is a patient where we do an excision of the scar, and later on what we did was we did inject the Botox, and we can make out the kind of scar what she is having. It's like an amazing results. So basically the Botox, it will immobilize the muscle underneath, and then it prevents the stretching action, and that could be the reason why the scar has healed very well. We should be aware of the complications like secondary infections, hematoma formation, wound dehiscence, and stretch scars, which I have already, which I have seen. This is a CP scar which has resulted in a dog ear, an unpleasant experience, and this is again a scar, and then it has healed with some amount of pigmentation, and this is again the scar which underwent tip necrosis and did not heal well, and this is again a post-inflammatory pigmentation which occurred, and the patient was not very happy with that. And this was a secondary infection and wound dehiscence which occurred, and then it healed very badly. And this was again a scar on the jawline. We should always be careful because any scars, it always results in stretching in such areas. So to conclude, scar revision surgeries are very simple, reliable, and they are useful reconstructive tool. No single method is ideal for every patient and every scar type. A cosmetic surgeon should be well versed with the plethora of options available, and a significant degree of artistic ability and an individual modification is required for consistent results. And I thank the organizers for this opportunity. Thank you.
Ma'am, can you unmute so that we'll take up the question? Ask to unmute करे पे मिलो. Thank you, ma'am, for a nice presentation.
Thank you, sir.
Yeah. So, so I want to know that is there any specific time period, like after how many days the scar revision should be done, like after post injury, or scar is formed, for after how many days you will go for scar revision?
Yeah, ideally we tell like we should wait at least for 6 months of time. And I usually, after 6 months only, we should be going in for scar revision surgeries. So any trauma, anything like the scar remodeling keeps on happening till 1.5 years. That is up to 18 months. So once a scar is matured, so maturation, it takes around 6 months of time. So we can do it like after 6 months of time, sir.
Thank you, ma'am. We are
Okay,
having again a little bit of audio issues. Just wait for 2 minutes. Are you getting our voice, ma'am? We'll do. Then we'll go to the next topic.
They can't hit the odd one out. Yes, sir.
Yeah, actually, we are unable to project you on the seminar here, so we are trying to do that.
Mm-hmm. It's fine, sir. Like I was.
Yeah.
Yeah. Okay, sir. If there are no doubts, then we can go on with
Yeah,
the
we
next
can.
sessions.
Thank you,
Yes,
really,
sir.
thank you very
Thank
much
you, sir.
for
Yes,
ma'am
sir.
for your nice presentation. We'll go to the next
Yes, sir.
topic now.
Yes, sir. Thank you, sir.
So the next topic by Dr. Yogesh Pingadia. He will be speaking on excision and suturing. कोटी ऐसे कल ठीक
Good afternoon, everyone.
Dr. Yogesh Pingadia is the consultant at Shivani Skin Care and Cosmetic Clinic, Surat. He is the secretary of IDWEL Gujarat State Branch and dermatology and aesthetic practitioner with more than 30 years of experience. So with this, I think I'll go for
Good afternoon, everyone. First of all, I would like to thank ACSI Odisha branch to give me this opportunity to talk on excision and suturing. First of all, starting from the scar means crack, cut, or incision. It forms as a part of healing process following damage to the skin as body lays down the collagen fiber. If only epithelial layer is damaged, there is no scarring as it heals by regeneration of the skin. If dermal layer is involved, it will cause scar as it heals by repair. Once a scar, it is always a scar. It can only be revised to make it look better. Now, according to the classification of scar, the scar can be classified into so many, like mature scar, immature scar, linear hypertrophic scar, keloidal scar, irregular scar, geographical, widespread hypertrophic scar, contracture, and acne scar as an individual entity. Now, these are several pictures which I am showing of several type of scars. This is a post-traumatic scar which is having a well-defined margin with depression in the center, and the texture of scar of the floor is uneven. This is post-traumatic but immature scar, maybe 2 weeks after the surgery. And this is a very irregular hyperpigmented scar that crossing the upper eyelid, eyebrow, and extending from the temple left side to the cheek region. So it involves the structural unit of the face. This is a post chickenpox scar over the cheek, but the long axis is following the nasolabial fold. So it will be an easy scar for revision. This is irregular and complex scar starting from the lower eyelid to the angle of mandible, and it has 4 limbs surrounding. This is irregular scar with ill-defined margin, but the texture of floor is having even skin that matches to the surrounding skin. So if we use something like filler to put inside the skin and just to elevate the skin, and we can get the revision of the scar rather than the excisional surgery. This is a scar that extends to the angle of mouth, so precaution should be taken not to distort the structure of the opening of mouth post-operatively. This is again scar that extend to the angle of mouth, and to the left side laterally it extend to the ear. These are multiple scar over the face and they are lying very nearby. So all scar cannot be revised in a single session. So it needs to divide the session in multiple. This is post-operative orthopedic scar after the fracture reconstruction. The scar is linear, but there are also multiple scar of the stitch prick surrounding. This is again irregular hyperpigmented scar, which is having a complex or group lesion and lying over the bridge of nose, which is again a difficult site for revision. These are horizontal, well-defined scar over the forehead with something normal texture skin at the floor. This is again a complex scar over hair-bearing area of beard with altered texture at the floor. So majority of the scar are eligible for elliptical excision. They usually give better aesthetic outcome. Elliptical excision, as we see in detail, it is a technique used for removal of the superficial and subcutaneous skin lesion. The classical fusiform has a length to width ratio is 3:1 or maybe 4:1 and an angle of 30 degrees or less at the end of wound. Preferably, the elliptical excision should run parallel to RSTL, but not mandatory always to follow the RSTL if the morphology of the scar is not favoring. It is based on site, size, axis of the lesion, and the functional area that the scar crosses. While removal of the scar with help of elliptical excision, the incision should begin with BP knife 15 number blade. It should be perpendicular to the both end of the ellipse, and after the penetration the scalpel handle is tilted to 45 degree, and it should be a single stroke method. There should not be cross hatching and staircasing of the wound margin as shown in figure. Depth of the excisional tissue should be even up to the subcutaneous level to avoid the dog ear formation post-operatively. We can select the axis of excision along RSTL in round lesion, but while we have to follow the axis of excision parallel to the long axis in case of oval lesion. Surgical excision always gives better result than energy-based device, as they fulgurate the lesion, causing coagulation and ultimately leading to fibrosis and scar formation. Suture should be loose enough to maintain the underlying vascularity and tight enough to cause apposition of wound margin. The excision is done with holding the scalpel at 90 degrees with a single stroke method to avoid stair casing and cross hatching. The depth of the excised tissue should be even to avoid socialization effect after the closure. Overuse of tooth forceps can cause crush injury and allowing the growth of bacteria. So this is a list of several indications starting from benign to malignant lesion. It may be a cyst, infection, melanoma, basal cell carcinoma, squamous cell carcinoma, post-traumatic scar, as well as compound nevus, junctional nevus, and so on. It can also be used for diagnostic purpose like in biopsy. Now, about the ideal scar, the characteristic of an ideal scar which makes it cosmetically favorable are it should be an imperceptible fine line post-operatively. It should be parallel to the skin creases, folds, and RSTL for better post-operative aesthetic outcome. It should have similar color and contour as the surrounding skin. There should be no distortion of the adjacent structure. It should be at the level of skin. It should be well positioned on the face. Now, as a selection, patient should not be selected if they are having unrealistic expectation, and timing of the scar revision. Generally, every scar will show improvement without revision up to 1 to 3 years, but traditionally we can wait for 6 to 12 months after the trauma or the procedure, allow time for the scar to get mature, perhaps earlier for those poorly positioned. If early intervention is needed, it is wiser to do it after 8 to 12 weeks in adults and 6 months in children smaller than 7 years of age. Scar that should be considered for the revision are the longer than 20 millimeter of size, wider than 1 millimeter of the weight, disturbing the anatomic function and distorting the facial features, poor match to the surrounding tissue. It lies against RSTL and also lies adjacent to RSTL but not in favorable site and may be hypertrophied. So this is a small video presentation of the scar revision surgery. This is a scar in crescentic shape over the bridge of nose that passes horizontally. After painting and draping, this is local anesthesia. We have used Xylocan with adrenaline as an infiltration. This is 15 number surgical blade. We are excising the scar according to the shape of scar, that merging on either side to make an ellipse. The cut should be made up to the full depth. The scar tissue is removed up to the full depth, and this is the closure in form of subcutaneous buried non-absorbable sutures. Now, the level of break of this subcutaneous buried suture is at the level of lower part of the dermis and not in the subcutaneous tissue, as subcutaneous tissue cannot hold the bite. So, subcutaneous buried closure is done throughout the length, maybe at the interval of 3 to 4 millimeter to close the wound so that there won't be any collection, hematoma formation after the procedure. To keep in mind, the cutting of the subcutaneous suture should be from the base so that the thread do not have the extra threads at the end. So this is how it looks after subcutaneous closure, and after then the cutaneous closure is done in a vertical mattress suture. Now, purpose of both sutures are different. Subcutaneous closure will close the wound, and vertical mattress suture cutaneously will give exact apposition to the margin. Now, this is the scar which I have shown already. This is intraoperative picture with removal of the full depth of the scar, and this is post-operative after 15 to 20 days. And this is the final outcome at the end of 4 months. There is hardly a visible scar. Now, concept of using subcutaneous closure. In this case, there is a scar of oval shape over the bridge of nose. We have done elliptical excision, but with only single layer closure, that is vertical matrix suture, that we removed on 10th day. But over the time, it gets separated and gives a linear elliptical scar again. Now, if we put a subcutaneous stitches in the subcutaneous tissue, it gives a lifetime strength to the tissue, and that do not allow the tissue to get separated. But if we are using absorbable sutures, the tensile strength of the suture is 14 to 20 days, and after that duration, it gets dissolved, so that the surrounding tissue will pull it and give the separation linear railroad type of scar, so which is not aesthetically acceptable. So do use non-absorbable suture for subcutaneous layer closure. This is article that is presented in JCAS by me in last year about utilization of non-absorbable buried subcutaneous suture material in closure of elliptical excision in various indications for better aesthetic outcome. A case series of 155 patients presented in Journal of Cutaneous and Aesthetic Surgery. This is a scar over cheek that runs parallel to nasolabial fold. It's a marking of the planning to be removed. This is intraoperative, this is subcutaneous closure, this cutaneous closure, and this is post-operative outcome. There is hardly a linear scar visible at the end of 6 months. These are multiple scar over the forehead. The top one is the crescentic shape and the middle one is the horizontal shape. This is the picture on the 7th day of suture removal, and this is post-operative. This is a scar over bridge of nose with oval. So this is marking in an oblique axis of excision. This is intraoperative. This is subcutaneous closure. It's a cutaneous closure, and this is post-operative outcome. This is again a scar over the area just below the temple of the face. This is on 7th day, and it's a post-operative outcome at 4 to 5 months of duration. This is again a scar over nose. This is post-operatively, and this is the final outcome, crescentic scar over nose. This is post-chickenpox scar just above the medial end of eyebrow. Now, the shape of scar is oval, and that's why we have to follow the long axis of excision as per the axis of scar. So this is cutaneous closure, this is after suture removal, and this is post-operative outcome. This is a scar of irregular shape over temple of scar, so we need to excise according to the shape of scar. This is intraoperative, this is after subcutaneous closure, this is cutaneous closure, and it's a post-operative outcome. This is a hesitation scar over the forearm. It is very difficult scar to remove as the circumferential tension over the forearm is too much that do not allow the scar to heal properly. So we have done elliptical excision in the major visible scar, and this is post-operative outcome, though not complete, but we can give the just reduction of visibility of scar. And this is a scar that extends inside the eyebrow. We have removed it in the same manner of elliptical excision, and this is post-operative picture. This is a traumatic scar over eyebrow with disruption of the eyebrow. So this is marking of the ellipse, and this is post-operative outcome. This is again a traumatic scar, and this is post-operative. Irregular scar over the forehead. This is excisional marking. This is excised. It's again post-operative outcome. So all scar cannot be revised, as this is a hypertrophic scar over the forearm with hypopigmentation surrounding tissue due to ILS. So it is well camouflaged with help of tattooing, and it's not visible. This is xanthelasma palpebrae removed in the same manner of elliptical excision, and this is post-operative. Congenital melanocytic nevus with elliptical excision. This is post-operative. Compound nevus removed with the same manner. This is post-operative. This is again compound nevus with post-operative picture. Keratoacanthoma with good aesthetic outcome with no scar. The accessory tragus removed in the same manner. This is post-operative. This is basal cell carcinoma which removed with 0.5 centimeter of safety margin, and this is post-operative picture. So sometimes all scar do not give proper result due to some mistakes we made. So here the sutures are too tight, the margin are not in apposition, and the distance of the prick is not in even in all prick. And this is how it end up with the post-operative scar as well as pigmentation again. Here there is a dog ear formation at the end of the suturing, and there is a collection inside which gives a wound gap, and finally the scar again. This is 2-layer closure with the green marking shows the apposition of marking in well manner, but in red circle the apposition is not there and there is a gapping. So chances of wound gap will be there. So to conclude, the surgical knowledge depends on long practice and not from speculation. Thank you for listening.
A wonderful session by all our three speakers. A lot of take-home messages, a lot of questions. So, Dr. Yogesh, good evening. This is Dr.
Good evening,
Devjit
sir.
here. Among all the fans in India, I am also one of your fan.
You are welcome,
Learning
sir.
a bit or two from you on IJD group. And I see a very novel and practical approach. And nonetheless, even Dr. Sushil and Dr. Madhura had also wonderful presentations. So we have a few questions from our live audience here. If you could take up, or like any of the speakers can take up. Ideal time if for suture removal after.
Should I take it or?
Yeah, please.
Usually face and genital are a very vascular region, and I usually prefer the 7th day for the suture removal. And other than face and body parts, it is on 10th day it should be.
Yeah, this is a very important thing which Dr. Yogesh has said, that for face it is minimum 7 days, and for other areas 10 days. I keep suppose on the back or on the foot, I keep for around 2 weeks, around 14 days also I keep, because I have seen ruptures if I do before that. In the face also, I sometimes tend to keep it for 10 days, because in the mobile area of the face, again, sometimes that 7 days the healing is not complete. So do you agree with this?
There is a specific reason behind selecting the duration of keeping sutures over a particular area. So over the face, if we remove the sutures before 7 days, so there will be a chances of wound dehiscence. If there is a muscular activity in particular region that tries to separate the wound, and if we keep it beyond 7 days, then there is chances of visible wound indentation marks. So we have to balance in between. And I think second thing is the counseling, because we have to advise the patient not to give much more dynamic action over the procedure part, so that the separation will not be there.
Yeah, this brings me to a second question, which is a takeoff from the first question, that the mostly we hear that to use a suture of 5060.
Yes, sir.
But when I have asked surgeons, they say that 3040 is more than enough, and the marks, wound marks or stitch marks, are pressure marks, so they are not permanent. So what is your take? Like, why are we fascinated to use a 5060, and what advantage does it have? Because as we are using a finer suture, the wound strength will be also less. The maneuverability will be also a bit difficult. This is a question which beginners are asking.
Okay. I will. See, our branch is an aesthetic branch, and very minute changes give you the major outcome changes. So I think thicker sutures like 30 and 20 can give indentation mark, and it creates too much apprehension to the patient post-operatively. So what our duty is, we have to give the best aesthetic outcome. So we are collecting 2% of the result, 5% of the result, 8% of the result, and collectively give it to the patient at the end of procedure. So I think the thinner the suture, less will be the complication at the end of procedure.
I think it is highly subjective, and you gradually develop your own way to deal. And I think anything above 30 will be fine. And I don't think there is a big difference between a 40 and a 60. Like for normal, what we normal cases we do. What is your take on silk versus proline? Like what will you choose considering the cost factor basically?
Silk nowadays, I think no one is using because it is a polyfilament and chances of infection is very high. And proline or ethylone are the monofilament molecules, and the chances of infection is very less. So I think I do not prefer specifically the polyfilament.
Okay, yeah. Then why I would like to ask you that regarding W plasty and Z plasty, like we saw from all the speakers, but if you can sum it up, which to do where?
So in case of my preference, I usually fan of elliptical excision, and I go towards W plasty and Z plasty as a last option. So if it is possible to do elliptical excision, I will prefer the first, and then plasties are at the last option.
Yeah, absolutely correct.
It is not possible with elliptical excision.
I saw your video in that you had done, I think, penile surgery with some device.
Yes, sir.
Yeah, that was really interesting, and I would like our audience to go back to IGD page and see that. So that was really a very interesting, without a single drop of blood. Very interesting surgery that was.
Thank you, sir.
Really caught my attention. So thank you very much, Dr. Yogesh, for being
Thank you.
there and making the version into a very interactive live session. And I hope the sessions were very interactive for our audience, and they took a lot of take-home points. So we'll proceed with our further sessions, and I would request you to be with us if it is possible on your part.
Thank you, sir, for the opportunity. Thank you.
Thank you so much. We'll be inviting speakers like you. We'll love to invite you again and again.
It will be an honor for me. Thank you.
Thank you, Dr. Yogesh. Now we'll go to the next speaker, Dr. Samkit Shah, who is a MD consultant dermatologist at Bourne. the more technology, more technical glitches. So anyway, so these are all learning things for all of us also. So now I welcome Dr. Samkit Sahu, who is a consultant dermatologist at Urmil Skin Clinic, Happy. And to his credit, he has got many awards, starting from Dr. A.C. Parikh Award, Best Poster Prize at International Congress of Dermatology, Best Oral Presentation Award, Dr. S.L. Vatia Award, and he has also received the Resident Scholarship Award at WCT Vancouver, Canada. So now he will be presenting the basic nail surgeries. Over to you, sir.
Good afternoon, everyone. Today we will be talking about basics of nail surgeries. So here is the nail anatomy, which is a sagittal view of the nail. Dorsal view, we all know how to represent it or how to read it, but this is the most important part whenever we talk about nail surgeries. So here there is a double layered proximal nail fold, which is overlaying the nail matrix epithelium. So this is the proximal nail fold. This is the nail matrix epithelium. Then this is the nail bed. Okay, and this is thick nail plate, which is overlying the bed epithelium. And here is the phalanx. So this understanding of nail matrix is very important, because if we injure the nail matrix, then there will be permanent dystrophy of the nail plate. So we should take care that we should not injure the nail matrix unnecessarily. This is the nerve supply of the fingers or the toes. So here you can see there are two separate nerve supplies. One is on the palmar or plantar side and other is on the dorsal side. So we need to take care that whenever we do any nail surgeries, we anesthetize both the areas properly. So here I will not be discussing too much of theory. It will be more of video demonstrations. And so first I'll be starting with the proximal digital block. So here, as you can see, we are injecting in the proximal area, just near the junction of the toe and the sole. So injection has to be very slow. Here I have kept in a little fast forward motion. Injection has to be done very slowly. I'll play it again. Injection has to be done very slowly and gently. We directly go inside, aspirate, see we are not inside the blood vessel, and then start injecting very slowly. Then, as I showed, the nerve supply is present on both sides, that is towards the plantar aspect also and towards the dorsal aspect also. So we need to see that we are infiltrating the anesthetic agent in both areas. This is a distal digital block, mainly useful when we are just dealing with single nail matrix areas, or when we want to do nail matrix biopsy. So here the infiltration is done just 5 to 8 millimeters proximal to the junction of lateral nail fold and proximal nail fold. Here also we should take care that injection is very slow, and this area is little more painful as compared to proximal digital. Next, we will move on to intralesional therapy for nail unit. There are certain cutaneous conditions like lichen planus, psoriasis, 20 nail dystrophy, which affect nail matrix, nail bed, or both, resulting in nail plate dystrophies. This is sometimes cosmetically not acceptable to patient, and it can also lead to functional compromise, which is distressing for patients. So why do we need intralesional therapy? For such conditions, it becomes very difficult to start a systemic therapy for an area involving only 2 to 5% of the whole body surface. Second, systemic therapy needs long-term compliance, which needs regular, continuous maintenance of treatment and monitoring in terms of side effects. Third, it takes a long duration to show response, which is very difficult. So what are the benefits of intralesional therapy? It is easier to access difficult to reach areas like nail matrix or nail bed with intralesional therapy. It helps in creating a depot of drug in the desired area, and we can directly attack the affected area. What are the types of intralesional injections? First is intramatricial injection. Second is intra-bed, that is in the nail bed. And third is hyponychial injections. So this chart is very important in terms of where to give injection for which conditions. Suppose if nail matrix is affected, The signs would be pitting, onychorexis, leukonychia, thin nail plate, focal onycholysis. In such cases, it should be intramatricial injection. Where there are affection of nail bed like subungual hyperkeratosis, onycholysis, splinter hemorrhages, in such cases, the injection has to be in intrabed layer. Then if there is excessive subungual hyperkeratosis, onycholysis, it is to be given in hyponychia. Then nail folds. If there are lesions over nail folds, psoriatic lesions, bullous lesions, lesions of lichen planus, then even translesional injections can be given. Even warts, we see many times warts are present on lateral nail fold or proximal nail fold. In such cases, translesional injections can be done. So intralesional injection mainly consists of triamcinolone. It is the most used agent in terms of intralesional injections of nail unit. Nowadays, intralesional methotrexate, intralesional biologics are also being administered, but still the amount of data is very low. So when triamcinolone and xylocaine is injected locally, it plays a great role in achieving faster response. Optimum interval is 3 to 4 weeks. Response is positive in 70 to 90% of the cases. Why triamcinolone? It has a longer duration of action. It has small particle size, high stability at room temperature, easy resuspension with shaking, and lesser effects on pituitary adrenal axis. So here we will understand where which type of injection is given. So when we give intramatricial injection, it covers or diffuses in this area and creates a depot in this area, which will further improve the diseases which are affecting the nail matrix. So here is a small video of intramatricial injection. So we are entering 5 to 8 millimeter proximal to the proximal nail fold, and we need to take care that the needle is slanting at a 45-degree angle and the drug is getting injected just in the nail matrix. You can see there is a blanching in the nail plate which can be seen just near the lunula. Here also you can observe there is mild blanching, and this shows that the injection is being given at a proper location. If we go very deep and if we are touching the periosteum, then the amount of pressure required to inject would be more. In such cases, we need to retract and come in properly. Then intra-bed injections. This is the area where intra-bed injection has to be given. In intra-bed injection, we can use the same technique as intramatricial injection, but we need to go a little more deeper. Just not in matrix, we need to move little distally and then release the drug. Then last is hyponychial injections. Sometimes what happens is the diseases affecting the nail unit, they are not just present in the matrix region or the bed region. They are also present in the hyponychium region. So whatever drugs are injected in the matricial layer or the bed layer, they cannot provide desired effect in hyponychial area. So in such cases, we need to go for hyponychial injections. Here we can see we have to enter gently and release a small amount of drug. This is little painful and difficult injection because diffusion of drug is not easy in this area. So it has to be done gently. If needed, you can retract and then go again inside and then inject properly. Then this is a demonstration of intralesional MMR therapy for warts. Usually when we see warts on palm, they are affecting the fingers as well as the nail area. So here we can see we are injecting in the wart which is present on proximal nail fold. The injection has to be gentle, has to be slow. The pain usually appears due to diffusion of the drug in tissue, which causes tissue expansion. So we need to inject it very slowly. The injection has to be done in the base of the wart, and we need to repeat the sessions every 14 days. How to make procedure comfortable? We should use thinnest needle possible with bevel side up. So I usually prefer insulin syringe as it is a lock needle. So there is no need of doing a lever lock or taking care of back splashing or extra pressure. So insulin syringe is most preferable. Inject very slowly. Topical anesthesia helps in reducing just entry pain, which is as also very nominal. We can use ice packs prior to the injection. Use of vibration or pressure to also sometimes helps, but most important thing is slow injection. Side effects which can occur are pain, subungual hematoma, secondary infection, nail fold hypopigmentation, vasovagal syncope, and hypersensitivity reactions. Vasovagal syncope can be avoided if patient is lying down in a proper position. Secondary infection and subungual hematoma can also be avoided if done in a proper technique. Nail biopsy. When do we do nail biopsy? When we want to differentiate between mycotic and psoriatic nails, differentiate between subungual hematoma and melanoma, differentiate between benign and malignant subungual and periungual tumors, diagnose cause of nail dystrophies. Contraindications, peripheral vascular disease, uncontrolled diabetes. If patient is on blood thinners or patient is on beta blockers, we should take such history properly, because that will lead to difficulty in healing, or it can even cause problems during the procedure. So this is a schematic image of which area to be biopsied. So for nail plate biopsy, we can take a nail plate biopsy from this area. Nail bed biopsy, we need to go inside. We need to first remove the nail plate and then take nail bed biopsy. Then distal nail matrix biopsy is done just near the lunula. Proximal nail matrix biopsy is to be done by lifting a skin flap. And then there is longitudinal nail biopsy, where whole of the lateral nail fold, then proximal lateral nail matrix area and the lateral nail plate. This whole area is excised. So nail plate biopsy is usually done in case of onychomycosis, warts and nail psoriasis. Nail bed biopsy to distinguish between conditions with similar pattern like onycholysis or subungual hyperkeratosis. Nail fold biopsies for nail fold tumors, and nail matrix biopsies for benign lesions of nail matrix, malignant tumors or acquired nail plate defects. So here is a small demonstration. First we give anesthesia. This is the distal digital anesthesia, then little bit of exsanguination to reduce the blood of that area, and tying a tourniquet, and then using a 3.5 mm punch and rotating. Here we need to apply a little bit of pressure. It is difficult to penetrate inside, using tiny iris scissors to release the tissue. So here we have done a nail bed biopsy along with the superficial plate. This is a small demonstration of nail matrix biopsy. Again, a small anesthesia. We wait for 4 to 5 minutes after giving anesthesia so that the desired anesthetic effect is achieved, creating a small slit, 2 cuts, which will help in releasing the slit. Then using a punch to go inside. When doing nail matrix biopsy, we should take care that we go deep. The layers are very small in this area. We have the proximal nail fold, then the nail plate, nail matrix, and then there is periosteum. So we need to go deep, and we should allow our punch to touch the periosteum and then come back so that we get the desired depth of the biopsy. Otherwise, the depth will be very superficial and the procedure will not be able to give the desired diagnosis. The samples should be sent to dermatopathologist to get proper diagnosis so that the procedure is worthwhile. And ingrown toenails. Ingrown toenails are also known as onychocryptosis or unguis incarnatus. Usual etiologies are improperly trimmed nails, hyperhidrosis, poorly fitting shoes, severe damage to nails, and frequent relapse are most common problems. Types of ingrowing toenails. Subcutaneous ingrowing toenail, hypertrophy of lateral nail fold, inward distortion of nail, distal nail bed embedding, and ingrowing toenail in infancy. Usually the ingrowing toenail in infancy resolves by itself. Common treatment options are warm water soaks, cotton wick insertion in lateral groove, debulking of lateral nail groove, complete nail avulsion, partial nail avulsion with matrixectomy, wedge resection of distal nail edge, and plastic tube insertion. So here I'll be demonstrating a short video of lateral nail matrix phenolization. First is surgical preparation, followed by anesthesia. So here I'll be penetrating inside, just touching the bone and coming 1 or 2 millimeter back, and then injecting the anesthesia. We have to take care that we are infiltrating both the plantar area as well as the dorsal area, so that we get a proper anesthetic effect. After injecting anesthesia, usual quantity required is 1 to 2 ml to achieve proper anesthetic effect. We wait for 2 to 5 minutes. Then we do milking of the area, which helps in reducing the blood flow of the area to be operated. followed by tying a tourniquet. Tourniquet can be, material for tourniquet can be a sterile gauze, can be a gloves, which is bone, and then we can cut it, or we can just cut the edges of gloves. We can just cut the edges of the gloves and tie it properly like I'm doing here. So the instruments, what I usually use is only 3 instruments are required. One is the nail splitter. I usually use a scissor which has a small edges so that they can penetrate beneath the nail plate, as well as here there is a small edge which helps in penetrating beneath the proximal nail fold. Then nail separator and a small forceps. So then we start separation of lateral nail fold. Usually the movement should be to and fro, not side and side, because this helps in releasing the lateral nail fold from the nail plate. Then we are separating the proximal nail fold from the nail plate, which will help in easily removing the nail plate which we are desiring to be removed. Then we insert the spatula beneath the nail plate and move in a to and fro motion and enter beneath the nail plate. And then with slight twisting motion, we can release the nail plate which was attached to the matrix. Once this is done, we will use a scissor to cut the separated nail plate. We can also use the anvil nail splitter, which is usually the most commonly used instrument for separating the nail plates. Once the nail plate is removed, here we can see there is a lot of hypergranulation tissue because of long-standing ingrown toenail. We will be removing the granulation tissue. The tourniquet should be kept for as small time as possible. If the procedure is going to last more than 8 to 10 minutes, then you can release the tourniquet for 2 to 3 minutes and then re-tie tourniquet and then complete the procedure. So here we have cleaned the granulation tissue. Now we will be applying the phenol. So phenol is the preferred agent for doing matrixectomy. Phenol is applied at the nail matrix and kept for 60 seconds, and such 3 rounds are to be done to achieve complete matrixectomy. Other agents like TCA can also be used. Even radio frequency or CO2 laser can be used, but most preferred technique is phenol. So this care has to be taken that the phenol does not get applied a lot to the lateral nail folds, because sometimes if there is excessive phenolization of the lateral nail fold, it can lead to necrosis of the tissues, and then the healing takes a huge time. I had one case which took almost 2.5 months to heal. So we should take care that the application of phenol is in a very proper way, followed by application of antibiotic ointment and then dressing. So this is a small video of nail gutter splinting with plastic tube. The video is provided by Dr. Manas. So here a small plastic which is a slit in between is inserted from the distal end and pushed towards the proximal end. So this is usually helpful when there is more distal ingrown toenail, where we have proximal ingrown toenail or retronychia. In such cases, this procedure is not helpful. Once the tube is inserted, we can do a dressing, and then patient can come back after 8 days. Now, after doing, what are the points to be remembered? While operating, we have to respect the boundaries of ventral or proximal nail matrix. This is the proximal nail matrix. Then we have to take care of the distal nail matrix and the extensor tendons, which are very near to the proximal nail folds. So we should not be overly aggressive while doing surgery and injure this areas. Post-operative care, Limb should be kept elevated for 48 hours to ease pain and facilitate healing. Patient should not plan to drive himself or herself to the home. Bleeding and soaking into the dressing can occur, so change of dressing may be required on day 2. Complications: immediate post-operative edema and pain, bleeding, infection, trauma to matrix can lead to nail dystrophy, and recurrence can happen if there is incomplete removal. This is a very rare case which we had dealt with. This is severe ingrown toenail with hypertrophic bridging. Patient had this condition for almost 2 years, and she was a 35-year-old female. So first, the hypertrophic bridge was excised, followed by the excision of the lateral and medial nail folds with germinative proximal nail matrix. So this is known as Vinograd technique, where the wedge resection is done towards both lateral and medial nail folds along with nail matrix. Even the nail plates were resected on both sides, followed by suturing. And this is the result which was seen after 1 year. So we need to see that we take care of such cases also, because nowadays we are seeing such cases where there is severe ingrown toenail with hypertrophic bridging. Thank you.
कंबल देना
Thank you, Dr. Sankit, for a nice presentation on various aspects of nail surgery. So now I think directly we'll be going to the next speaker. Next speaker, Dr. Devdeep Mitra. So Dr. Devdeep Mitra is the professor of dermatology in Command Hospital, Bangalore.
Good afternoon, one and
So you heard his name wherever there is a quiz program. So he has a gold medal and distinction in Maharashtra University. He was the runner-up at IDBL JSK quiz master for several states and national level. And he is a master in dermatology surgery, basically the vitiligo surgery and acne scar surgery. So with this, we'll go to his presentation. About you, sir.
Some few practical steps and what we are looking forward to. So basically, once we talk about vitiligo surgeries, it is about, today I'll be speaking about vitiligo surgeries, how they have evolved, some few practical steps and what we are looking forward to. So basically, once we talk about vitiligo surgeries, it is about tissue grafts, which includes suction blister, punch epidermal sheets, follicular transplants. Then we have something known as cellular grafting techniques, melanocyte culture techniques. And then there is a mixed bag, which has got tattooing, camouflage. So I'll be decoding the how it is to be done, the basics, and thereafter sharing a few practical tips. Okay, so now what happens when we decide to do a vitiligo surgery? The most important thing is stability of vitiligo, which is considered to be 1 year, that the patient should not have any new lesions, no keratinorization. Now, there are certain new other molecules which have been mentioned, but they are still in the textbook and in the research stage. The basic thing is patient counseling before any vitiligo surgery. So at the recipient site, we must remember that a patient or areas which have got an increased vascular supply or a follicular density has got a better outcome. Dermoscopy can assist us in assessing stability of vitiligo. And here I must emphasize that segmental vitiligo is totally different as compared to generalized vitiligo, both in terms of treatment, pathogenesis, and the surgical outcome. Segmental vitiligo has a much better outcome as compared to generalized vitiligo. Now, the positive indicators here obviously is a stable disease, a segmental vitiligo, and lesions on the face and neck. So these are some of the pointers which can help us in deciding a patient of vitiligo surgery. Any past medications is also important in deciding which surgical procedure we are going to take in our patient. Stability, as I've mentioned, there are no new lesions. Existing lesions should remain in size, absence of chimerization, and we can even do a positive mini graft test. A few grafts are tested after 3 months, whether the graft take is good, the donor area repigments well is a good indicator. So now coming down to the tissue grafting techniques. In this, something which is coming up in a big way is the epidermal harvesting system or the cellutome. This is a machine which uses a negative suction pressure and creates small microdomes. It's actually a modification of punch grafting technique. I'll just be emphasizing the advantages. The cost of this machine is around 1 to 1.5 lakhs, and the blades need to be changed for every patient. They are not usable. Rest of the machine, this vacuum assisted system, is reusable. So this is basically what is done in this procedure, is that a negative suction pressure is applied and these blades are fitted on the thigh. Generally no anesthesia or any topical anesthesia is also not required. The patient has to lie stable for about anything between 1 to 1.5 hours. Small microdomes are created, which gets attached to the tegaderm sheet, which will be attached to this blade once the procedure is over. This procedure is very safe, convenient. Just to cut these microdomes, this is when the system is on, the machine or that vacuum assisted part has been placed on the thigh. These are the small mini punches which are created. They automatically get transferred to the tegaderm dressing. The advantage is at the donor side, there is hardly any scarring. The skin repigments excellently, and look at the color match, which comes generally at about 28 days. And there's just a faint erythema at the time of after about 7 days, which resolves on its own. So the biggest advantage of doing this cellutome technique, which is basically an extension of the punch grafting, is at the donor area, we do not get any scarring. That's number one. And secondly, the punches or those small microdomes which are created are very superficial. They're devoid of any dermal tissue. In vitiligo surgery, the basic diktat which we are taught, or which is conventional, is that we should have as less dermal tissue as possible for the best outcome. So this was the first thing which is practical and which can be used in the OPD setting. Now coming down to the cellular grafting techniques, what I'll be discussing is that something about taking the graft or taking a thin epidermal sheet. We have the Humby's knife, we have the electrical dermatome, but they are slightly expensive. But there is something which is easily accessible and very easy to do, is using and just an artery forceps or a needle holder and a stainless steel blade. The stainless steel blade which I'm mentioning here is the normal blades that were used in the erstwhile era for shaving beard. This blade is readily accessible. Okay, the problem here is that we should the learning curve is there when using a shaving blade. The advantage: easy, readily available, cost effective, but it is the learning curve. But just in a couple of patients, we can just try it out and we'll be able to deliver a very thin epidermal graft devoid of any dermal tissue. The next practical point which I would like to share is we should not be using lignocaine and adrenaline while giving a field block or while giving a local infiltration when we are obtaining a thin epidermal sheet. The problem here is that we should know when we are reaching a level of pinpoint bleeding. So it should be plain lignocaine infiltration, which is advised. Now, once this first step is done, we will be shifting this epidermal thin graft into a trypsin media. Now, this trypsin media has to be kept at a refrigeration, that is in the freezer compartment, and it has to be transferred and it has to be slightly brought to room temperature before we transfer this epidermal graft to the trypsin reagent. Why trypsin? Trypsin is basically used to separate or separate the epidermis from the dermis. Now, the biggest question is, where do we all get these reagents for? So at the end of the presentation, I have given my email address and telephone numbers are there. These will be available from any of the high media or Sigma Aldrich company. These are the two reagents which are required: trypsin EDTA solution and Dulbeco's modified Eagles medium. Along the instruments, we require petri dishes, we require this incubator, a centrifuge, and these centrifugation tubes. I'm not discussing the melanocyte transplantation procedure in detail here. I presume that this has been showcased in so many different other conferences and the audience is aware about it. Now coming down to preparation of the vitiligo part. Here we will be using either a diamond dermabrader or the defocused mode of carbon dioxide laser or a manual dermabrader. Anything can be used. A slight modification here is using of hydroxymethyl cellulose gel to the cell suspension. This is how it is done. It just adds some viscosity, putting up the collagen dressing and tegaderm on top. This gives a good pack at the recipient area. Now coming to the melanocyte culture technique. Here we require a medium called M2 medium by Sigma Labs. This is the code. Why we are using this is we need to multiply the melanocytes and keep the keratinocytes and the fibroblasts at bay. Otherwise, they will multiply at a very fast rate. So apart from these M2 media, I require the T25 tissue culture flasks and the incubator for doing a melanocyte culture technique. And the biggest advantage of doing a melanocyte culture technique is that we are able to cover about 100 centimeters square of skin just with 1 centimeter square of skin. That means that we are able to extrapolate our entire multiplication by about 100 times. This is how the log phase growth of melanocytes take place. The cells multiply. Now, within about a week, it reaches a plateau stage. Now the fibroblasts take over. So we need to subculture. Subculture means we need to change the media. I'll just be showing how we generally do it. This is on day 2. We need to do it every alternate day. We need to, using a sterile pipette, we need to withdraw and take out all the contents of the tissue culture flask, transfer it to M2 media, put in some fresh amount of M2 media and gently rinse the T21 flasks. Now this procedure is important because there are some cells which may still be there, and we will be pipetting out the entire contents and transferring into the fresh M2 or even DMEM medium is fine. Thereafter, the next step would be that we would be taking some amount of trypsin and adding it to the T21 flask. Now, what this trypsin does, it will detach the cells which have got attached to the surface of this T21 flask or this tissue culture flask. We gently tap the ends, and thereafter we will be adding some amount of antitrypsin to prevent the action or the excessive action of trypsin, and thereafter transferring these cells back to the stock solution, because this change of liquid or change of media is very vital every alternate day. The entire success of this procedure called melanocyte culture actually depends on this procedure of changing the fluid every alternate day for a total of 21 days. This 21 days is the time which is for which we keep the melanocytes in culture bottle, changing this media every alternate day and at 37 degrees Celsius in an incubator. This is the stock, finally the cell pellet which we have found, and from we will be discarding the supernatant fluid, the DMEM solution. From this final solution, we would again apply some amount of DMM, rinse it, and we would be using this cell pellet, loading it on a new bar chamber. Now, loading it into a new bar chamber is to verify as to how much the melanocytes have increased. This is how we load a new bar chamber, just to see the density of the melanocytes. And using this we can justify, or we can see as to how much this number of melanocytes has increased as compared to its initial density. we also need to check the color of the M2 fluid, because if there is any turbidity, we would be sure that there is some bacterial growth and we might have to discard the culture. And this is the final step wherein we, after the centrifuge and the pellet has been obtained, we reload it into the T21 flasks and transfer it to our incubator, where it will be kept for a total of 21 days. We must make sure that there is an even distribution of the fluid and it just doesn't collect in one of the pockets of this T21 flask. So once we are done, I'll just be highlighting how trypan blue, and these are the dead melanocytes because it is a very vital stain. So a few practical tips: we can use cold trypsinization, phosphate bluffer string, trypan blue I've already mentioned, dermabrasion by laser. My practical experience, patients whom we have done a laser removal have responded well. Certain other modifications, there's a branded kit known as ReCell kit, which has got multiple wells and chambers. And thereafter, we have a 6-well technique in which in one setup, we have all these reagents placed together and they are used. Thereafter, we have certain other modifications. Now, there is something which is coming up new. This is about dermal mesenchymal cells. As I mentioned in the beginning of my presentation, that dermis should not be there in a cellular culture, or less amount of dermis in tissue culture grafts. But this is something which is new. Now studies have found that dermis incubated in collagenase kept overnight has got a better result, or these dermal mesenchymal cells, if they are transplanted along with the non-cultured epidermal cell suspension, the outcome is much better. The basis of this is the repigmentation which is observed mainly in cases of palms and soles, where, as per logic, this is the dermal cells which are causing this repigmentation. So this dermal mesenchymal cells, the dermal substrate is mixed with NCES at a ratio of 1:1. The CD90 dermal mesenchymal stem cells are present, which have been demonstrated on immunohistochemistry, something which works in this procedure. Now, the advantage is that the patient with a very short stability, say at least about 3 months, there is a better repigmentation. The CD8 plus T lymphocytes, which is the main culprit in vitiligo, are inhibited by these dermal mesenchymal cells, so the outcome is better. That's what it has been claimed. Now, a word about the hair follicular stem cell transplant. This is how it is done. These are the hair follicles which we are taking from the occipital area. This is just local infiltration. We require a very small area, or the donor area is quite small. This is how the grafts are obtained. And this is a normal technique as we follow for any other hair transplantation procedure. But the difference is that the number of grafts that we will require is very, very minimal to cover a large surface area. So these are few of the advances these are practical advances which are being done. I'm not talking about something or a molecule which is still in the research stage. Hair transplantation or hair follicular suspension graft is being done routinely, and it is very successful and it's easy to obtain. So this is how we obtain the grafts, and it's quite a simple procedure and it doesn't take much of time. This is the grafts which are kept in DMEM medium. So that is, again, we can still use Zinger's lactate, but DMEM has got certain other advantages. And thereafter, the donor area, what we need to do is, this is the donor area. There's absolutely no scars which will be visible after the procedure. The donor area is just dressed with mucosa. Just look, there's a very little number of grafts which are taken up. The donor area is dressed and the patient can continue. There's hardly any downtime after the procedure. That is one very, very big advantage of this procedure. The moment the donor area is done, okay, the only other important thing is that the patient should have black hair. Graying or hairs are generally not acceptable to be taken for this kind of procedure. The next step would be that we dress the donor area and shift over to the vitelliginous areas. Now, once we have obtained these grafts, now this is the procedure how we separate the grafts in DMEM, because we are not in, we don't want the hair follicles here. We are in fact interested in that bulge region where we have these stem cells. Now, these stem cells will go and multiply in the vitelliginous areas and cause repigmentation. This is a procedure which is quite similar to separation of epidermis and dermis in non-cultured epidermal suspension technique. This is again quite a simple technique. We just separate out the hair strands or the hair follicles. What remains behind is the bulge area along with the dermal matrix, a little amount of dermal matrix that is then transferred into this DMEM. It is then centrifuged and the cell pellet is obtained. Just briefly about the vitellogenous areas. Here again, we must remember that we should not be using lignocaine plus adrenaline. We should be using plain lignocaine. Why plain lignocaine? Because if we're using a manual dermabrader or if we are using any kind of other dermabrasion technique, we must know once we reach the level of pinpoint bleeding, because that is the level once we have reached the dermoepidermal junction. Using lignocaine with adrenaline or using adrenaline will cause vasoconstriction and we'll not know exactly as to what is the level of dermabrasion. We must dermabrate slightly more or extend the areas, and we must mark the areas. Again, that is one more practical point which I would like to share. Just marking the outer areas actually helps, because as you can see, once we are doing a dermabrasion, the entire area gets faded away, the margins are faded away, and we are not very clear as to how much do we need to dermabrate. This superficial dermabrasion is done till we reach the level of the pinpoint bleeding. That is the level where we will be transplanting our cell pellet, which we have obtained either by non-culture technique or by the hair follicular suspension technique. This is basic dermabrasion using electrical dermabrasion. This we will be doing at all the vitellogenous sites. Now look, once we are doing it, if the side markings are not correct, we will be extending beyond the margin and we would not know exactly how much to proceed. This is removal of the superficial epidermal skin so that we can put our graft or put our suspension on this area. After this, the dressing would be done and the patient would be immobilized for about half an hour inside the OT, and thereafter the patient leaves, the dressing stays in place. This is diffuse pigmentation after epidermal suspension. The diffuse pigmentation is important because if it is only post-trauma, then it would be perifollicular. A diffuse pigmentation means that we have done a successful autologous melanocyte transplantation as compared to a spot-wise perifollicular pigmentation is something which we need to avoid. Again, we can see that this is post hair follicular sheath compression. Even leukotrichia can be treated. Just within 2 months, we have found this. Acral areas, we have done a melanocyte culture. The treatment outcome is not that satisfactory. Now, these are few of the complications. On the bony prominences, inadequate pigmentation, disease can get reactivated because we are not treating the disease particularly. Even the donor area got depigmented in one of this procedure. Now, a word about platelet-rich plasma, which also has been used as one of the media. This can be used in place of DMEM or Delbecque's modified Eagles medium. Lasers and energy-based devices are coming up in a big way. And something in the pipeline is helion neon laser. A word about camouflage. This is something which we need to offer to our patients much more often. Camouflage is something which is easily accessible. The patients need to be motivated about this. It can both be temporary and permanent. Permanent in the form of tattooing. We have liquid dyes. We have got foundation-based devices readily available. And a word about depigmentation. If the vitiligo is extensive, we'll have to go for pigmentation. Future perspective. So I would like to conclude about stability, camouflage, and the melanocyte culture techniques. Thank you very much, ladies and gentlemen.
Thank you, sir. Thank you, Dr. Devbi Mitra, for your nice presentation on vitiligo surgery. So, so we'll go to the next speaker, Dr. Pradeep Kumari. Ma'am, are you getting my voice?
Yes, I'm getting your audio. Am I audible?
Yeah, yeah. So, can you project the?
My screen needs to be shared, Dr. Manas.
Yeah, just a minute, ma'am. We are putting. Just a minute, ma'am. We are putting the CV now. Pradeep Kumar. Fine. नहीं छ ଏଇଠି ମୁଁ ଖୋଲି ଦଉଛି।
It's okay, Dr. Manas, if it is not happening, just allow me to share screen. I can start.
Yeah. Ma'am, he is actually working on it. So he's just doing that one. Yeah.
Okay.
So Dr. Pradeep Kumari, ma'am is our actually ma'am, previously she was Joint Secretary of ACSI, and now Madam is DVD and practicing in Pune. The present affiliation is Skin and Surgery International Pune and Asia Institute of Hair Transplant Pune. So she is having many presentation, more than 100, and many publication to her credit. And I welcome you, ma'am, to the same hall. You were there few years back when I was in the department, and you had demonstrated many live cases here. So the same audience, same hall here is waiting for you for your presentation.
Thank you. Good evening, everyone. I have very nice memories of visiting that hall and the medical college department. In fact, I've been there twice, thrice. So without much ado, thank you for patiently waiting for this presentation. Let me start. So this presentation is basically regional nerve blocks in dermatosurgery. So where do we give regional nerve blocks is mainly these areas: face, scalp, digital nerve blocks, wrist blocks, and ankle blocks. Out of this, a learning dermatosurgeon is required to most commonly give blocks in digital nerve area, wherein we are doing nail surgeries, and that is usually the first block PG student is going to learn. Then comes the area of scalp, because more and more students are these days learning hair transplant, and that is a very welcome thing too. And face is mainly from the perspective of cosmetic procedures which we do, and wrist and ankle also in extensive surgeries and mainly hyperhidrosis. So before we look into doing regional nerve blocks, we also need to understand just a little bit of physiology and chemistry of local anesthetic agents. So classifications wise, we have esters and amides. Out of this, amides are hydrophilic in nature and they are metabolized by liver. Especially when we are giving long-term blocks like hair transplantation blocks, we need to understand how much anesthesia to give. Mainly in the amides, the central intermediate linkage changes. The terminal amine lane remains the same. For students, it is easy to remember if you know which belongs to what category. Wherever you see double I, that would be the amide. Majority of the times, the regional nerve block is done with the help of lidocaine. That can be with or without adrenaline, depending upon the area to be operated. One area where regional nerve block you would want to combine and mix with another agent, or would want to give a mixed solution, would be plantar. If you are creating full ankle block or full feet block, that is when you can combine it with bupivacaine. The main idea being the amount of solution required to create a full feet block. The amount of anesthesia tends to cross safety limits at one go. So bupivacaine also gives you an advantage of prolonging the duration of anesthesia. So let's say we have assumed that we are going to block a nerve. We would want to know what can be blocked at what level. This helps us achieve the amount of anesthesia. And many a times we don't really need the full nerve block, especially in the face area, because we are looking at pain and prick sensation. So once the nerve is blocked, we first have vasomotor or sympathetic efferents going. Temperature is the first sensation to get blocked. First cold, then warm. And the last sensation to be taken care of is deep. So as a learner, we need to be aware that once we have blocked, it is not the deep pressure which we are going to touch or check whether the area is blocked or not, distal to the nerve. We should be touching a gentle touch or the needle prick kind of touch. That's when you would understand the adequacy of anesthesia. So regional blocks, why are they preferred? Because they offer you longer duration compared to an infiltrative technique. They also minimize the pain of infiltration at sensitive sites. Like let's say for the example, nose. If you are doing something on the nose, nerve block makes it much more easier. Similarly, lips. Many a times the topical anesthetics are not sufficient. Giving field block or infiltration block will make it very high number of pricks, and that's where the role of infiltration or regional nerve block comes. It also reduces the number of pricks required significantly, decreases post-operative pain, and improves patient comfort and satisfaction. So once we have injected in and around the nerve, local anesthetic is injected, it follows a diffusion path. So nerve outer surface, the covering or mantle to the nerve core is the driving force of the local anesthesia once it is injected. And the first area to be anesthetized is the superficial or the mental area, mental fibers. These superficial fibers supply the proximal nerve structures or the proximal area of any nerve innervation. So anesthesia would develop first proximally. If you are giving the infraorbital block, the proximal area would get anesthetized first. Later on, the anesthesia goes to the deeper or core fibers, and the distal anatomy would recover last. So patient, if later on calls you and says that, okay, this area which is far away from where the block or injection was given is feeling anesthetized, you need to know that it takes longer for that to recover. Coming to the regional nerve block proper, I have listed out the indications. So complex excisions, intralesional bleomycin, which is painful, full face laser resurfacing wherein the topical may be insufficient, fillers, PRP, and hair transplant. So procedure wise, we should be taking patient consent. Procedure should be explained well, including the anesthesia procedure, not the actual surgical procedure. And even for all topical anesthesia, the small local infiltrations, the procedure of anesthesia and sensitivity testing should be explained to the patient, and it should be done under sterile precautions. The size of syringe is block dependent. Like for face, when you're doing filler injections or small cosmetic work, you might as well use an insulin syringe. When you're doing hair transplantation, a 2 to 5 ml syringe is adequate. When we are talking about field blocks like ankle and feet, then we may end up using 5 to 10 ml syringe so that we can inject from one syringe itself. The local anesthetic should be kept at room temperature, and again the needle size is dependent upon the area where we are going to perform the work. So when we look at the face, this is the innervation of the nerval structure. So supraorbital nerve, supratrochlear nerve, infraorbital, median or mental nerve. So these are the areas of nerve infiltration where we can give simple blocks. Now looking at the nose, you would be seeing that there are approximately 4 nerves which are supplying the nose, and we need to block all these if we are going to operate on the entire nasal area. So infratrochlear, supratrochlear, external nasal, and infraorbital, which supplies the ala. So if you are working on ala, just taking care of the infraorbital may not give you full anesthesia, and external nasal now need to be blocked in addition, especially when you are doing rhinoplasty, non-surgical rhinoplasties. Now this photograph also demonstrates how these are like linear and they can be blocked in one single line. Coming to the lateral side of the face, we have greater occipital and lesser occipital nerve, which are mainly blocked when we are taking the hair grafts from the hair transplant areas, and third occipital also. So these, and the lateral side of face, where we have auriculotemporal and other nerves. Talking of the first major anesthesia, which most of the times this would be one of the first you are learning on the face. In fact, this is one of the easy ones to do, wherein we are blocking supratrochlear and supraorbital. Easy because this is one of the areas where we also do our nerve palpation for leprosy examination. So supraorbital and supratrochlear nerves are blocked by palpating the supraorbital ridge first. Then we inject approximately 1.25 centimeter, 2 centimeter away from the medial line. We look at the supraorbital notch, and with the medial direction of 45 degrees, approximately 2 ml of local anesthetic is given. Then you withdraw, come above subcutaneously, parallel to the brow, towards the bridge, and after a negative expiration, again inject 3 ml. So approximately for this full anesthesia, we require 5 ml. So that's a huge amount. It is important to remember that 5 ml in this area, once the surgical work is done, is going to lead to some puffiness around the eyelid area next day for the patient, and that patient should be made aware of. In majority of the dermal filler work, if you are going to do just dermal filler, and let's say a very short procedure like PRP, which someone would want to do under nerve block, we don't need to give 5 ml. We can also give a small ml like 1 to 2 ml, achieve short-term nerve block, complete the procedure, and take care of the comfort of the patient. The next nerve is external nasal nerve blockade. In this, 1 to 1.5 ml local anesthetic is sufficient, and the anatomical marking is the bony and the cartilage joint marking laterally on each side. Post injection, massage it gently. This is a very thin area, so too much of force application may also not be required. Be gentle, use the least amount of anesthesia. Then comes the infraorbital and mental nerve blocks. Now this picture depicts intraoral route of administration. This also can be done from the surface, wherein we are going beyond the inferior orbital margin, approximately 1.5 centimeters or 1.25 centimeters beneath, and injecting over there. Now, I also would like to point for beginners that when we are doing regional nerve blocks, it is most important to hit the nerve. The anesthesia is going to act by diffusion, and even if we are around or nearby the nerve, it is going to give good anesthesia. So it is not highly important to pierce through the nerve. In fact, piercing through the nerve is going to make your anesthesia more painful. You may end up, if you're using a higher gauge needle, you may end up causing nerve damage or nerve injury, and that would require a lot of healing time. It is a very slow healing tissue. When we're looking at infraorbital incisors and canine, so the point or entry point is basically from the midline 2.5 teeth away. There is a small foramina and the mucobuccal fold of first premolar. That's where we direct the injection. The entry point to infraorbital is approximately 10 millimeters. So once we have taken anesthesia and taken the prick, you keep your non-dominant hand on the infraorbital foramina, allow it to be there so that it can act as a guiding force for the needle, and then you go inwards. Always aspirate and then inject. Again, like I said, when we are doing these areas, infiltration or nerve blocks, we don't really need to fully block the nerve. So sometimes even 0.5 to 1 ml is sufficient for doing dermato injection procedures. If you are doing a dermato surgery, it is going to involve a flap. If it is going to involve doing long-term work, then you need to give higher amount of anesthesia, and then approximately 2 ml at least should be given to sufficiently block the nerve in that area. Similarly, for mental area, so what we do is, if we are going to use intraoral route, we take 3.5 teeth, and in the mucobuccal fold, we go laterally and approximately 5 mm, 45 degrees angle, 5 to 6 mm, and inject our anesthesia over there. This is a small nerve compared to other facial nerves, so can be blocked with 0.5 to 1 ml. So for dermato injection procedures, 0.5 ml is usually sufficient. One important point to remember for beginners is that when you are using intraoral method of infiltration of nerve block, it makes things simpler, but we have to change gloves once we start coming on the surface and actually start operating. We really don't want to bring our oral mucosal bacteria and flora onto the surface or the surgical field. So even if you feel you are sterilized and you are still staying in the sterile field, while actually dermabraiding or operating on the skin surfaces, we have to change the gloves which we used while doing anesthesia. Otherwise, mixing of the flora may happen. Coming to the zygomaticotemporal block, so this is like lateral orbital margin. Palpate the foramina, go inside the depression posterior to the aspect of lateral orbital rim, and 1 to 2 ml. So typically for the lateral areas we use. Zygomatic, then comes the preauricular or auricular branch. Over there, typically for earlobe repairs, we may need to do it. So we come in 15 millimeter ahead of the tragus, go towards the tragus. The needle is at 30 degree or 20 degree at a low injection level, a low angle, and inject 1 to 2 ml of local anesthesia like this. So almost horizontal. The next anesthesia, which again, like I said, the students commonly learn these days, is basically greater occipital nerve and lesser occipital nerve. And occipital protuberance is the anatomical landmark which you palpate and then go beyond this. So basically palpate the occipital artery at the level of superior knuckle line. So just beneath this superior knuckle line you palpate and feel the artery just lateral to it at 90 degrees angle. So because this area we are going to operate for longer duration, 2 to 4 ml of local anesthetic is required, and this has to be repeated on the other side also. Then once we have blocked greater occipital nerve, we go on to the lesser occipital nerve blockade. Again 2 to 3 ml of anesthesia is required, and we just go lateral and block. And the next comes the extremities where we are going to give blocks. So hand is comparatively more commonly blocked, and I'm talking about from hyperhidrosis perspective. Dr. Samkit Shah just covered this in detail, so I would just give you the salient points of dorsal artery, digital artery block. In digital arteries also, or for that matter 2 arteries also, there are 4 nerves supplying each digit. So we need to block all the 4 nerves to achieve proper anesthesia, and this is basically traditional web space block. So what we are doing is we are just going lateral, just distal to metacarpophalangeal joint, lateral at an angle of 70 degrees. Should not be horizontally perpendicular, otherwise you may come out through the other side and inject it. So which areas to inject once we are doing this is basically all 4 sides should be covered. So you inject, then go medially, then from the other side again inject. So it is basically placing a sausage shaped amount of anesthesia on each side of the finger. So one sausage shaped amount here, other sausage shaped amount here, to block all the 4 nerves, the dorsal side and the ventral side. Next comes the hand block. In this, we have to block all the 3 nerves. So basically radial, median and ulnar. And these are the supply areas. Typically in hyperhidrosis or vitiligo surgery, resurfacing, we would need to block. So the first line nerve is radial nerve, which is comparatively easier to block. So we mark out or feel anatomical marking of radial styloid process, and across it is a radial nerve. In fact, radial nerve block can be considered as something of a field block because there are many superficial nerve fibrils in these areas, and the entire area should be blocked nicely. So basically, we palpate styloid process, keep the needle 30 mm proximal to this, aiming medially, and that's how the nerve gets blocked, and approximately 5 ml anesthesia if we want to block it adequately. The next is the median nerve. In median nerve, basically we are going between the tendons of flexor palmaris longus and flexor carpi ulnaris radialis, and that is how the nerve will get blocked. You basically go 3 to 5 mm depth at 45-degree angle. If bone is felt or if you are hearing a click, then you have to withdraw 1 to 2 ml and slow injection of 3 to 5 ml. This is the area where median is also likely to get damaged easily, so don't go overboard. Like I said, even if you're around the nerve, it is fine. If you're hearing the click of fascia, then you know that you're not in the bone, but always aspirate before injecting. So if we look at median nerve and the ulnar nerve, that is how the tendons are placed. So flexor carpi radialis, median nerve, and flexor palmaris longus. So between these two tendons, you go. You ask the patient to flex the hand and then inject. Ulnar nerve is beneath or just medial to flexor carpi ulnaris tendon, and the approach is usually medial to lateral while injecting. That way we can avoid the tendon damage also, because that also is a painful scenario. So basically you approach from medial to lateral, just go beneath the flexor carpi ulnaris tendon and inject. Again, a lesser amount of anesthesia can be used because these areas, if you're doing a small dermatosurgery, you can easily do. Now, feet, we don't really commonly inject, but one nerve to remember over is sural nerve. So sural nerve biopsy is done as nerve biopsy, and that's when we would need to block this. Also, we need to remember that if we are going to achieve complete feet block, we are going to require blocking all 5 nerves of the feet. So tibial, deep peroneal, superficial peroneal, saphenous, and sural. The more important ones are basically sural, because very few times we would want to block the entire feet. And just at the beginning, I also mentioned that blocking of all these nerves may involve large number of anesthesia. So when we are doing this, to reduce the amount of lidocaine injected in one go, we can mix and create a bupivacaine and lidocaine mix solution and then inject. So basically the nerve supply of the various regions, so that way we can decide which area to block. For hyperhidrosis, we would require maximum. So tibial, medial, this is one of the easiest to block. So posterior tibial artery we palpate, and just posterior to it, we inject our local anesthetic by aspirating first, checking in not being into the vein, and then. And the needle, once it is withdrawn, approximately 2 ml is injected. Next comes the superficial and deep peroneals. So these blocks also can be done easily. Suppose if we look at superficial and peroneal and saphenous nerve, they can actually be blocked from one single entry point. So for one we go medial, and for the other we go lateral. Solid line marking the medial malleolus and then injecting the saphenous basically. And this is how the marking is done for saphenous. Complications wise, there is a whole list of complications, but when it comes to regional nerve blocks, there are only 2-3 which we need to remember and significantly understand and take precautionary cares. One is while doing feet and hand blocks or wrist blocks, taking care of the tendons, not passing through the tendons, because that is very, very painful, and the healing and the process is slower. Also, it is a very unpleasant experience for the patient. Systemic complications when we are injecting large amount of anesthesia. And for face, it is important to remember that using high amount of anesthesia, patients may be numb for a very long time, especially around the lips while doing intraorbital. Then that is something which you want to make patient aware of. Another thing which you need to be prepared as a budding or initial dermatosurgeon is to make sure that you are aware of the allergic reactions and how to handle them. Accidental intravascular injection is easy to avoid. In digital blocks, don't go overboard. Try not to use with adrenaline mixed anesthesia in the beginning. And if at all you are seeing any soft tissue necrosis, local wound care has to be installed first. Toxicity wise, even if it is happening with small amounts or if you suspect, you need to be aware of the toxicity sequence. So prodromal stage is very important to understand, especially when you're doing hair transplants. So if at all patient is complaining of perioral numbness, dizziness, taste disturbance, that is what you would be asking the patient. It is important to stop the procedure, not continue going ahead giving further anesthesia, because over there you are going to operate for very long hours, and take care of the lidocaine overdose. So if perioral numbness is coming or patient is being hyper anxious, is complaining of cold or shivering, that is when you stop. And also remember your airway management and other basic life support management, and that's how you manage. With this, I would like to bring this presentation to an end. Thank you so much. Thank you for patient listening. Dr. Manan?
Yeah, thank you, ma'am, for your nice deliberation. And actually, we are also running behind schedule. So anyway, thank you, ma'am, for joining. I think we'll go to the next speaker directly. So our next speaker is Dr. Ashim Sharma, and he will be talking on innovations in dermatosurgery. So, doctor, live So Dr. Asim Sharma is one of the stylist and dynamic dermatologist. He is the chief dermatologist in Skin Saga Center for Dermatology, Andheri, West Mumbai, and ex-assistant professor of dermatology, LTM General Hospital, Mumbai. So he has written many articles and chapters and over 300 presentations to his credit. And he is present in many international forum like Cochrane Skin Group, F1000 Prime International. Then he had AAD22, ADV21, WCD19 scholarships, and many more. And he is having many organizational activity to his credit, and he is the editorial board member of various journals. So he will be speaking on innovations in dermatosurgery. Engage. Just we are starting the video.
Good afternoon, ladies and gentlemen. I'm Dr. Aseem Sharma. At the outset, I'm very, very thankful to the Association of Cutaneous Surgeons of India, the Academy Chair, Dr. Swapnil Shah, the Workshop Chair, Dr. Manas, and President ACSI, Dr. Shamanta Barua, for starting the year with a bang and for inviting me to talk on a topic which is very, very close to my heart. Having said that, very thankful to ACSI and IDVL Odisha for organizing this wonderful CME on lasers and dermatosurgery. And I wish to see all of you in a physical conference very soon. Now, today you've heard a lot of talks and you've seen a lot of video demonstrations on the art of dermatosurgery and lasers and energy-based devices. My job here is going to be a little more hatke, something which is close to my heart, like I told you. I'm going to speak to you about something called innovations. And as I go along the way, I'm going to tell you how I plan to format today's lecture and how I plan to cover it and under what objectives I plan to cover it. But before that, let's start with a quote. Now, Dr. Albert Georgi is somebody who's credited with the discovery of vitamin C. We're using serums left, right, and center. So maybe, we should trace the origins back to this gentleman. He said, and I quote, "Innovation is seeing what everybody has seen and thinking what nobody has thought." So that's the cornerstone of innovation. Everything begins with a simple idea. Yes, this is not a telecom ad, but everything does begin with an idea. But how far you can take that idea is what innovation is all about. Jugaad. I think as Indians, Jugaad is derived from the Devanagari script. It's a word that can be as Indian as possible. And as Indians, we are very, very Jugaadu. But to put it into context, this is one of those words which has made its way to the I think the Oxford Dictionary or Webster, or maybe not, maybe it's just a hoax like everything else. But what it means as a noun is a flexible approach to problem solving that uses limited resources in an innovative way. So there are a few things, a few keywords here, which I'll be discussing in the next couple of slides. Before that, let's move away from dermatosurgery for a moment and dermatology for a moment. Let's meet the paddleman of India. Let's see why we as Indians are the kings and queens of Jugaad worldwide. So this is the guy who can walk on water using things which cost under 1,000 rupees. This is a man who will, get the feel of a four-wheeler when he has just a bicycle. And I really wish I had this innovation when I was in college, when I was in, in my hostel days, where I could use a simple steam iron and a hair dryer to heat up a lovely, like a very delicious looking slice of pizza. Closer home, coming back to dermatosurgery and dermatology, our braveheart of ACSI, Dr. Neeti Khungar, has made the word Jugaad plausible and possible when she wrote about innovations and simulations in dermatosurgery in a journal which is owned by the Association of Cutaneous Surgeons of India, JCAS, and she made this word popular. So Jugaad also features on PubMed now, thanks to ma'am. What are the 6 operating principles when you want to innovate? Seeking opportunity in adversity. Whatever's thrown around you, you try to seek an opportunity in that. You do more with less, which applies beautifully to us because most of us are in resource poor settings. Thinking and acting flexibly. So knowing the start and end of your objective or of a particular process or a procedure, and knowing each step on the way. So you can simplify each step along the way. So keeping everything simple is also the cornerstone of innovation. Overcoming conformational bias. Now, I want to explain conformational bias to you. Now, we're all tuned to think psoriasis occurs through the T cells. And through, let's assume through, let's remember that it occurs through, TH17 or interleukin 17. But what if we tell you that interleukin 12 and 23 are also involved? So conformational bias is doing something exactly the way we are taught to do, or thinking about something exactly the way we are taught to think. Conformational bias, to remove something like that, you need to unlearn what you know and relearn it. So that is the cornerstone again of innovation. Focusing on cost effectiveness, which I've already discussed. And last but not the least, following your heart. There are some ideas, and we all know the great inventors of, not only our times, but times before us. If people had not followed their hearts and people had, stuck to, thought of their ideas as very stupid or silly, we wouldn't have even had something as basic as fire or electricity today. So that's something which, I wanted to bring to the notice of the audience. So let's start with the topic at hand, dermatosurgical innovations. Now, this is a crude classification, my own, which I've put forward. I'm going to discuss a few innovations in general surgery to get the ball rolling. I'm going to discuss procedural trichology because that is a subject which is very close to my heart. I'm going to talk about vitiligo surgery and a few honorable mentions at the end of my presentation. So let's start with general dermatosurgery. Now, before I start, the real innovations are the ones that make you go. And I'm sure when you read articles by Indian authors and a lot of people who are very innovative, you bang your head and you say, why did I not think of this before? I think that is the mark of a good innovation. And don't get me wrong, the simplest innovations often require the most amount of research and the most amount of toil and hard work. But yes, if they make you think like this, then they are great innovations. I'm going to get the ball rolling again with the previous edition of the ACSI textbook. Dr. Sharad Mutalik, Dr. Ganesh Pai et al. Have, anybody who wants to understand about innovations, especially by Indian authors, should go through this chapter. So something as routine as using a cling film as an occlusive agent for anesthesia. This was thought by somebody. It's so routine, we use it so commonly now that we've forgotten that this was once an innovation. So there was another way to do it. We found a simpler way. Similarly, with the micropore that you see in the bottom left of your slide. Now, using a micropore to clear off hair, pre-operative or even pre-laser hair removal these days. This is something which is so commonly done that we've forgotten that somebody actually thought about it. Cryosurgery. Now, cryosurgery is something that we all love for various reasons, at least I do. But all of us know that the cone of cryosurgery needs to be contained. Otherwise, you cause a lot of heat transfer in surrounding tissues and thereby cause damage. So what did Dr. Sharad Mutalik et al. Do? They used a simple otoscope, something which is readily available in ENT departments across the country. And they used the plastic cone to limit it, thereby making a cryosurgical cone. I spoke to you at the beginning about igniting the innovation engine. So when somebody innovates, another person takes it forward, and the innovation engine is sparked, and you keep it becomes a domino effect. Then one innovation leads to another, and so on and so forth. So what did Dr. K.T. Ashik and Dr. Feroz Kaliadan do? Again, these are brilliant researchers from South India who publish a lot and a lot of great innovations under their belt. They used a PET bottle, a simple cutout from a PET bottle, to achieve the same cone. Now, all this is good when you have sessile lesions, but when you have pedunculated lesions, the stalk is even narrower. So you want the cone to be even narrower. So what do? You take a styrofoam cup, a simple cutout at the bottom of a cup, and the lesion comes inside that cup, and you spray the cryogen from on top. So you're limiting damage to even the stalk, which is what I again found very brilliant, again by Dr. K.T. Ashik and by Dr. Feroz Kaliadan. And thanks to researchers like these, thanks to innovations like these, we have foreign companies that own, I think Cryopen is American if I'm not wrong. Hydrozate is Danish. they came out with customizable stencils, as you can see, between 1 to 7 millimeters in diameter. Now, thereby making cryotherapy something which every office can use. Earlier, we used to restrict its usage to medical colleges because there are a lot of logistical issues with using cryotherapy, with the can and the refilling of the can. But these pen-shaped devices and the handheld devices, now even small clinics use it. We use it at our clinic as well. So these are a few things where innovation can actually help us in our practice. Let's move on to anesthesia techniques. How many of you do PRP without a vibratory device? I think nobody. Not only one, we use 2 vibratory devices, one at the origin of the nerve and one at the final field of injection. Again, that is something that was thought of by Dr. Mutalik et al. Way before we started using it commercially. Now, another thing which is, so obviously, when you're using vibration, you're using the gate theory of pain. You're basically using a counter stimulant. You can also use cold, which we know as cryoanesthesia. It's a big hit abroad. What they use is a simple ice tray, but like you can see, if your injection site is here and you're using just a straight or a vertical ice tray, you're causing only a vertical column of anesthesia. Whereas when you're injecting something, you want a circumferential column. What you do there, I still remember sitting with a dear colleague, Dr. Sandeep Agarwal in Sion, I think about 3 years back, when we thought of filling up a surgical glove, readily available with normal saline, chilling it for a couple of hours, and between the fingers of the glove, you actually have circumferential anesthesia. So better cryoanesthesia than you would get with a vertical column. One idea sparks of another. Another student and a dear friend of mine, Dr. Tejas Vishwanath, decided one day that he was going to use cryoanesthesia for one of his patients. All of us know when you're injecting immunotherapy for warts, especially vitamin D3, because of the oily suspension, it's a very painful injection. So you immerse the patient's finger in a tray which is pre-chilled for about 2 hours, and underwater injections of vitamin D3. Again, this is brilliant and something which everybody can do in their offices, small departments, anywhere, and something which is very, very effective. For all the innovators in the house and all the dermatosurgeons in the house, especially if you work with plastic surgeons on your boards, you know what this is. This is called the eye of a pair of scissors, or the finger ring. This is the most common hemostatic. So common that, again, Dr. Mutalik et al. Had published this in the ACSI textbook. Look at it being used before radiofrequency ablation, pre-surgery, for a simple biopsy, being used for lip surgeries, for a suction blister grafting, as can be seen in this photograph, for earlobe repair, and for removing small tumors. But what did Dr. Katie Ashik go ahead and do? What these people did was they reinvented the Calazion clamp. And in fact, I'm proud to say that we as dermatologists possibly use the Calazion clamp much more than ophthalmologists do. In fact, this is me in the inset using such device before a surgery. Now, because you've made the base elliptical, you can grab a bigger portion of the lip. You have a wider area where you can achieve hemostasis by using a Calazion clamp. So again, something which is repurposed. Now, here is where I wanted to maybe bore you for a minute and tell you about a journey of an idea. Now, once you have an idea, for example, just to this will obviously be a graphical representation of what actually went on in Dr. Katie Ashik's mind. But you had an idea to make the surface oblong or elliptical from circular. That was the idea. To innovate it meant you had to make the device. You had to do some kind of production to use that device and see if it actually works. From an innovation, you can make it an invention, where you file for a patent, where you think it's a brilliant idea, you don't want other people to use it. So you file a patent and you start mass producing it. When you produce it en masse, you're actually converting an invention into an impact or an industry innovation. So from an idea, the final goal of any innovator should be impact. So this is a beautiful example of how an idea became an innovation became an invention, and an invention finally became an industry innovation or something which had global impact. So kudos to the team, but this is how most innovators need to think. A lot of us fail in the idea phase. In fact, research shows that 70% of innovations fail in the idea stage, where you can't make an idea into an innovation. Yes. So we've been talking about hemostasis with the Calazion clamp, but what happens when you have a large area? A simple device. Those of you who follow us know what I'm talking about right now. but especially when you're trying to create slits. A lot of us who do hair transplants know this fact that the minute you start creating slits because of the tumescence, in fact, despite the tumescence, the area becomes very bloody. So it's very difficult to keep marking, excuse me, without going on. So this is where I clearly remember Dr. Rachita Dhurat coming out of the OT, and we were having lunch together, and she said, why don't we use something circular? She looked at her bangle. We searched all the residents in the department for anybody who had a steel kada. We autoclaved that and used that thereafter. And this is a photograph from the same day, while you achieve circumferential hemostasis by using a simple bangle. Now, what a brilliant innovation this is. Imagine how somebody on the global front thinks of this innovation. A simple ornament being repurposed. But what happens when you want to make this device even more sophisticated? When you have larger areas and when you want to use it for not only slit making, but for extraction also. Dr. Amit Kirure, another brilliant innovator who actually won the ACSI Innovation Award, I think in 2019, if I'm not wrong, for this particular innovation called the Kirure clamp. Very simple device. Basically, in one of the holes which is left by the graft, you put one end of the clamp, the other end can be clamped to your operating table. And the idea here is multi-pronged. You not only want to achieve hemostasis and a clear field, you want the anesthesia to be maintained in that area. Plus, when you create traction, as you can see by the second photo, you're actually making that area turgid. And when you're making it more turgid, you're reducing the transaction rate. So the straighter the follicle is, the more chances are that you will take the entire follicle with the sebaceous gland. So that's something where transaction rates can be reduced. The time taken can be reduced. So this is a very nifty innovation. And again, something which he patented and then mass produced. So again, a beautiful example of how an idea made its way and impacted people globally. Again, closer home, inspired by Dr. Amit Kirure, Dr. Sandeep Agarwal also came out with a multi-purpose HT frame, which is again very, very good for hemostasis. A simple cutout frame, which any engineer can make for you, or not even an engineer, anybody with any technical background, or people, if you're good with your mechanics and you're used to playing, with toys like mechanics or Lego, you can put this up together as well if you're good with the soldering iron. But again, just to tell you, once the innovation engine starts, you can keep updating and reinventing the wheel. Another very nifty innovation, and I'm going to end my innovations in trichology here. All of us who do trichoscopy, I use it especially for trichoscopy, where you can use a simple soap which is slightly wet to part the hair. And the hair, because the soap lends its grease to that, the hair are parted beautifully, and then you can do trichoscopy without any hair mingling in the field. So that's again a very nifty innovation by Dr. Sharad Mutalik et al. So I'm going to show you an innovation of our own. Now, normally when we're doing earlobe repairs, we do a surgical deepithelialization. A small linear defect becomes very large. So what we wanted to do here was to minimize the area. So instead of using a surgical blade to refresh the edges, you use a conical dermabrader to refresh the edges, and then you use a small iris scissor to cut out that area. I think due to paucity of time, I'm going to quickly go over the video. So refreshing with the conical dermabrader like I've shown. And in the end, you can use an iris scissor to cut out the leaflets, and then you suture. So here you're combining the best of both worlds. You have a non-surgical method which will limit the size of your scar, and you top it up with the surgical method. So again, something a very simple innovation here. Just trying to show you what else can be done. We haven't published this, but we use this regularly when we do ELRs in our practice. Again, pre and post procedure. So if you want to learn more about this, you can contact me personally for this innovation. Obviously, when I'm showing you giant innovations here, this is probably a little speck in that universe, but yes, something which I can call my own. So I've covered innovations generally. I've covered them in the field of trichology. I'm now moving on to innovations in vitiligo. Why I've covered this today is because Indian authors are giants in the field of vitiligo, right from punch grafting to non-cultured epidermal suspension, suction blister grafting, using cryogens for blister formation, and thousands of other things. Even therapeutic wounding now, that is, which is in vogue right now. 92% of all global innovations which have been done in the field of vitiligo are by Indian authors. So that's something which we should be very proud of, and something which I'll show you in subsequent slides. I've assorted these innovations into mini punch grafting, or let's call it punch grafting, because I'm covering mini, micro, and macro punch grafting here. recipient area preparation, suction blister grafting, non-cultured epidermal suspension, which is also known as NKTP, and other innovations in which I'll cover therapeutic wounding. So we started with macro punch grafting, which was also used for hair transplantation back in the day. We moved from there because of the cobblestoning and the stuck-on appearance. We moved to mini punch grafts, where we reduce the size from, say, a 5 millimeter punch to a 1.5 to 2 millimeter punch. Now there are researchers and colleagues who are using a motorized microdermabrader and using hair transplant punches. So punches as thin as 0.8 to 0.9 millimeters in diameter. Obviously, the chances of cobblestoning go down. So that is a very nifty innovation. But here, if you have grafts, you can also cut them into 4 sections if you have grafts of 2 millimeters and use, for example, the researchers here have used a 23 gauge needle. So you can actually use a 23 gauge needle to put it into epidermal pockets. So this is micro grafting, which can be done in a resource poor setting. Follicular unit extraction, maybe a few years ago, when FUE was, FUE is still in vogue, I'm sorry, for hair transplantation, but it's been repurposed to be used in vitiligo, especially hairy areas like the hairline or the eyebrow, or even areas on the legs which are very hairy. This can be a very, very good option. And now we've come to a realm where we're combining procedures. So not only follicular unit extraction in whole as a tissue graft, but you also have non-cultured epidermal suspension from follicles. It's called follicle non-cultured epidermal suspension. So you're taking follicular grafts and reducing them to cellular grafts. So that's again something which is very nifty. So like I said, somebody innovates and people move forward with that innovation. I'm just going to shift my screen to the right side. Yes. So motorized micropunch grafting, I've already spoken about this using a motorized microdermabrader. So just to show you photographs, brilliant results around the areola. Now, what happens with graft fixing? And Dr. Yogesh Bringadia is another brilliant researcher from Gujarat, a dermatosurgeon par excellence. He uses Fevikwik. So you can send patients home with punch grafts in situ without using any synthetic dressing on top, not even a biological dressing, just simple Fevikwik. And what did Dr. Mutalik et al. Do after this? For all of you who find it difficult to regulate the number of drops that come out of your Fevikwik bottle, you can attach a 23 gauge needle. I think he's used 23 gauge here to regulate the number of drops that come out of that. So again, sparking the innovation engine all through. Let's quickly move on to recipient area preparation. Now, traditionally, we're used to the Manekshaw manual dermabrader. Every residents who have keyed into today's lecture, you have to know these instruments by heart. What we also use are motorized microdermabraders, much faster, much simpler for larger areas. I also use a CO2 machine for dermabrasion. I know people who use other ablative erbium YAG lasers to do the same thing. Now, what happens here is you have to reduce the pitch size of your CO2 lasers and you have to enter a dermabrasion mode to be able to dermabrade. But these are things which have been used in the past. It's not something which I've innovated at all. But moving on to an innovation by Dr. K.T. Ashik et al., when you have areas like the eyelid and areas like the periobital area with vitiligo, you can use a simple sandpaper, tie it around your finger, a gloved finger, and you can scrape with that. So using a sandpaper to abrade is again something which is an old concept, but repurposed by Dr. Ashik et al. Obviously, people who are comfortable with motorized dermabraders can also use a pear-shaped small dermabrader like a dental burr that works equally well. Dr. Somesh Gupta and Dr. Sanjeev Gupta are again brilliant researchers from North India, many papers under their belt, but they've used a hypodermic needle. So if you don't have access to a manual dermabrader, if you don't want to use a motorized one, you can use a hypodermic needle and scratch the skin till you remove the first layer of the skin. So manual dermabrasion again without using a dermabrader. If you don't even want to do that, you can do a chemical dermabrasion. Again, by Dr. Somesh Gupta and his brilliant team from AIIMS Delhi. They use duofilm, which is 16.7% lactic acid and 16.7% salicylic acid, as you know, as a dermabrading device. So you basically put a gauze piece along with this, you wait for 2 to 3 days and the skin comes off on its own. So chemically assisted dermabrasion. You can also use 30% TCA, which has been published, and urea-based keratinolytics, especially the higher ones that are in vogue now, 20% to 40% urea, which we now have commercially available. Let's move on to suction blister grafting. Now, traditionally, we all have used the 3-way, a 10 ml syringe and a 50 ml syringe to produce this kind of picture that you see on the right side. But what are the modifications here? You can, for those of you who have skin polishing devices, you can also use the suction cup of a microdermabrasion machine to do the same thing. You also have radiation-induced blistering, which can be done by a handheld phototherapy unit or even a Woods lamp. You have cryogen-induced blisters for those of you who are daredevils. I wouldn't try it in Indian skin because of, you all know about cryogens and melanocytes, so we won't go there. And injecting local anesthesia or warm saline. This is again something which I had heard Dr. Somesh Gupta talk about at DASL a few years ago. So that injected into smaller blisters can increase the surface area and give you proper full-size blisters. Again, when you're making your suction blisters while you're waiting, all of us know you have to wait for anywhere between 2 to 4 hours for a good blister to form. You can use a hair dryer at a temperature of 44 degrees centigrade for a minute every 10 minutes to reduce the size. So a lot of papers here, and when we do SPG, we use it. We get blisters in as low as 1 hour to 1 hour 15 minutes as well when done properly. So you've got your blister, now you want to transfer it. Using a gloved hand is the oldest trick in the book, again popularized by Dr. Devendra Mohan Thapa from JIPMA. You can also use a paraffin gauze which comes, sticky paper which comes along with your gelonate or paraffin gauze, and you can cut it in different parts. So for the lip where you have irregular areas, you can actually put one on top, one on the bottom. So you can bandage or dress them separately then. You can also use acetate sheets for those of us who remember overhead projectors and acetate sheets for OHPs rather than, before we had Microsoft presentations like these. Also, glass sides can be repurposed, professionally, made and cut to be able to transfer the grafts as well. Cellutome, not a true individual derived innovation, but an industry derived or a device derived innovation. But yes, somebody would have thought of that, of combining the concept of a micrograft and the concept of a suction blister grafting. Obviously, a lot of people still are not very comfortable doing vitiligo surgeries. We get a lot of referrals at our clinic in Andheri. But for those of you who want to try vitiligo surgeries but can afford a machine, obviously the machine will set you back by between 3.5 to 4 lakhs depending on where you're getting it from. And the consumables, the suction plate that you have in the cellutome costs around 15 to 20K. So if cost is not a bar for you, it's a time-saving procedure, combines the best of a punch grafting and a suction blister grafting. There is minimal donor site morbidity, which we have tried in limited studies at Sion. Anesthesia at the donor site is not required. And it's a very short and simple learning curve for those of you who find vitiligo surgery daunting. So that's something which I'll throw it out there, whether you want to use it or not, but it's definitely an innovation which is being used. My favorite procedure, something which Dr. Madhulika and I do very, very commonly at our clinic, non-cultured epidermal suspension. All of you are aware of the steps, so I'm not going to bore you with that. But what if I told you that we have an innovation where you can make everything in the skin? You don't need an external incubator because you can use the body's own temperature, core temperature. You can use trypsin and EDTA, de-trypsinize it inside and just pull out a suspension from the same blister. So again, and what's better is you can cut out the blister and use it as a biological dressing for the donor site area as well. So that's wonderful. This is again by Dr. Somesh Gupta et al. Donor site harvesting, I think the last time I used a Humvee's knife or a Sliver's knife or a microtone was in Sion Hospital. Now, we exclusively use a 3 rupee 7 o'clock blade at the end of a long handled forceps. I think this is a wonderful innovation and something which now is so common that we've forgotten that somebody actually used it, as an alternative to the microtones. So what if you don't want to do MCS? You can use brushings from the donor site itself, from the recipient site itself, gather them, into the area with an antibiotic ointment, or you can use them to create a small epidermal cell suspension. So that's also something which can be done. Again, something more sophisticated is smash grafting, where you can take it into a container and smash it with a, an iris scissor or a Castroviejo scissors. And again, it's a novel method of vitiligo surgery. What about incubators? So lab-grade incubators can set you back by over 10K. What we use at the clinic is something which was gifted to us by Dr. Mulekar, who is our mentor, the Novital Co2. This is a British brand, but you get a lot of egg incubators commercially available, which you can pick up for anywhere under, under 2,000 to maybe even 8,000 for a good one. Does the job equally well, maintains 37.2 degrees centigrade to a T. While in science, I remember a time where, one of our students had a thesis on NCS and we were doing it left, right, and center. But one of those days where the incubator didn't work, we had to send the sample down to the pathology lab. We thought of making something in-house. Now, this is not very sophisticated. It's a very crude method. But for those of you who do not want to invest in an incubator, the whole setup costs less than 500 rupees. Again, I'm reiterating the fact that it's a crude setup, but it has a thermal sensor. It has a regulator for a fan. It has a thermal sensor, like I told you, and it has an enclosure for you to keep your graft there. So anybody who's interested in that can hit me up after this lecture, can email me or contact me, and I would love to share the details. To detrypsinize or not, again, that is a burning question. A lot of modifications here. DMEM can be the aim of an idea. Remember, there are no failures, no stupid ideas. There are only baby steps forward, and all of us must innovate. I'm going to end with a quote where the famous Thomas Alva Edison was called too stupid to learn by his teachers. His friends, used to say he couldn't grasp very simple steps of a procedure. He took 1,000 attempts to get the light bulb right. So, my friends, I leave you with that thought. Do you think these were 1,000 attempts, 1,000 failures, or were these 1,000 baby steps to something which was marvelous? Thank you for a patient hearing. I am open to questioning now.
Thank you, sir, for nice innovative things in various fields of surgery, various different surgeries starting from your love to vitiligo surgery and many more. So these are really small innovation, but which helps a lot, and it gives a encouragement to the young dermats to start new thing. So now, thank you, Dr. Ashim, and hope very soon we'll have a physical one. So now we are having another young, very dynamic, and you can see the face, always laughing, Dr. Dhanraj D. Chavan. He is a consultant dermatologist in Pune, Clear Skin Clinics, Hair MD Hair Transplant Center, and Ben MD Varicose Vein Center. He is the winner of Best Video Presentation Award in ACSI, and I feel proud to announce his name last year. And he is also the winner of Dr. S.L. Vadia Award for Best Research Paper, and also many more awards to his credits. And he is very good in technical aspects of, like, he helps a lot during all our technical thing. So with this introduction, over to you, Dr. Dhanraj. You can start sharing.
Thanks a lot, sir. Thank you for the warm introduction. And
He's the most softwarely connected dermatologist in India today.
So you're too kind, sir. Hi, everyone. Thanks a lot for inviting me. Would have loved to be there physically, but so glad that we can connect over Zoom and such a short notice. So I'll quickly share my screen. I'm going to talk basically about 3-4 things here. A combination treatment of acne scars and update for the same. We have been treating acne scars. So my screen is visible. I'm audible, right?
Yes, you are audible.
To confirm, yeah. Okay, so we have been treating acne scars since a long time, and because of the variable kinds of scars that are there, in each patient there are multiple types of scars. So never has it been that one treatment is enough for all the scars. So each time most of the time you have to combine treatments for the patients. We see various kinds of scars in our practice. There are post-inflammatory hyperpigmentation, like you can see here. Post-inflammatory erythema is also very common. There are box scars, both superficials and deep ones. And then there are ice pick scars. As we can see in this, many rolling scars are also seen. Rolling scars that are often combined with something linear here. If we can see, that's linear boxcar scars, if we may call them. And then there are linear tethered scars, which especially when the patient animates his face is visible quite a lot. Boxcar scars can be seen here, some ice pick scars. So in each patient that we have, always there is a combination of scars, and that's very important to understand. what the kind of scar is, what the anatomical level of the scar is. So if you go into the microanatomy of our skin and understand where that scar is, then it becomes very intuitive and easy to treat them. A very nice infographic, one of my most favorites, which I also use while explaining to patients, is this one from acne.org, a wonderful site. It talks about the different types of scars that are there and the various options that we have in terms of treatments for acne scars. And then it's graded according to the effectiveness. Green is effective, yellow is less effective, and red is ineffective. If we go on one by one, so for lasers, that's CO2 and erbium YAG laser, that's ablative CO2 and erbium YAG or fractional CO2 erbium YAG. They're great for rolling scars, shallow and boxcar scars. So the way they work is basically either by burning or heating the skin. In ablative, you burn it. In non-ablative lasers, you basically heat it, do coagulation. Not very effective for ice pick scars. Then we talk about the augmentation or the fillers. So when we are talking about fillers are the most effective in rolling scars. So we see once we have done subcision or just inject a needle and try to create space from within inside, that's when augmentation, that's rolling scars, and to an extent in boxcar or deep boxcar scars also. So once you connect the boxcar scars into a converted into a rolling scar by feathering the margins, then again they become rolling scars, and then in those cases augmentations is effective. Augmentation or fillers can be of 3 different types as I understand it. The first and the long-term one is basically hyaluronic acid fillers that usually stays for about a year and the year and a half, but because it also stimulates collagen formation, in many times you don't have to repeat the treatment. The second or third type of it is fat and biofillers. So both fat and biofillers are not very long term. Fat does not survive if injected into the dermis per se, but because once we do the subcision and instead of waiting for the hematoma to form, if we let the fat sit in there, it creates a structure over which the new neocollagenesis will take place. So in that way, it's very effective. It also contains adipose derived stem cells, which again help in new creation of the tissues. If someone is not as affording or you don't want to do an invasive procedure like fat transfer, you can of course always take biofillers that take plasma and coagulate it, and the gel that is formed, you can use it instead of say fat or hyaluronic acid fillers. Even biofillers will stay for about 15 days to 30 days in the dermis, but what it will do is it will again create that structure over which the new tissue will form. Subcision combined with biofiller is one of the most recent and a treatment that I have started doing quite a lot, and it's giving wonderful results. So that's something that can be tried at a very low budget also. In terms of subcision, again, it can we know subcision is bi-level, so it can be either in the dermis, as we can see in this, or it can be done at this level in the subdermal level, as like I'm pointing here. In this level also, it can be either a needle or we can use a cannulas. So cannulas that we use for fillers, those can be used. It's known as blunt subcision. Or newer devices like the Taylor Liberator can be used, which are semi-sharp. So they're not exactly sharp like a needle, but they have a pointed edge, which when inserted into the skin will lead to that bi-level subcision. Punch excision, punch elevation, good for boxcar scars. Small punch excisions are good for ice pick scars. Otherwise, in rolling scars, they usually do not have any effect. Also, punch excisions do require some amount of skill on part of the doctor. If you're not good, if you don't have that skills in order to suture properly, the results are not as great. So practicing the suturing part is very important in order to get punch excision results. TCA cross, good for ice pick scars and for shallow boxcar scars. This is how it works. It basically stimulates the fibrous skin in the dermis after going there. So it burns the skin above. The epithelium is ablated chemically. And then the skin below it, that's the fibrous cells are stimulated in order to create more collagen and elastin. So good for ice pick scars or shallow boxcar scars. Then, I've covered fillers, I've covered subcision, punch excision, chemical peels to an extent in ice pick scars or shallow boxcar scars if they are deep. TCA cross I spoke about. Micro needling is something we can definitely do. Derma pens, there are derma pens from a wide range of budget. It can be as derma pens come for as cheap as say 5,000, 10,000 rupees, and then they also go up to 2 lakh rupees. That's the official derma pen. Each one has its effects. Usually the ones that are expensive like collagen pen or derma pen have better results. That's because of the strength and strength of the motor that's there, and the needles go much deeper. These are good for the rolling scars and the boxcar scars. In terms of fractional radio frequency, there are various devices which are available, again good for the rolling scars or boxcar scars. So anything that will stimulate the dermis is going to help in rolling and boxcar scars. And in ice pick scars, as we can see, TCA cross and punch excision are the two most important treatments that usually give results. I'm going to discuss two patients. So, in them, the treatments that I've done to achieve these results. So if we can see here, this is one patient who has had rolling scars, multiple rolling scars, and a few tethered scars in this area with volume loss. So he has, again, multiple, he doesn't have many ice pick scars as such, but yes, volume deficit in this area. And you can see deep rolling scars here, 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 here. So this patient, the way we have treated him is we've done talar liberator, that's a deep plane subcision, subdermal, and we have done subdermal fat autologous micrograph transfer, and also intradermal subcision plus micrograph transfer, and then done fractional CO2 and him. And these are the results that we could obtain after 2 sessions of combination of these treatments. See, if you can see again, this areas where the rolling scars are there, and we can see subdermal atrophy also. So fat atrophy is also there. So placing the fat after the subdermal subcision has given this results. I'm going to play this video now in which we see the whole procedure, what all has been done. Talar liberator is the first procedure that we've done in him. Yeah. So first in talar liberator, what is done is, because it's a semi-blunt device and the device is large, the gauge is around 18 gauge. We usually do tumescent anesthesia because it's subcision at a subdermal level. When tumescent anesthesia is used, the skin is lifted above the SMAS layer. So it helps in compressing the blood vessels below the in the SMAS layer and below the skin, and also lifts it up from the nerves. So the damage that's caused is quite less, and in 2 to 3 days, this swelling also settles down quite nicely. Actually, the next day itself, it's quite less. The patient is comfortable, and the anesthesia in itself also makes the procedure quite comfortable. What I'm using here is a tumescent pump and a 22 gauge spinal needle, so that less amount of pricks have to be done. Post that, insertion site is made with a 11 number blade, a stab incision is done, and this is the talar liberator that's there. Like I shown in the photo, it's a tri hook thing. Once inserted inside, it's not sharp, it's semi-sharp, and then once it goes inside with a to and fro motion, we release the skin and the fibrous scarring that is there from below the skin. We lift it up. So this indication is basically for rolling scars that are there, in which we can see that the surface of the skin is up and down. So especially when the patient animates, we can see that there is fibrous scarring below the skin. If there's only dermal atrophy and there's no subdermal atrophy, no subdermal fat atrophy, then this procedure obviously won't help. But most of the patients do have some amount of subdermal atrophy, especially if they've had cystic acne. So from the same entry point, we go in and separate the scarring. The level at which I am is immediately below the dermis. So if you can see at these points, we can actually see the tip of the device that's there. And because of the tumescent anesthesia, I'm not harming much of the SMAS layer. The other hand is acting as a vision, so I can feel where the cannula is and then accordingly direct it and also target the scars that are there. Post that, we just roll over and remove as much of the fluid as we can in that part, so that not much fluid stays inside post the surgery. But we don't try much. In a day or maybe maximum 2 days, that fluid goes off. Then the same patient, we are taking fat. So I'm injecting tumescent anesthesia, getting fat out of his abdomen. We can see fat harvesting being done here. This is a 60 ml syringe, which has a syringe lock present above it, and it helps in making the fat harvesting procedure is easier. Once that is done, we harvest the fat. Again, in fat harvesting also, I use the other hand as a guide and to feel where the cannula is. This part that I'm doing is intradermal subcision, to and fro motion. I'm in the dermis. The needle is a 20 gauge needle. I'm in the dermis. I'm injecting fat. So this is microfat. This is not nanofat. I'm injecting microfat in the dermis. Like I showed in the subcision slide and the filler slide, what I'm doing is I'm subcising intradermally, and instead of just leaving it like that for it to fall upon itself or waiting for the hematoma to form, I'm injecting the fat into this. Once the fat is injected, it creates that separation, and over time the fat gets reabsorbed and new tissue forms over this area. Because in this patient, the areas that I've marked also had a lot of subdermal atrophy, that's fat atrophy below the skin. I have also injected. So if you can see here, this post injecting in the skin, I've also used a cannula. So I go below the skin, and below the subdermally, I'm also putting microfat. So whatever dermal atrophy that he had, subdermal atrophy that he had, that depression is filled out with his own fat. So before, in the before photos, if you had seen, he had a very depressed part here. Post the fat injection, his face looks fuller and more contoured and younger. So just to recap this patient again, this was the depression that I was talking about in this patient. These are also the areas in which we did the subcision and filler and the fat filler and fat. So overall, this is the improvement that we got in just 2 sessions. One session of the whole tailor liberator fat thing, and one more session later of a fractional CO2 plus PRP treatment. In just 2 treatments, this is the improvement that we can achieve over a period of say 6 to 8 months. So the patient doesn't have to come again and again for fractional CO2 treatments. We just do 2 or 3 sessions and we get a good improvement in the patients. The same patient from the other side. The second patient that I'm going to show today is this patient. Again, the case has multiple box scars and bridge scars. So in the next photo, I'll show all of these submarine like scars that we can see go on to the other side, and there's a lot of bridging that's there. So even though it's not appearing too much in the photos, when she touches her face, there's a lot of unevenness, and it's there are hypertrophied areas in it. So I'll show how those bridge scars are treated, and also how the box scars that are there here, they also show how the surface is ablated with a fractional CO2 laser to make it all smooth. We can see some amount of hypopigmentation here. This is 2 or 3 months post that, but now when the patient is come for follow-up, it's pretty much normal. It's not much to worry. So this is the bridge scar that I was talking about, and the patient had almost 20 of these on like combining the 2 sides together. So a lot of them. So whenever she used to feel her face, it was a very hard nodular feeling that she used to have because of the hypertrophic bridge scars. And this is what we release quite a lot. So on the photograph is not as much visible. So I'll show how to open these bridge scars, how to do the ablative laser for the CO2. So if you can see, she had these multiple bridge scars. What I do is I just put a plain forceps in there and open this up with a 11 number blade. Once these are opened up, I cut them off. And most of the times the area beneath it is raw. If not, I make it a bit raw with the blade itself. As you can see, one more bridge scar that's there. I open this up from both the sides. So I cut the bridge from both the sides, and below it, whatever it is left open. While doing the fractional ablative CO2 for the feathering of scars, I also ablate the base of these bridge scars so that new tissue, whenever it's formed, has a hole on the whole skin. So you can see I hold the bridge part and then remove it with the 11 number blade. So this is done for each of the scars. Then again, the same tailor liberator procedure. I have fast forwarded this because I've already shown it in the previous video. First, tumescent anesthesia is given, and then the tailor liberator is put inside. The tumescent anesthesia here is 0.001%. So in 500 ml of normal saline, we usually put 20 ml of lidocaine. So that goes to about that percentage. Also add adrenaline and sodium bicarbonate. If you can see here how this other hand is trying to visualize where the cannula tip is and removing the scars. So both the hands act in synchronization to do the procedure. Once the procedure is done, then again we do the fat grafting for her and repeat the same intradermal subcision along with injection of the microfat in the dermis. So again, the common understanding is microfat is injected below the dermis, subdermal. But here what I'm doing is injecting it in the dermis. The idea being it acts as a scaffolding for the neocollagenesis that happens. This is a conventional CO2 laser, 500 micron tip, energy is 24 millijoules. And what we're doing basically with it is whatever the borders of the bridge scars or the box scars were there, I'm just ablating them so that they get smoothened out, feathered out. The same thing, I'm just with a free hand painting it so that the borders get feathered out. These are other 2-3 videos that I have of the procedures. I'll just share them once just to cover maximally. This is TCA cross. I'm using a toothpick and placing the trichloroacetic acid. I usually use 50% trichloroacetic acid, but some people also use 100% and are fine with it. I've just noticed a higher chance of hypopigmentation with it, so I prefer using the 50% trichloroacetic acid. In most of the patients, we also do fractional CO2. Depending on the type of scars, the parameters usually change anywhere from 50 to 100 millijoules is the power, and the density may range between 50 and 100 dots per square centimeter. So that gives a area coverage of around 8 to 15%, depending on the density that we use. Post that is done, post the fractional CO2 is done, we either inject PRP, or if fat is taken, then we also prepare nanofat out of it and inject it also, and also apply it over the fractional CO2 marks as a drug. So it basically acts as an intralesional drug delivery. We just apply a mask out of it and let it be for 20 minutes. So whatever the adipose derived stem cells that are there in the nanofat should go inside and help in the healing and neocollagenesis. I'll just share a few results. So just let me know if I'm overshooting the time, and I'll end this. But again, I'll just share a few results of similar procedures. Again, most of these patients have been done with 1 or 2 sessions only, and the results are post 3 to 4 months of the last session. In this patient, what we have done is tailor liberator. So if you can see, he has we've done tailor liberator and fat and CO2. If you can see all the scarring that is there, especially superficial, but also deep rolling scars. And overall, because of the tailor liberator and fat, the face, which is very depressed in the scars area, rises up and gives a nice appearance. The same patient on the other side. There's another patient in which we did tailor CO2 and fat. You can see the scarring in these areas. Pardon me for the lighting, it's a bit different, but yeah, different can be noticed. In this patient, again, what we did was biofillers, tailors, and CO2. So not in all patients we need to do fat. Biofillers is something, again, that is very helpful and quite easy to do. So you just do a subcision and a biofiller. In this patient, of course, we've done Taylor's liberator, but only a subcision, a biofiller, and CO2 also gives quite nice results, is what we have observed. The same patient on the other side. This patient is post-Taylor liberator, fractional CO2, subcision, and biofiller. So again, another patient with no fat that is done. This is only Taylor liberator, fractional CO2, subcision, biofiller. Subcision is intradermal. And then instead of putting fat there to as a scaffolding, We use biofiller as a scaffolding here. The same patient, the other side. Another patient post fat grafting and subcision. So in this patient, no talar liberator was done, just fat grafting and subcision. This patient, talar liberator, fat and CO2. We can see the improvement in the volume and in these rolling scars. Another patient with rolling scars and the improvement that we can see. She has some pimples which have come later, but yeah. This patient again had post-inflammatory erythema and rolling and box scars, and post the treatments that we did, a combination. So the combinations usually depend on what type of scars there are. Like we saw in the first diagram that was there, depending on the scar and depending on the techniques that you have, you can mix and match and do multiple treatments together, going from the lower side to the upper side. So first do the deepest treatments and then start coming up. That will help you combine and also give you an algorithm of how you should combine depending on your skills and the devices that you have. Another patient with quite deep rolling scars and post-inflammatory hyperpigmentation also. That's it. Thank you.
Yeah, Dr. Dhanraj, am I audible?
Yes, sir.
Yeah. So very nice and interesting cases. The audience wants to know your trade secret, some which I will be asking you one by one.
Sure, sir. My pleasure. I'm here.
Yeah. So what was that needle? If you can repeat, we would also like to get that that needle which you are putting inside.
So that device is a Taylor's liberator. There's Dr. Mark Taylor in America, and he's devised this device. It's basically a long stainless steel device. It's quite thick, about 16 to, I think 14 gauge, not 16. So it's quite thick and quite strong. You just have to insert it from one point, and it goes right till the angle of the mouth. So from one entry point, you can cover the whole cheek area and whatever adhesions are there below the skin. This is not intradermal, this is subdermal. So whatever adhesions are there subdermal are released. So especially when the patient smiles and all the scars that get increased, those are signs that the patient has subdermal adhesions. Those get released quite nicely with this device.
Okay.
It's
So
Taylor's liberator.
where do you get these needles?
So you can just Google it. The website is Gateway Aesthetic Laser. That's Dr. Mark Taylor.
Okay.
Yeah. So on their website, you can order it and they ship it to India. The cost is around 21,000 rupees. The last, like the time last two years, it's almost 2.5 years now. 2.5 years back when I bought it, it was $300, $350. So I think should be the same. Some amount here and there, 20 to 20.
Like what are the advantages this has over our typical 18 gauge needle or say cannula or a spinal needle?
Usually, what I've observed is 18 gauge needle. When we are always in the intradermal level. If we go subdermally and try to do with the 18 gauge, the damage to the subdermal structures is quite a lot. There's a lot of bleeding, and you can't do it in such a wide area. If you take a 18 gauge needle and try doing it in the whole area, the bleeding is quite a lot, and the damage is more, is what I have observed in my limited experience. With this, once you give the tumescent anesthesia, you just have to enter through one point, and then you're doing the subcision to the whole area. The healing is quite nice. There's only one patient who has got some mild hypertrophy, which was quite unexplained, but she also had some weight gain. But otherwise, within 1 or 2 days, the swelling also reduces and the patient is totally fine. There's not much pain also. Some patients have paresthesias, but that's it. And so one is the ease of doing it. Tumescent takes maybe 2 or 3 minutes, and the whole procedure takes 2 or 3 minutes. So in 5 minutes, I'm in and out with one whole cheek side. So if there's an assistant who's preparing the patient and everything is done, then in 5 to 10 minutes, you're done with one side. With if you're doing an 18 gauge needle, would take more time, I'm sure. And the damage is less because of the tumescent anesthesia.
Okay. So interesting, very interesting and innovative things. So we had a very long session. We had our first part, we had some demo for our state QTCon. followed by this XC workshop. I, on behalf of the organizing team of QTCon, the workshop committee, thank all the speakers of the day in the first half and in the second half also. And it was so kind of you, Dr. Dhanraj, and all the other speakers who participated, cooperated, took up the questions. And I think we had a good audience, and you speakers kept them awakened and alive throughout the day. So this is a big thanks from all of us here at SCB Medical College, Cuttack, my alma mater, and great to be back here and for this great dermatosurgery learning workshop. So thank you very much, bidding adieu to all of you, and looking forward to meet you in some another platform and on another day. Thank you very much. Thank you, Dr. Dhanraj.
Thanks a lot, sir. Thanks a lot. Thank you everyone for being there till such a late time.